Okay, good morning. Hello, everybody. Welcome. Welcome to this year's regional event, Linking Hearts. We're so glad that you could all be here today. My name is Tori Temple, and I am the Regional Program Nurse Educator here at the University of Ottawa Heart Institute. We have a wonderful day lined up for you today. It's going to be pretty jam-packed. We're covering a lot of topics and separating them into 5 parts. We're going to start by talking about the patient with valvular disease, and then we're going to speak about the patient with atrial fibrillation. Then we're going to go over some cardiac resources, and then we'll cover the patient with stroke, and then finally we're going to end on the topic of cardiac prevention. Before we get started, however, I do have a few housekeeping items that I must mention. This is a hybrid event, and while it's wonderful to have so many people join us in person, we are also hosting a lot of people online, and we're very glad that they can join us as well. A friendly reminder to please reference and make use of the digital event guide for today's presentations. It was provided to you in a SWAY format. For our in-person participants, we ask that you please put your devices on silent or vibrate mode. Our washrooms are located just outside the auditorium to the left-hand side. And when it comes time for questions or active participation, we ask that you please raise your hand and a runner will come and provide you with a microphone. It's very important that you wait for that microphone to arrive because we do want our online guests to be able to hear the questions. For our online guests, please use the chat to make any questions or make any comments. We have online moderators working hard, so you're not going to be forgotten about. And now I would like to read our land acknowledgements. The University of Ottawa Heart Institute acknowledges the unceded traditional territory of the Algonquin Anishinaabe and the people of the Algonquin Anishinaabe Nation. We recognize all Indigenous people in the region from all nations across Canada who have also made Ottawa their home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. We dedicate ourselves to moving forward in the spirit of partnership and reconciliation. Together, we take responsibility for the heart health of all people in the region. And now, without further ado, I would like to introduce Bonnie Quinlan. Bonnie Quinlan is the Director of Prevention and Rehabilitation at the University of Ottawa Heart Institute. She has extensive experience developing and providing patient education programs based on best practices related to secondary prevention strategies and interventions, as well as integrating patient engagement in quality initiatives. She has held roles within the Institute as the Advanced Practice Nurse for Cardiology, Manager of Cardiac Prevention and Rehabilitation, and is currently my boss. So it is my absolute pleasure to introduce Bonnie today to provide our opening remarks.
Thanks so much, Tori. And actually, it was really supposed to be Bonnie Bowes, my VP and my boss, presenting this introduction today. But unfortunately, Bonnie became ill this morning at the last minute. So I'm presenting on her behalf, and I'd like to recognize that the slides that I'm presenting as well this morning were developed by Bonnie. So I'm going to do my best to do her justice on that. So welcome, everyone. I understand we have over 300 people, well over 300 people registered for this hybrid event. So it's wonderful to see so many people here. So we're going to start just a little bit of an overview of where we are, where we've been with heart disease in Canada and where we're going. So currently 1 in 12 Canadian adults live with a diagnosis of heart disease. Every hour, 14 Canadians die from heart disease. Looking at their mortality rate, that is 2.9 times higher among adults age 20 with a diagnosis of heart disease versus those without. 4.6 times higher amongst adults who had a heart attack versus those without as well. 6.3 times higher among adults aged 40 and older with a diagnosis of heart failure, again, versus those without. However, there is some great news. If we looked at data from comparing 2001 to 2017-18, things are looking better. So the number of Canadian adults diagnosed with heart disease declined from over 217,000 to 162,000 or so. And the death rate, or the number of deaths per 1,000 individuals with a known heart disease, has decreased by 21%. So really good to see. So that means we have a new reality, right, in healthcare, caring for cardiac patients. It means our patients are living longer with more complex disease and more comorbid conditions. And this being primarily due to some amazing life-saving and life-sustaining treatments, including many new drug classes that I'm sure many of you are familiar with, and new treatment. And really, this has resulted in significant changes in cardiac care for our patients. So patients are living longer, requiring a greater focus on secondary prevention measures to help prevent subsequent and repeat events, and also help to improve their quality of life living with these comorbid conditions. And bringing this home to a division I'm responsible for, cardiac rehabilitation program, even in the last 5 years, we've seen a significant increase in the age of patients enrolling in cardiac rehab, a change in patients with increased frailty, and many more complexities. But these patients are enrolling in greater numbers, they're completing the program, and we're seeing outcome measures that are comparable to patients who, with pre and post evaluation metrics, compared to patients who have, we saw maybe 20 years ago, who are younger and much with many less comorbid conditions. So really great news for us in cardiac rehab, seeing these patients do so well. Certainly, technology is enhancing and enabling care, and you're going to be hearing from a few folks this morning that are looking at new forms of technology that we're using to improve our patient access to care. For example, the Nitro app that our cardiology APN will be discussing. And certainly requires a holistic approach, including overall well-being of the patients and their caregivers, is the new expectation from patients and their families. So as a result of the new realities, I know Tori has already talked about what we're going to be talking about today. So basically a list of all the things that speak to this. We're very fortunate too to be having our colleagues from the TOH today, the regional stroke team, with us to talk about the care and the journey of stroke patients, from prevention, inpatient care, and also community supports. Other things that too, in terms of technology, virtual care, telehome monitoring, new research on physical activity, I'm sure you'll find quite interesting, and some novel work the Heart Institute's been doing in relation to the implementation of the new Canadian 2020 adult guidelines on the management of obesity. And lastly, speaking again to that overall well-being, we'll have Dr. Tulloch and Dr. Bouchard here talking about some new resources and supports for navigating heart disease within the family. So please ensure that you're engaging with our speakers today. We want to hear about your knowledge and your insights into these subjects as well. This is all about a sharing opportunity, so we want to hear from you. We're also going to be asking you to give us some feedback on all the day today, and how it can be improved, and also what you'd like to see next year. We do this every year, so please let us know what you like, what you want to see changed, and we'll do it. So great to meet with you, and enjoy the day. Thank you so much.
Thank you very much, Bonnie. So we're going to get our lineup started now with part one, which focuses on the patient with valvular disease. For the following presentations, we're going to do a strange little format. We're going to ask that you hold the questions after each presentation, and then at the end, after everybody has presented, our CCU educator, Christy Strecko, is going to come up with all of our speakers, and we're going to have a little Q&A session. So now I'd like to introduce our first speaker for our valve disease panel. Dr. Christopher Glover is an interventional cardiologist in the Division of Cardiology at the University of Ottawa Heart Institute. He is an associate professor in the Department of Medicine at the University of Ottawa, and he is here today to talk about transcatheter aortic valve implantation procedures.
Thanks for having me, Tori. And we miss you in the cath lab. So I'm dressed like this because I'm actually doing TAVIs today, but I got Dr. Dick to cover me. So thanks for inviting me to talk about this talk. I think that this is, to me, it's very exciting because I think it's the most important thing that's happened in cardiovascular medicine in the last 25 years. So, and I'm just happy to be a part of it. So I know I don't have that much time, so I apologize. I'm going to try to get through as much as I can because it's a really difficult topic to get through in 15 minutes. So, and unfortunately, I won't be here for questions. So maybe we'll have 2 minutes for questions. I don't, it's up to, okay. So we'll talk a little bit about what is severe aortic stenosis, what are the outcomes, what are the complications, and what do we do after if there's problems. And as most of you know, valvular stenosis is a condition in which there's narrowing, stiffening, thickening, fusion or blockage of one or more valves of the heart. The aortic valve is the most common valve to have aortic stenosis. And so it's something that we see the most of in our day-to-day practices. And it's just an example at surgery. So the normal aortic valve area, hopefully that we all have, is about 3 to 4 centimeters squared. And then narrowing can occur with calcification or due to congenital problems. And once it gets less than 1 centimeter squared, symptoms may develop. And so the most common reason that people get this is age-related degeneration. So the most common patients that we see are in their 70s, 80s, and 90s. Having said that, some people who are born with a bicuspid or a unicuspid valve may develop aortic stenosis at a much earlier age. And then we don't see much of this anymore. But back in the day when rheumatic fever was more prevalent, we would see aortic stenosis due to rheumatic fever. So the issue with aortic stenosis is that it prevents the blood leaving the ventricle, going to the rest of the body. Our body wants to keep a normal cardiac output, so it's going to try to generate more pressure. And as it does this, it's going to lead to left ventricular hypertrophy. And over time, that left ventricular hypertrophy becomes pathological, and it causes reduced blood flow to the heart, and eventually causes reduced cardiac output. And this pressure hypertrophy, we get diastolic dysfunction or stiffening of the heart, which leads to myocardial ischemia, which leads to symptoms, and then ultimately death if not changed or fixed. So you guys may see this, and this is just, it's a bit of a busy slide. But the most important thing here is what we look at when we're making a decision whether it's severe, the aortic stenosis or not. We look at the peak jet, and we want it more than 4 milli. And this is something that we see on an echo, so 4 meters per second. A mean gradient, which is either in the echo lab or the cath lab, of greater than 40 millimeters of mercury, and a valve area less than 1 centimeter. So we like to see all three, but most patients haven't read the book, so some may have one and may have not the other. So we have to kind of make a clinical judgment depending on their symptoms and looking at the valve. So symptoms generally only occur with severe aortic stenosis. So if we see someone with aortic stenosis who has symptoms, see someone with aortic stenosis that's not severe with symptoms, we always try to look for another cause. And the main symptoms is, the most common symptom is actually, I have angina here, but it's actually dyspnea. And usually exertional dyspnea is the most common. And then over time, they can develop a heart failure at rest. Also as well, we can see exertional syncope, and occasionally we'll see angina. Although in, what I see when I see someone with angina with aortic stenosis, I usually find coronary disease as well. But it can be an isolated symptom. This is just an homage back to Dr. Higginson, who would probably not be very happy the way we evaluate people today. This is the classic, you don't have to know this, the classic physical exam that we were all taught when we were residents. Now we listen for a murmur, and if we hear a murmur, we get an echo. But don't tell Dr. Higginson that. And these are sort of the classic findings that we used to have memorized and we used to try to look. And I still try to look at this, especially if we're trying to decide if it's severe or not. And this is just a natural history. So before there was any intervention, what happens when you have aortic stenosis and you don't do anything? So this is studies from 50, 60 years ago. And they found that, once they developed symptoms, people would rapidly, unfortunately, die. If they developed angina, it would take about 5 years. About 50% would be dead in 5 years. Syncope, about 3 years, and heart failure, dyspnea, 2 years. So quite a very, very serious and morbid condition that obviously required intervention. And with early on with cardiac surgery, the initial procedures were aortic valve replacement, and studies showed that the natural history was definitely changed. We saw a massive difference, 63% for survival at 5 years versus 22% just even with the early surgical valves. So this showed that fixing this valve would make people live longer. Having said that, though, you know, our society, as we've seen much more lengthening of our life expectancy, and we're seeing a lot more people in their 70s, 80s, and 90s that were never really intended for the original surgeries. We see now in some studies up to 10, even up to 15% of people over the age of 80 will have some type of aortic stenosis. So the rationale for finding some other type of way of doing this rather than open heart surgery is that AS incidence increases significantly with age. The risk of surgery rises dramatically with age, and many and most elderly patients are not suitable for surgery. So if there wasn't something new that came along, we would see a lot more mortality from this. So this led to development of a transcatheter option, and the first one was put in about 22 years ago by Dr. Cribier, and this patient did very, very well, and led to the idea that we can maybe do something for patients who are not surgical candidates. These are just two of the valves that we use today, and I'm just going to talk a little bit about the clinical trials. Not too much, but just sort of give you a flavor of what we do and why we do it. One is the Edwards sapien valve, which is balloon expandable, which is about 90% what we do, and this is the self-expanding core valve, which is about 10%. So the clinical trials were done in a very, very stepwise fashion, and I'll just talk about them first, and then I'll just come back and I'll show the video just after, just so we just get a little sense. And I'll come back to this one later. So I think that compared to anything else we did in medicine, this is done so logically, and if you look at the data, it's so robust compared to many of the things we do, like ACE inhibitors post-MI. The data is nowhere near as robust as this. So first, they looked at patients who were high risk for surgery, looking at whether surgeons would do the procedure or not, and then compared it versus TAVI, then intermediate risk patients, and then low risk patients. And I'll just go through this and then I'll show the video. So this is the first sort of seminal trial, looking at patients who had TAVI and had severe aortic stenosis and not considered surgical. They could not have surgery, but they still had a TAVI. And what they found was dramatic. So still a very high mortality at 1 year, 30%, with the TAVI, but 50% without it. So 20% absolute risk reduction in mortality, which is seen in almost nothing else in medicine. Everything else we do, STEMI, 1 or 2% absolute risk reduction, 20%, quite dramatic. When we look at just high-risk patients who could have surgery, again, significant, this is surgery on the top, and about a 4% difference in mortality at 1 year. We look at, as technology moved on, we got better devices, so our actual mortality and complications went down from transcatheter valves. So they're using the other self-expanding valve, the core valve, and we looked at their high-risk patients. Obviously, their high-risk patients weren't as bad because they were 19% versus 24% mortality. But now we see even a 5% absolute risk reduction in mortality. So even high-risk patients, TAVI is significantly better, and it's not even close. And this changed our practice. We went from anybody high risk, we would not do. This is about 15 years ago. And again, reduction in stroke. One of the concerns about TAVI is that we're popping open a valve on popping a new valve in a calcified valve. We could just fire off little atheroemboli or calcium chunks, and there is actually a higher risk with surgery. Now we look at intermediate risk patients, and I'll talk a little bit about how we grade that. But even in intermediate risk patients, again, difference in mortality and stroke. And finally, when we look at even low risk patients, so people who have a 1 or 2% risk of mortality with surgery, there's still a significant benefit with TAVI when we look at death, stroke, and rehospitalization. So really, it's done in very, very logical, very, very stepwise, and the data is very, very robust that in most patients over the age of 65 who are considering for a bioprosthetic valve, a transcatheter valve is the most obvious choice. And I'll just go back to here, just because I think, and do I have to minimize this? So I just thought I'd show it because I'm not sure anybody's, some of you have been in the cath lab, but I thought it'd be just good to have a quick. There we go. This is actually from Edwards, so I'm not paid by Edwards or anything. So can I see it? I can't see it online.
No.
Oh, okay.
Yeah,
Have to look at it right. Okay. I'll look up here. So this is just a transfemoral, and as you saw in one of the slides, we want to do transfemoral. It's the lowest risk, but in some people with bad peripheral vascular disease, we can go through the carotid artery. We did one of those on Monday. We can go through the subclavian artery. We can actually go transcaval, so we can go through the IVC and then puncture across into the aorta, and then have to put an occluder device in after. And then if none of those work, we actually can do a small cardiac incision and do transapically, or we can actually go direct aortic right next to the aorta. So here we are, we put a sheath that goes into the femoral artery, and now we're passing a wire up. It's usually not as easy as that getting across, but once we get across, we may or may not do a balloon valvuloplasty prior to that. So we put a balloon across, and we pace the heart. I don't know if you can tell here, but we pace the heart about 200 because we don't want that balloon at all. So we balloon it open, and that helps us sometimes if the valve's really, really tight, get that bulky valve across. And then we bring up the valve. This is a balloon expandable Edwards. I said the other one's a self-expanding. Both have excellent results. This is just the valve. This isn't important, but the valve, to get the valve through the sheath, we have to push it onto the balloon after we're in the aorta because we have more room there. So that's just what we're doing there. Just bring it around. So it's quite simple. It's really not, it's not rocket science. And you can imagine, we'll talk a little bit about complications briefly. You can imagine elderly people with calcified aortas, with lots of atherosclerosis in there. We're moving this catheter up there, we can cause problems. So then we just position the valve. And this is actually an old video because we actually don't position it as low as they show on this, but it's not really that important. And then once we don't use an echo or anything like that. We just use fluoroscopy. We inject a little bit of dye, and we make sure where we are. We get it in the right spot. It usually takes us less time than this does, but. And then we pace the heart's doing, and then we just blow it up. And then hopefully there's no complications. So I'll just come out of that then. Anyway, I hope that people. Is that, how do we, can we just, yeah, sorry. Anyway, I hope that just gives an idea. And then it's basically the same whether we go through the carotid or the subclavian or direct aortic, or the only difference is we have to remember when we're doing transapically, because we're coming the other way, we have to flip the valve the other way. We don't want the valve closing as we're trying to get blood out. Perfect. Anyway. All right. Excellent. All right. So, and just this is just a slide showing all the things that I've said that we all the different ways we do. We're probably about 95% though transfemoral, and we try our best to do transfemoral, but some people just have such bad peripheral vascular disease. So the data is very, very clear that TAVI reduces death and stroke, and the benefit is most benefit in the people who are the highest risk for surgery. The other thing I thought that's really, really interesting is that the low risk study, we'll just look at the middle part here. They did a 6-minute walk test, and they looked at the percent difference from their baseline. They did a baseline and then at 30 days and 1 year. And you'll see that at 30 days, there's a massive difference in 6-minute walk distance improvement in the TAVI, but it's sustained till a year, which shows that, we talk about surgery, you're in hospital for a week or two, you're back you're fine at 6 weeks. And this clearly shows that that's not the case. There's still a benefit at a year for ability to do exercise with TAVI versus surgery. So I think that's also a really important thing. And so just to reiterate, massive benefit versus medical and non-operable, high risk, intermediate risk, low risk, there is a mortality and stroke risk. So what confers risk to patients? Obviously age, the older you are, the higher risk. People with chronic renal failure, COPD, liver disease, stroke, malignancy, people who are on steroids, people who are frail, so they can't get up and walk, and anybody with previous cardiac surgery. So that's a lot. Those are a lot of patients. So most of the patients that we see do have some type of risk factors. One of the big unknowns we don't know, and we do know we're learning more and more every year, every day. As every day goes by, we're seeing whether these valves are lasting long. Early on, the question was, are they going to last as long as the surgical valves? And what I would say, we're at a point now that we're definitely able to, we're lasting longer than some of the very poor surgical valves, and we're getting close to probably equivalence to some of the better surgical valves. So it doesn't seem to be that there's any marker at all for valve failure at an intermediate stage that would make us worry about putting it in a 60 or 65-year-old. So what we do, so anybody who's non-operable or intermediate high risk, we will always consider a transcatheter valve. Anybody low risk, I put 65 here, but Sandra, you were at the meeting today. I mean, we're talking about people in their 60s and even people in their 50s, depending on, there's nuances on the size of the valve and possibly other need for other surgery, which does play a role. But I think anybody, really who wants a bioprosthetic valve could be considered for a transcatheter valve. And I think that's important. And then there are some anatomical contraindications. We get a CT scan looking for where the coronaries are and things like that. But very rarely does that happen. It's probably like 1 or 2%. And what's been the most exciting thing that we've seen over the time I've been here is that when we first started doing, I think 2006, patients were intubated, they had an art line, they had a Swan Gans. We do 1 or 2 a day. We wouldn't wake them up on the table. They'd be in CSICU. We'd wake them up after, and they were here for a long time. Now we put them. It's like getting a root canal, or maybe not a root canal, maybe a wisdom tooth out. It's conscious sedation. Some people are sleeping. Other people we're talking to during the procedure, so they won't remember too much because they're getting propofol and a bit of midazolam. We mobilize them 4 hours. We let them eat 2 hours. We mobilize them 4 hours. And some people, the first case of the day, if they're suitable and they're young and they're healthy, they'll go home the same day. And otherwise, most people will go home the next day, no matter what, unless they've been in hospital for a while. So some of the people that we see, they've come in and decompensated heart failure. We've had to diurese them, get them better, and they're here for a week and they get a little bit deconditioned, and we won't throw them out the door on day 2. We'll let them get a little better. And now we do 5 cases a day, and we're usually done by 3 o'clock. And that's a real testament to everybody on the team. Everybody on the team has done such a good job, and especially Sandra and Liz, the coordinators. So who doesn't benefit? And this is a bit of a moving target, because I think, we used to say anybody with moderate dementia. I see the 2 minutes. I think, we tend to give people the benefit of the doubt, and even moderate dementia will do. Anybody with poor 1-year survival. Having said that, if someone just keeps coming into hospital with recurrent heart failure admissions, it may be worthwhile fixing it, and then we keep them out of hospital. And then other poor quality of life, not due to aortic stenosis. I'll just very briefly, complications. These are things that hopefully that we never see, but we do see. And these happens all in the lab. We can rupture the annulus. The valve can rupture the annulus. We could dissect the aorta. As you see, we're moving something around the aorta like that. Depending where the coronaries are, we can occlude it with the valve. We can give a stroke. We can cause problems wherever our vascular incisions are. And then we can get heart block. Everybody gets paced, as you saw. We pace them to rapidly pace so we can implant the valve, but we have the pacer there if they need it for heart block after. One of the things we see after, so the people who work in the reference center or CCU, we do generally, some people not in heart block, they will go into heart block after. Hopefully we've left the pacer in, but sometimes we haven't. Sometimes we do see some strokes. Usually it happens during the procedure, but sometimes it can happen after. And we often see some access site complications, bleeding, ischemia. Renal failure would happen several days. And any mechanical thing, we did have a rupture about a couple months ago, but that's rare, very, very rare. We had about 3 hours later. That's extremely rare. I think it's the only one I've ever seen. Usually that won't happen. We often get hematomas, never infections, or rarely. We often you'll hear bruits because we put ProGlide stitches in that will narrow the artery down a bit. And sometimes we see some issues just with blood pressure and with heart failure, just depending on their medication changes. They're always on aspirin for life unless they have an indication for Coumadin or DOAC. They're on your usual medications and they need endocarditis prophylaxis. As I said, the valve life expectancy seems to be about 10 to 15 years, which is average for a bioprosthetic valve. We see them every year, and they need endocarditis prophylaxis. One of the best things about TAVI is that if the valve fails, and we do this a lot with surgical valves fails, is we can put a valve in valve. So I'm doing one right after this. Somebody's valves failed, I'm putting another valve in. So that's actually quite common now. So the conclusion, obviously, symptomatic severe aortic stenosis requires intervention. TAVI has replaced surgical valve replacement as a preferred therapy, and complications are generally procedurable. I just wanted to highlight all the TAVI team, and I realized I did not put radiology in here, so I hope there's no radiologists who will take offense to this, but they're very, very important to our team. But Elizabeth Murray and Sandra, they do a great job. They're kind of our den mothers and make sure that we're doing our job. We've got awesome nurses and x-ray techs in the lab who do a great job. The cardiology, great group of guys, and the cardiac surgeons, anesthesia as well. They're really a great group of people to work with us. So I'm really privileged to be part of it. Anyway, sorry, I kind of a bit of a whirlwind tour. I hope some of it will stick. Anyway, thank you very much. Okay.
Thank you, Dr. Glover. That was awesome. And having been a part of that TAVI team, it's really something to see. They're like a well-oiled machine, I must say. Obviously, Dr. Glover has to run back to the OR. So for when it comes to Q&A, if you do have questions for him, we can certainly send them his way and get back to you. So next up, we have Dr. David Messika-Zeitoun, who is a non-invasive cardiologist specialized in echocardiography and valvular heart disease here at the University of Ottawa Heart Institute. He is leading the Center for Valvular Heart Disease, and we are very grateful he is here today to speak to us about valvular heart disease.
Thank you. Good morning, everyone. It's supposed to be the first presentation, so I will go first back to the basic. You all know what a valvular heart disease are, disease of the valve, which are directing the blood inside the heart. They can be dysfunctioning by limited opening or limited closing. And the two most common valvular heart diseases that we face in Western countries are aortic stenosis, Chris will talk about that, and mitral regurgitation. They are disease of the elderly. Chris mentioned that. We have seen a marked decrease of rheumatic disease now in Western country, and we are seeing more and more patients with degenerative valvular heart disease, which means related to age. And I will show you as well that we are facing new valvular heart disease more and more frequently. They are related to age, and you can see the marked increase of prevalence of valvular heart disease with aging. Between 65 and 74, prevalence is around 4% and up to more than 10% above 75 years old. And you have all seen this kind of pyramid of age. Our population in Western countries is aging. And so specifically in Canada, it was estimated that in 2016, we had 7 million of people more than 65 years old of age. And it's expected that number to go up to 12 to 13 million in 2060-50. And it has a huge impact on the prevalence. In the house valve studies, they looked at, during family office visit, regarding the prevalence of valvular heart disease in patients that were undiagnosed before with any valvular heart disease. And it estimated that the prevalence was 1.5 million at that time, and this prevalence is expected to double up to 3.3 million in the UK by 2056. And interestingly, you see this red part, most of the patients with valvular heart disease were underdiagnosed. And we have new valvular heart disease, not only COVID, but we have the CMV D20, the TR21, and AFMR22. Just acronyms. What is the first one? CMVD is calcified mitral valve disease, again, related to aging. The calcification of the mitral annulus, the posterior part of the mitral annulus, which extend into the leaflets, causing mitral stenosis and or mitral regurgitation. And we look at that in our own echo lab in 2016, so some years ago. the prevalence of calcific mitral valve disease, so mitral stenosis or mitral regurgitation due to calcification, was 0.5% of all the TEs performed at the Heart Institute, so a huge number. And the problem with calcific mitral valve disease is that we don't have good solutions. Surgery is high risk, and we don't have any easy transcatheter option. Second important rising valvular heart disease is tricuspid regurgitation. It has been assessed in the community, study from the Mayo Clinic, and the prevalence overall is 0.55% of the total population, very high. Higher prevalence in women than in men. And again, you see this high prevalence, increased prevalence with aging. And it is estimated that the prevalence of tricuspid regurgitation is the same now than the prevalence of aortic stenosis. Third disease, atrial functional mitral regurgitation. We used to differentiate mitral regurgitation into two main entities. One is primary mitral regurgitation, which are due to disease of the leaflet or the chordae. So this is abnormal mitral valve. And functional mitral regurgitation, when the valve is normal, but the disease is due to left ventricular remodeling, tracting the mitral valve and impacting the closure. What we see more and more now, it's atrial functional mitral regurgitation. The disease is not caused by the remodeling of the left ventricle, but enlargement of the left atrium, enlarging the annulus and causing the mitral regurgitation. And it's quite prevalent. In this study from the Mayo Clinic, they look at in the community the different entities, and they found that 1/3 of the patients with mitral regurgitation had primary MR, 2/3 had secondary MR. And among secondary MR, approximately 60% were due to LV disease, so ischemic cardiomyopathy or dilated cardiomyopathy, and 40% were due to atrial functional MR. And it's very important because atrial functional MR is linked to atrial fibrillation. You have a session on AFib, and AFib is also a huge burden on our society, very common in elderly patients. So because of aging, you will have more and more AFib and more atrial functional mitral regurgitation. So clearly, valvular heart disease is the next epidemic. It's a degenerative process linked to age, but it's not a random process. There is a pathophysiology behind that. Problem is that we have a better understanding. It's a complex graph regarding aortic stenosis, but the bottom line is that we don't have any medical therapy. There is a link between aortic stenosis and atherosclerosis, but all studies using statins to prevent progression of aortic stenosis has failed. People have looked at different pathways, osteoporosis, vitamin K. All the studies has failed to prevent progression of valvular heart disease. So only treatment we are left with is an intervention. Could be surgery, replacement, or repair, but has to be an intervention, and we have no way to slow down or prevent progression of valvular heart disease with medication currently. And Chris Glover showed you this slide. If you treat patients with valvular heart disease, you markedly improve the prognosis. This study was a high risk or prohibitive risk patient with aortic stenosis, and you can see that the relative decrease of mortality is 50%. Huge. So valvular heart disease are lethal disease if left untreated, and we have no medical therapy. The good news is that we have less invasive options. Chris Glover mentioned the TAVI. In this study, we look at all aortic valve replacement performed in France between 2007 and 2019, and you can see that there is a marked increase in the number of interventions due. It's not due to the fact that, so you can see that there is a slight decrease in the number of surgery performed, but the most of the increase is not due to a shift from surgery to TAVI. TAVI has changed the way we are managing patients with AS. We are now treating patients that had no option before. Most of these elderly patients were left without any treatment, but now with TAVI and other transcatheter therapies, we can treat patients that had no option before. So transcatheter therapy has completely changed the way we are managing patients with valvular heart disease. The three pillars when you want to manage patients with valvular heart disease, you need to screen patients. You need to be aware that your patient has a valvular heart disease. You need to follow the patient carefully, and you need to perform a timely intervention. Are we doing good in clinical practice? Answer is no. In this survey, they ask people more than 65 years old regarding awareness regarding valvular heart disease. And you can see that people are aware of cancer, Alzheimer's disease, stroke, everything else, but only 2% were aware what is valvular heart disease. And the consequence of that is you ask them how often your family physician is listening to your heart. For half of the patient, is a male or female, very seldom or never. And it's a missed opportunity because we know that if we are listening to the heart, you can diagnose valvular heart disease and put that this circle. So patient has diagnosed, have follow-up, and have timely intervention. So lesson number 4, patients with valvular heart disease are underdiagnosed. And critically, they are not only underdiagnosed, they are undertreated. Study from the Mayo Clinic, very famous institution, all patients had an echocardiogram, they have been diagnosed with mitral regurgitation. So patients have severe mitral regurgitation, they have been referred to their family physician, patients have no issue with access to care in the US here, and despite that, only 20% of the patients with a class 1 indication for intervention were not offered any intervention, were only referred an intervention. We look at that in France. We collected all patients admitted with mitral regurgitation in hospital during a 3 years period. You can see that only 8% of the patients got an intervention within a year. And the population was quite old, 77 in average, with 12% more than 90. And a lot of patients had significant comorbidities. This is the population we are facing now. An impact of the patient medically managed, quite poor. Mortality at 1 year, 14%. 2/3 were either dead or readmitted at 1 year, and 1/3 either dead or readmitted for heart failure at 1 year. And it's true for primary as well as secondary. When you want to convince people, it's always easy to talk about money. If you evaluate the cost during a year of mitral regurgitation in France, we estimate that between 350 to 550 million euro per year, and only for mitral regurgitation. It's a huge burden on the society. And patients are also referred very late in the course of the disease. This STS database, US, you can see that 50% of the patients presented with an history of heart failure, so late in the course of the disease. They have reduced ejection fraction. They have a high systolic pulmonary pressure. Patients are referred late in the course of the disease. And it's a registry we have done in Europe across 23 centers a few years ago. And you can see again, we confirm that patients are referred late in the course of the disease. Regarding undertreatment, we look at that in another valvular heart disease, tricuspid regurgitation. We collected all patients with tricuspid regurgitation admitted in France during 2 years. Population were quite old, again, 75 to 82% had prior cardiac history of surgery, combined with mitral regurgitation was very often. Only 10% of these 17,000 people get an intervention. Even patients referred for surgery for mitral regurgitation. They have mitral regurgitation and they have tricuspid regurgitation. In 1/3 of the patients, the tricuspid regurgitation was neglected. And the vast majority of patients are conservatively managed, and you can see that outcome is not good. Again, 5% in hospital mortality, 17.8% 1-year mortality. And despite I show you the high prevalence of tricuspid regurgitation, in France, only 120 patients per year get an intervention for just the tricuspid regurgitation per year in the country. So valvular heart disease are undertreated and patients are referred late in the course of the disease. There is also inequality of treatment. In this other study, we looked at patients referred for mitral valve surgery, either for primary or for secondary. We showed that, as was expected, mortality is higher for secondary mitral regurgitation than from primary. It's higher when you do combined surgery, compared to when you do an only mitral valve surgery. It's higher when you do replacement compared to repair. But what is striking is inequality regarding mitral valve repair. Even in the best subset, patients have no comorbidity, Charlson score of 0. They are less than 60 years. You can see that repair rate in degenerative mitral regurgitation was only 84. And what is even more striking is that there is a big difference between male and female. It's not due to anatomy. Why female get rates of repair of just above 55%. And this inequality was observed irrespective of age. Low rate of repair and lower rate in male than in female than in male. And this inequality has been referred to the lottery of mitral valve surgery. Depending on where you are at, you can get a repair or you get a replacement. And this sex disparity has been confirmed in the aortic stenosis study from Quebec. They have seen, you can see here, that the mortality of women with aortic stenosis is lower than the mortality of men with aortic stenosis. And one of the explanations is that women are less referred for an intervention than male. And there are also country-specific issues. In this graph, you can see that access to TAVI is lower in Canada than in the US. The good news is that we don't pay much attention to the income of the patient compared to the US. We don't treat based on income, but we have less access to new technology in Canada than in the US. So there is significant inequality in the treatment provided with patients with valvular heart disease. So in summary, valvular heart disease are undertreated, underdiagnosed, and patients are referred late in the course of the disease, which has a huge impact on mortality, heart failure, stroke, and arrhythmia. And even if you do an intervention late in the course of the disease, you never restore the life expectancy compared if you do the intervention earlier in the course of the disease. So what can we do? There is an urgent need to change the management of patients in Canada and in many other Western countries regarding valvular heart disease. We need to develop new screening methods. We need to develop referral pathways, and we need to improve centers of excellence. Raising awareness. You have seen all these campaigns regarding stroke, Alzheimer, breast cancer. Nothing on valvular heart disease. In one of the studies I done in France that I showed you, we estimated the prevalence and mortality of mitral regurgitation compared to breast cancer. Number of deaths due to MR is very similar to the number of deaths to breast cancer. And despite that, you don't see much awareness for valvular heart disease. In 2022, with the Canadian Cardiovascular Society, we have developed a working group to tackle some of this issue, raising awareness, developing new referral pathways, and improving screening at the family physician office. We have developed some of the campaigns. You have the Heart Valve Disease Day, Heart Valve Disease Week. One is in February, was in September. Some of the key message is detection. You need to ask your family physician when you are more than 60, 65 years old to listen to your heart. We are also highlighting that we have new treatment options for patients that are elderly and with valvular heart disease. You need to educate. I showed you the survey done in the population. This survey has been done in physician. It's not only family physician, cardiologist, even cardiac surgeon. One of the results of the survey is to show that, again, family physician and physician don't listen to the heart of their patients. But what was interesting as well is that the knowledge of most of the physicians regarding the management of valvular heart disease is relatively weak. So we need to improve the knowledge of our treating physicians. We need to implement valve clinics, the new referral centers and pathways. And why is that? Because timing is key. You may not be familiar with this kind of economic curves. It's called marginal gain. It's what kind of effort you need to do to improve outcome. Could be how much money you put to improve the quality. You have to spend a lot of money to improve the result of interventions. Doesn't mean that you don't have to do it, but you spend a lot, you gain little. If you want to have a huge impact on healthcare system, what is important is to do timely intervention. Again, you can only do timely intervention if you screen patient, you detect them, you follow them. And it's even more important that we have more and more evidence showing that even asymptomatic patients with significant valvular heart disease, so AS and mitral regurgitation, might benefit from an intervention even if they have no symptoms. Waiting sometimes for symptoms, waiting for triggers can have a huge impact on outcome. So this is true for AS, it's true for MR. And so at the Heart Institute in 2019, end of 2019, we have developed the Center for Valvular Heart Disease. Cindy Cross here is our manager. And we are doing now more than 2,000 visits per year. We try to coordinate everything same day. So patient arrive, we do blood work, we do ECG, we do echocardiogram. We ask the patient to be part of our research program, and they are seen either the same day or the following weeks. Early detection and diagnosis. I don't want to go too deep into that. Sandra will present our new mobile screening program. I'm done here. I hope I've convinced you that valvular heart disease are silent killers. And I took the quote from Saint-Exupéry, showing that heart is very important and you need to detect patients with valvular heart disease to do an optimal treatment. I thank you for your attention.
Thank you very much, Dr. Messika-Zeitoun. That was super interesting. I'm sure people are gathering their questions for our question and answer period. So next, I would like to introduce Sandra Wong, as Dr. Messika alluded to. She's currently working as a nurse specialist in the Center for Valvular Heart Disease here at the University of Ottawa Heart Institute. And having recently moved out of my current position, for which she set a very high bar, she now plays a huge role in running the mobile screening program clinics, which she is going to talk to us about today. Please welcome Sandra Wong.
Thanks so much, Tori. Thank you, everyone. It's a pleasure to talk a little bit about our Center of Valvular Heart Disease, particularly our mobile screening program, MSP. So just briefly, I'm going to outline the reasons for the development of our program, as well as share a little bit of what it is, how it is that the mobile screening program works. So as you've just heard from Dr. Messika-Zeitoun, that a lot of our valvular heart disease is really often underdiagnosed, undertreated, referred late in the course of disease. So really it's important to screen early and also refer early and treat the valvular heart disease in a timely manner. So that's the impetus for our mobile screening program. So what it is, it's all part of the Center of Valvular Heart Disease, and it's a community outreach that offers free clinic of valvular heart screening. And it also includes a cardiovascular risk assessment. So who qualifies? So anyone who's 65 and above without a cardiac history can participate. So that means that they don't have any known heart disease. They can't be followed by a cardiologist, and they can't have had recent cardiac conditions. So like CAD, arrhythmias, and they can't have had cardiac surgery as an example. So how does it work? Well, participants get an ultrasound of the heart or point of care ultrasound or echocardiogram, and it's about 5 to 10 minutes. It's done by our registered sonographer. And then participants also get a point of care testing for their HbA1c as well as cholesterol. And with the nurse, they'll also review other relevant cardiovascular risk factors. And at the end of the visit, participants get all their results from the testing. So here's a photo of how it all looks in clinic. So on the right-hand side, this is actually a photograph of our sonographer with the participant. And using iPad technology, as well as the echocardiogram probe, we can actually visualize the heart valves. And we can see whether it's opening and closing properly and detect any valvular issues or non-valvular findings as well. And then on the left-hand side, this is sort of what it looks like with the nurse. So we do a cardiovascular risk assessment. We ask them questions. We do their blood pressure. And with point-of-care testing with our Abbott Affineon product, we can actually test for their HbA1c and cholesterol. So what does our POCUS look for with our participants? So the sonographer is going to look for any significant valvular abnormalities. So any moderate to severe aortic valve stenosis or regurgitation, any moderate to severe mitral valve stenosis and regurgitation, and any tricuspid regurgitation. Some of the other non-valvular abnormalities that we might note are things like left ventricular dysfunction, any wall motion abnormalities, any right ventricle dysfunction as well. Sometimes we also can potentially catch any pericardial effusion, enlargement of the aorta, as well as any congenital abnormalities. So how does it work when our sonographer finds something? Well, here's a little diagram of sort of the algorithm. So when we find valvular heart disease, any of the moderate or severe that I just noted, there's an automatic referral to our CVHD clinic. And they also get a formal ultrasound. So the one we do is only 5 to 10 minutes, but the formal ultrasound is about 30 to 45 minutes. And they get seen by our cardiologist here at the CVHD clinic. If we find any non-valvular echocardiographic abnormalities, if it's urgent, we have some criteria of what's urgent, semi-urgent, non-urgent. But if it's urgent, we'll actually send them to the emergency department so that they get care seen right away. Semi-urgent, we do an automatic referral and we send them to their primary care provider and we ask them to do a formal ultrasound. And they also can get referred to our rapid access clinic. If it's non-urgent, we also just refer to the primary care provider. For uncontrolled cardiovascular risk factors, so those things we look for: uncontrolled diabetes, so high HbA1c, unmanaged cholesterol levels. If there's high blood pressure, we all look at those things as risk factors, and even smoking is in there. And if it's uncontrolled or not managed, we actually bring it back to their primary care provider's attention, or if they don't have one, we actually refer them to a local walk-in to get seen. So a big part of the nurse's role in the mobile screening program is to provide education. So we give them all sorts of information. So things like the top tips for healthy eating, exercise, managing stress. We have, a tip sheet about blood pressure measurements, heart healthy living booklets. We really try to capitalize on a lot of the resources we already do here at the Heart Institute to share with our participants in the mobile screening program. So who's involved? This is our MSP team, and Dr. David Messika-Zeitoun is our director. Our manager is Cindy Cross, the APN, and myself, Haley, and Ruth are the nurses that are involved. And we also have a lot of registered sonographers from our Echo Lab here that are participating. So Addie, Sam, Dua, and Amy, as well as Edgar. And we also have lots of administrative support, booking, calling people, Donna, Emma, Taya, and Katie. So it's really a whole team that's behind the mobile screening program. So what are the supports? How did we get to where we are today? Really is from some generous funding supports from BI as well as Ontario Health. We also got the UHI Magnum grant as well as Edwards grant that have really helped facilitate the development and sustaining the mobile screening program. So how do we recruit participants? So one of my key role is to liaise with key community leaders to introduce the program. And I talk with them, I tell them what the program is, and we make arrangements to see if we can host the clinic in their space. Other times, we also host the clinics in public spots like Carlingwood Mall, other places that are very public, and others they just call in and we can get them in those public spots. Other times we're advertising on radio, paper posters, Facebook posts about our program with certain community groups, and that's how we get interest to hold the MSP program in their area. And we really try to also target certain population groups where they're more at risk for valvular heart disease or cardiovascular risk or cardiovascular disease in general. So we also look at ethnic groups, Indigenous groups, that are perhaps at more risk. In terms of what we need, we are truly mobile in the sense that we're portable and we use any space that's given to us. So we just need 2 rooms, one for the ultrasound to be performed and one for the nurse to do the assessment. We obviously need electricity, washroom. It has to be generally accessible for everybody. And once we've made the kind of arrangements and talks, we actually book the interested participants into the program, and we actually also book it into our Epic EMR and just so that there's a record. And we also leave some spots for interested participants to walk in. Typically, we do about, for an MSP day, we do about 20 participants a day from 8 to 4 p.m. So how do we get around? Well, this is a little image on the right of all the ways we carry our stuff. We actually bring a lot of belongings with us. We have things like massage table, stool, you know, all the iPad and ultrasound probe. We bring our blood pressure machine, and you can see a lot of education materials, wipes, drapes, tablecloths, all of that. And these things are secured in our in a room by the loading dock here at the Heart Institute, and staff essentially load all the equipment up in their vehicles and they drive to those sites. And once the clinic is done, we bring it all back here to the Heart Institute. So really, we try to do regular checks, make sure all our supplies are replenished and maintained as they should. So what have we seen with our mobile screening program as initial outcomes? Well, it's been about a year, and it's actually been a great success. We started in May last year in 2023, and up to this year in March, we've actually done 47 clinics, and we've actually done also a special focus on underserved, vulnerable populations, rural and Indigenous populations as well. The average age of participants who come are 75 years old, 72% are female, and 28% are male. And actually here on the left-hand side, you can see a little map of some of the areas we've been to. It's mostly in Ottawa, but as you can see, we've also gone outside of Ottawa to Kemptville, to Osgood, to other kind of more rural areas. So the other kind of outcomes is that from May last year to March this year, we've done 749 participants. So 66.1%, so 51 participants have been diagnosed with valvular heart disease and actually referred to our CVHD clinic and being seen by our cardiologist. 8.5% of them we have identified non-valvular findings. And of course, those are either seen in our rapid access clinic or in our emergency or dealt with by the primary care provider. And then actually, astoundingly, 34.8% of participants were referred to their primary care provider or walk in for uncontrolled cardiovascular risk assessments. So really all this to say, we're seeing outcomes of both valvular heart disease, identifying them, but also identifying really uncontrolled and unmanaged cardiovascular risk factors. So what have our participants said about our program? Really, we included some questions about participants' experience with heart auscultation, as well as their screening of cardiovascular risk factors with their primary care provider. And we also asked them for feedback about their clinic visit with us at the mobile screening program. And we've done 112 surveys so far within that 6 months time frame. And like Dr. Messika mentioned in his presentation, most of them didn't really have their doctors auscultate their hearts. So a lot of the feedback that we got from our surveys was that the program has really increased their understanding of valvular heart disease as well as cardiovascular risk factors, that we gave them clear recommendations and they kind of understood more about how valvular heart disease can affect them. And almost 100% of them would recommend this program to a friend or family member. So what happens after their mobile screening program visit is that they get a follow-up call. A follow-up call is made at 6 months and 1 year following the visit. And we have a script and we ask participants if they follow through with their recommendations made during the visit. And we also document it on our Epic EMR. So what's next for our mobile screening program? Well, as you can see here, the dream is a bus. We hope to be truly mobile in the way that we're going to different locations and being really accessible to our community. We hope to have an area of the bus that's for the sonographer to do the point of care echocardiogram, and then another area of the bus to also include the nurse's assessment of the cardiovascular risk assessment. So that's the goal and dream, and we continue to look towards that that goal. All right, thank you so much for your time. For more information, you can scan our QR code about our program.
Thank you, Sandra. That was great. And Sandra's also set up with Cindy over in the corner on our breaks. If you would like to go talk to them and learn a little bit more, please feel free. That was wonderful. So next up, it's my pleasure to introduce Dr. Lawrence Lau, a cardiologist here at the Heart Institute and an assistant professor in the Faculty of Medicine at the University of Ottawa. Dr. Lau is here today to speak about one of his research interests, endocarditis.
Thank you, Tori. And thanks to the organizers of the symposium for inviting me today. So yeah, my name is Lawrence Lau, and again, my interest is in infective endocarditis, which is, you know, a less glamorous topic, but something that I have very excited to talk about. Just, you know, generally my objectives are to review the diagnosis, principles of treatment of endocarditis, as well as sort of a new approach to treating and managing endocarditis, which is through the heart team. And then last but not least is hearing about a patient's perspective on being diagnosed and recovering from infective endocarditis. So I'd like to start off with just a couple of illustrative cases for you to consider. So these are real cases. This is a 50-year-old gentleman who was previously healthy, came into the emergency room with infectious symptoms as well as heart failure symptoms, history of recent dental cleaning, and then blood cultures in the ED showed viridans streptococcus in multiple bottles, and the echo, as I've shown you here, shows a aortic valve that is has these vegetations on them, and the valve's leaking a lot as well. So this is sort of classic endocarditis. Hopefully you can appreciate, and the treatment is, you know, surgery. So pretty relatively straightforward for the medical team. But then I want you to also consider a different case. So this is a 35-year-old woman, presents to an outside hospital with a history of injection drug use, who's actively injecting, presents to hospital confused, and her blood cultures show many different organisms. She ultimately is diagnosed with endocarditis of her pulmonic valve. As a consequence of that, her right ventricle is no longer working well. In addition to that, just to complicate things, her capacity to consent is in doubt. So you can see that this is a very different case, you know, quite a bit more complicated. It required a lot of kind of thought in terms of what to do. So there's a big spectrum of endocarditis, but ultimately the pathophysiology is, you know, starts out very similarly. You have to have a combination of kind of factors that all kind of coalesce. But it starts with endothelial injury, which is damage to the endothelium of the valves themselves, and sometimes this is related to intervention, you know, for example, TAVI. Sometimes it's related to inflammatory material that people inject. And then on top of that, you have bacteremia with an organism capable of attaching to the damaged endothelium. So, you know, for example, this is viridan strep. And then the bacteria proliferates or grows within a protective matrix, and that forms the vegetation, which is the mass that we see on the valve. And then lastly, sometimes when the vegetations are big enough, or they embolize or disseminate and cause problems in other organs. The epidemiology of endocarditis has changed over the past 100 years or so since it was first described. Historically, these are patients with rheumatic valve disease who had poor dentition, and classically they're infected with viridans group streptococci, which come from the mouth. However, in the present day, population with endocarditis is quite a bit different. You have patients who have prosthetic material, such as TAVI valves or implantable cardiac devices like pacemakers, who also have indwelling catheters, which are the source of these organisms. So more commonly, what we see is Staphylococcus aureus from skin, which is a lot more virulent, a lot more destructive than other bacteria. The risk factors of endocarditis are multiple, as you can see there, but probably the highest risk is patients who've already had endocarditis. So if you've had endocarditis before, patients should be particularly vigilant for the symptoms of recurrence. This is a very chaotic slide. I apologize, but this kind of just highlights the variable nature of how endocarditis presents and explains why it can be quite difficult to make the diagnosis. And registry data shows that the most common symptoms are fever, murmur, and heart failure, which are quite nonspecific. But I tend to think about endocarditis as grouped into basically four different categories of presentation. So first you have the infectious symptoms like fevers, chills, malaise, weight loss. You can also have symptoms potentially of local destruction. So if patients have significant valve regurgitation, they can have heart failure symptoms. Sometimes you can have conduction system disease related to block from abscesses that develop. The third category are these dissemination kind of events, which we call embolic events. So patients can present with strokes, can present with infarcts to various organs, as well as what we call splinter hemorrhages, which I'll show you in the next slide. And then sort of in the other category, rarely patients can present with immune-mediated complications, as well as what we call mycotic aneurysms, which are kind of weakening of the vessels and typically the brain, which can lead to bleeding. Oops. Okay. So yeah, major group are these vascular phenomena. So I mentioned splinter hemorrhages, but these are what we call Janeway lesions on the hands and feet, as well as on the conjunctiva of the eyes. More commonly, we pick these up radiographically. So when we do CTs, screening CTs, we see that we see evidence of endocarditis there in various organs. This is an example of a coronary artery embolism. You can see here that in one of the diagonal arteries, there's a blockage here, which was related to endocarditis. Just quickly, there are immune related complications that we see less often these days, but they include Osler's nodes, which are these painful nodules on the hands or feet, these raw spots, these sort of red spots here on the fundus of the eye, as well as glomerulonephritis, which can cause acute kidney injury. The diagnosis is tricky. We have these criteria called the Duke criteria. They include both major and minor criteria. Major criteria include microbiologic evidence as well as imaging evidence of endocarditis, and then minor criteria basically are the symptoms that patients present with. And you have to have a combination of these two groups to make a definite or possible diagnosis. Diagnostic testing, first line, is typically transthoracic echocardiogram. So this is one of our sonographers scanning a patient. Again, just as sort of Sandra mentioned earlier, this is the exact same modality of imaging. But when we can't see as well, or when we don't see anything and the suspicion's high for endocarditis, we move on to do what's called a transesophageal echocardiogram, so an echo through the esophagus to image the heart from the posterior side, because you can see structures much better. It's sort of a semi-invasive procedure, conscious sedation, so there is some risk to it, but the benefit is we know what's going on. more and more, we've employed multimodality imaging like CT and leukocyte scintigraphy and FDG PET. CT provides information about abscesses and paravalvular destruction when we can't see so well in the echo. And PET and WBC scans provide sort of functional information. If we're not sure if something's infected, we can do this scan and it gives us an idea if there's metabolic activity around the area of concern. The principles of treatment include are sort of fourfold. First, you want to make sure that the patient's admitted to hospital to expedite the investigations and to start antibiotic therapy quickly. And antibiotic therapy is always intravenous, at least to begin with. There's been data to show that early switch to oral therapy is non-inferior, but we're not quite there yet, at least in practice. Some patients require surgery to completely eradicate their infection, particularly if there's valve destruction or if there's an abscess. And then after the infection has been well treated, prevention is also extremely important. In my valve clinic, I like to remind patients to tell their dentist about their previous episode of endocarditis, or if they've had a heart valve replaced because they need prophylactic antibiotics. I remind them to get their teeth cleaned every 6 months at least, and to maintain good daily oral hygiene. And equally importantly, just be aware of the symptoms of endocarditis, which can be very nonspecific. And really the first point of contact should be a blood culture if there's suspicion, because a positive blood culture in the right context does kind of initiate a cascade of investigations. Yeah, so just briefly, what's new in endocarditis? This is sort of probably the one of the few new things. Endocarditis is a very old disease with very few kind of changes in how we treat it, but something that we've started doing in the right patients are this percutaneous vacuum-assisted removal, where we introduce a catheter into the heart and basically grab the vegetation and pull it out with this sort of vacuum suction device. It avoids having surgery for patients who are too high risk for whatever reason. But routinely, we do still say that surgery is the mainstay of therapy when indicated. I wanted to highlight in the last few minutes just the role of our heart team. The endocarditis heart team was formed a couple years ago, and we've discussed several hundred patients on the team. The team consists of several cardiologists, cardiac surgeons, infectious disease experts, microbiologists, a nurse specialist. You can kind of see all the people who are involved there, and then we get neurologists, addiction specialists, and other specialists involved as needed. We meet weekly on Microsoft Teams, and we present the cases, we show the images, and the reason why is we really need to integrate the clinical story as well as the imaging together to make a diagnosis. You really can't make the diagnosis just based on one or the other, and these decisions are very complicated. So we found that this is a great way to manage sometimes very complex cases. Indications to refer to the team are if you're not sure about the diagnosis or treatment, or you have a high index of suspicion and you really want to expedite the transesophageal echo. We've done that as well. However, just the caveat is that the discussion shouldn't delay treatment that's already established. Like, we don't want to delay surgery for someone who clearly needs it. So lastly, but not least, I want to highlight one of my patients who's kindly agreed to participate in today's Q&A. So Sarah, she's an active, so I'm going to talk about kind of before, during, and after the diagnosis of endocarditis with slides that she's helped me prepare. So Sarah, before her endocarditis diagnosis, she's an active 51-year-old, married, mother of 3 sons, worked as a full-time senior manager with a Crown Corporation, so really, you know, like any one of us. However, a couple years ago, she developed sort of non-specific symptoms. So they included low back and hip pain, thirst, dry mouth, sore spots in the toes, fingers, and scalp, irregular periods, night sweats, hair loss, weight loss, and fatigue. This was sort of during the summer. Didn't really know what was going on, so she went to the emergency room in July, and ultimately the diagnosis that was made was possibly appendicitis, although the CT scan at the time didn't show that. So she was sent home with these sort of lingering symptoms, and a couple months later, she awoke with sort of startling symptoms, unable to feel her right foot, unable to speak. And so her husband called 911, and she was taken to the hospital. And unfortunately, she was found to have a new stroke as well as a blood infection. So from there, the diagnosis of endocarditis was made. She underwent surgery for a brain aneurysm, followed by open heart surgery a few days later to replace and repair 2 of her valves. The recovery, fortunately, was quite good. I'm sure she can talk about that personally in the Q&A session, but she underwent intensive stroke rehab at Briere. And then since March of last year, she's participated in a number of resources that we offer here at the Heart Institute, including cardiac rehab, Women at Heart, which is a support group for women with heart disease, mood and coping, outpatient speech therapy, and psych counseling. And today, happily, she's resumed most physical activities, and she's been cleared for travel. And she hopes to travel to Florida in November and visit some family abroad hopefully soon. So, you know, this is an ongoing kind of, I mean, it's been treated, but, you know, as I said, we want to keep vigilant for any recurrence of endocarditis. So, you know, and monitor her valve. So she'll be having regular echoes to review her mitral valve, and she'll see me in the coming months. Good. So with that, I'd like to close and thank you for your attention. If you have a patient with endocarditis who you're worried about or want to refer to the heart team, this is the contact information for for Ruth Colton, who's the advanced practice nurse who works with me to manage the heart team. And then if you have a patient with endocarditis who needs to be followed as an outpatient, then you can refer directly to me as well. Great. Thanks for your attention.
Thank you very much, Dr. Lau. So following our next presentation, we're going to have our Q&A period when all of our speakers are going to come up and join us here at the table. So have your questions ready for that. But for now, I would like to introduce Kathryn McLean. She's our nurse coordinator for the Thoracic Aorta Clinic, and she's here today to speak about the post-operative care for our valve patients.
Good morning, everyone, and I'd like to thank the organizing committee for inviting me today to share my experience and information regarding the patient who has undergone heart valve surgery. I just thought I'd do a bit of an overview and probably you've heard much of this morning, but just sort of as a lead into how the patient progresses through their surgical experience. As you know, we have many choices for patients. We have tissue or bioprosthetic valves. We have mechanical valves. We also have autograft valves, which is the Ross procedure that is offered here at the Heart Institute, and the human allograft, which is not a procedure that's done very often anymore, but was previously. So there's many pros and cons to the type of valve that a patient will choose. With the tissue or the bioprosthetic valve, we know that their durability is about 10 to 12 years, and that depends on the age of the patient. It's the length of durability increases as the patient ages. There is no anticoagulation required for these patients. And as a consequence of that, there's fewer lifestyle changes. So they're a good choice for patients, depending on what their lifestyle is, what their occupation is, that sort of thing. With the mechanical valve, we know that in most cases it's an indefinite lifespan. And that's very intriguing to a lot of patients because they, they hear the fact that they might not require surgery at some point. So that's very attractive. It does require a daily anticoagulant to be taken. And of course, INR management that goes along with that. With the mechanical valve, there are lifestyle changes that have to be considered, such as diet changes, alcohol, and any sporting or types of activities that may have caused trauma or injury to the body. Just a picture here showing a tissue valve replacement. So tissue valves are made up of animal parts. So you can see there that the tissue is in the center of the valve there. And the next slide I have is a mechanical valve showing the metal components made out of metal and carbon components in the middle there. Here at the Heart Institute, and particularly in the aortic clinic, our go-to or our first offer for patients who are suitable candidates is an aortic valve repair. And this is Dr. Budwani's specialty. So until he came back to the Heart Institute in 2009, it was not offered here. So this is a wonderful a choice for patients. As I said, it's a newer option. It's now not as new because it's probably 20 years plus where people have been, or doctors have been performing this procedure. But it's a great option. It's so far proving to be quite durable. Patients do not need to take a long-term anticoagulant. And so there's not a lot of lifestyle changes, and their quality of life can pretty well remain status quo once they recover through the surgery. We also offer the Ross procedure, which some of you may be familiar with. It's a double valve procedure, which again, this is a procedure that's performed by Dr. Budwani. And this is where the pulmonary valve is relocated to the aortic valve position. And then we obtain a pulmonary homograft, which is then sewn into the pulmonary valve location. So it's recommended for patients who have severe aortic regurgitation or severe AS, and some of them have mixed valvular disease. It's a preferred option for young patients, particularly children have it, and we use it here for younger adults. So if a patient is a suitable candidate, usually they're in their 20s to sort of 50, 55-year range at the most. So we know that there's a lifespan of about 15 to 20 years. There's no anticoagulation required if people have the Ross procedure. There's low risk of valve-related events. And as I said, with the other procedures, few lifestyle changes. The disadvantage of the Ross procedure is that there's a higher operative risk, and that's because you're going from a one valve to a two valve procedure. With the Ross procedure too, the availability of the homographs for us sometimes affects the ability for us to offer it, because obviously we have to find the right size of homograph for the patients, and so that dictates, how quickly and efficiently we can get this procedure organized for the patient. So in terms of the preoperative care, we see patients in clinic and we discuss and assess their valve disease and their symptoms. My role in that consultation is providing a lot of education to the patient and the family around what the disease is, what the symptoms are, and what to be looking for as they're waiting to proceed to surgery. We complete a diagnostic workup and a pre-admission unit assessment. The surgical options are discussed with the patient. And again, we go through like the pros and cons of the different valvular options. And this is a big decision for patients because, as I just previously mentioned, there's, you know, some valves offer longevity where others offer better quality of life, perhaps, right? So depending on the patient's age and all those factors, it is a big decision for people. And oftentimes they go home and think about this, talk about it with their family. They don't make that decision on the spot. We also use our patient partner program here at the Heart Institute, where we have patients who have experienced cardiac surgery or valvular surgery specifically, and we can connect those patients with our patients, and they offer an immense source of support and information for the patient. So that's a wonderful program we have. Post-operatively, immediately post-operatively, these patients are managed the same as any of our other surgical patients. So, you know, their wound care, sternal precautions, mobilizing the patient, working with physio to get their physical activity back up to their baseline, hemodynamics, pain control, and initiating their anticoagulation as indicated. These patients also have a tendency for atrial arrhythmias post-op, so we have to be on the alert for those situations as well. Now, the patients who require anticoagulation, as I mentioned, those are the mechanical heart valve or replacement, but the other patients also require aspirin in the short term. And I have a slide, the next slide will show us the chart here. So a lot of questions come back to us about, you know, what should a patient be on? What's the time frame? That sort of thing. So in terms of the tissue valve, lifelong, these patients are going to be on 81 milligrams of aspirin once a day. And many of them are on warfarin for 3 months. However, this is doctor dependent, I find. It is in the literature saying that they should be, but some of the doctors are more conscientious about that and others not so much. But so that's good. Even though they're on it briefly, we can reassure the patient that it's not a long-term thing. And DOACs or other oral anticoagulants are not acceptable. In terms of the mechanical replacement, they're going to be on an aspirin 81 milligrams as well and lifelong warfarin. And of course, the dose will be variable based on their INR results. For the aortic valve repair, there is no warfarin required, but they will be on an aspirin 81 milligrams for 1 year. And after that 1 year, then they're on no antiplatelet or anticoagulation at all. With the Ross procedure, again, it's the same as the repair. So 1 year of the aspirin 81 milligrams, and then no warfarin is required. And after that year, they're free of any blood thinning medication. INRs in managing the Coumadin dosages and the INR blood work. Again, questions come to us from the community, nurse practitioners and physicians, just because there have been some changes in the last few years. So with the mechanical valve, at the current time, or for the last few years, we've been using the Onyx valve, which is a Medtronic product for the aortic valve. And it's important to note that for the first 3 months, their INR needs to be between 2 to 2.5. After that 3-month period, we can then drop the INR to 1.7 to 2.5. So this is great because it means a lower dose of Coumadin for the patient, and we're always happy about that. The mitral valves continue to be at 2.5 to 3.5, and that's lifelong. There's no changes after 3 months. With the tissue valve, we're using the Carpentier-Edwards tissue valve. And for that 3-month period that I mentioned that the patients usually are on warfarin, they have an INR approximately 2 to 3. And again, as I mentioned, that is physician dependent. The other key point following valve surgery is antibiotic prophylaxis. I think we err on the side of caution a little more than maybe what you might read in the literature. With the Canadian guidelines, antibiotics are required for pre-dental treatment for all patients who've had a replaced valve of any kind. We also request the dentist provide antibiotics for any of our valve repair patients as well. And it's just, as I said, sort of we're erring on the side of caution because as Dr. Lau, who's just spoke before, endocarditis is a life-threatening situation for many patients. So taking an antibiotic 1 hour before, for us, it outweighs the risk of developing an endocarditis. So we do recommend it for the valve repairs. We also recommend it if people have had a Ross procedure, which is the double valve replacement we mentioned. And in terms of other invasive procedures, like we get a lot of calls, I'm having a colonoscopy or I'm having some kind of, minor surgery, that kind of thing. And so it kind of depends. I'll usually ask the doctor who's caring for the patient, this is the invasive procedure they're having. And so then we'll, make a decision whether they need to be protected with an antibiotic. So, but that we that's another area that we have to be very cautious about. So in terms of the patient's education, we're involved in the, instructing the patients about what their wound should look like, what the signs and symptoms of infection are. We want them to mobilize following their surgery, and they should be following the exercise program that they leave here with. And then following that, they are connected with our cardiac rehab program, which will take them going forward to get them back to their baseline. Sternal precautions we're always reinforcing, the use of or lack of use or restrictions with your arms and lifting and that sort of thing. We just talked about anticoagulation and INR management, so that's a very important piece, and can't stress it enough that when people make this decision, they need to know that this is a lifestyle change. There is blood work that has to be done on a regular basis. There's a medication which has to be taken on a daily, it's very strict regime. So, I've had patients that, just don't go for their blood work, or, I forgot to take my warfarin yesterday because I'll see a drop in their INR. And you just can't stress enough the importance to them that this is a life-threatening event if they don't take this medication on a regular basis. And we just talked about antibiotic prophylaxis. And again, that's also very important that patient understands the importance of that. And for patients who have a mechanical valve and are taking warfarin, we do recommend a medical alert bracelet or a necklace or chain, whatever. I think they have some different options now, but some kind of identifier so that when they are in the community, if anything happens, they have, the bystander can recognize that this is what they've had done. I'm not as strict on it with the tissue or the other procedures. When you're not, it's the warfarin that I really want the people to, be able to identify. Resources that our patients have once they leave following their surgery. They're all given the cardiac surgery discharge book. This is also available on the Ottawa Heart Institute website. So, patients there's all kinds of resources. They can read all this stuff even before they have their surgery. So it's all out there. There's the preparing for surgery. There's the going through surgery, and then the discharge booklet. So there's, people get all kinds of information. So they're well prepared. We have the surgical APN, the nursing coordinator, or the clinic nurses that are here to provide support and information for the patients on a 24-hour basis. As I mentioned, our patient partners are a great source of support and information for patients. So if we identify somebody that would benefit from that program, then we certainly go that way. And then we have the community family of doctors and nurse practitioners who also help us to progress these patients through their recovery. And that's the end. Thank you. We take questions. Oh, okay. Okay.
Thank you so much, Kathryn. So all of our presenters for our valve portion, if you'd like to join us up here center stage, grab a seat, and we're going to commence our question period, and it'll be moderated by our CCU educator, Christy Strecko. For our online participants, please feel free to type your questions in the chat, and we will be sure to ask them. Thank you.
Thank you for participating in our question and answer period. Does anyone have a question? If you'd like to raise your hand, I can bring the mic by. If not, oh, perfect.
Hi, I'm wondering if the TAVI procedure can also be used for implanting a mechanical valve or only the tissue valves.
Yeah. So the TAVI valves are only tissue valves. They're biologic. Mechanical valves are only surgical at this time.
It's just a mechanical issue. You cannot shrink. When you put a TAVI valve, you use a kind of surgical tissue valve that you shrink. With a mechanical valve, you cannot do that. So it's maybe in the future we'll have new materials that can do that, but for now, no.
So relating to the last presenter, a common question that seems to be in the community to primary care providers from dentists perhaps is before dental procedures, should the anticoagulant be stopped or can it be stopped prior to procedure? Is there a guideline that you would follow and could it be shared with primary providers to give them guidance? They tend to defer back to the dentist.
Right. So if a person is having just a regular checkup cleaning, they don't need to stop their warfarin for that. If it's invasive, more invasive, like if they're having, root canal or extraction, that kind of thing, then usually we'll have a discussion with the dentist to see, what the nature of the procedure is. And if we have to stop the warfarin, then we would have to bridge them with heparin. David?
I agree. But more and more, it's recommended that we continue Coumadin. We check the INR around 2, and most of the dental procedures should be able to be done on Coumadin without stopping. If you have a very complex dental intervention, maybe, but most of the dental intervention should be done on Coumadin.
I have 2 online questions. The first one is for Dr. Lau. What was Sarah's risk factors for endocarditis?
Yeah, so a good question. And I think this kind of speaks to how challenging the diagnosis was to make because kind of as I presented, there were really no indicators that this was for sure endocarditis in the beginning, which was what accounted for the delay in diagnosis. But, the second presentation, the combination of stroke and positive blood culture should alert any healthcare provider to endocarditis. So I think the second presentation was a lot more obvious, but yeah, there were no traditional risk factors to alert us. I know there's a second question, but maybe if I can ask maybe a question to you, Sarah. is there any kind of, from what your perspective is, any advice you would give or like, do you have any, in the beginning, or, do you think things could have gone differently from?
Well, everything, hindsight is 2020, but I would say no. Now, I know at some point during my recovery, there was a comment because I did have a very enlarged aorta. So there was that was one theory, that because my aorta was so enlarged that maybe it made it very attractive to the bacteria, but I don't know. So other than that, I would just say, I mean, I knew I was not feeling well, so I should have been more persistent. And that's really all I can say. It's just, if anybody, a lot of the symptoms, like I did have the weird things on my fingers, and that unfortunately my GP didn't question too much. So I'd just be more persistent if you think that it's not, if it's not right, that kind of thing.
I mean, symptoms, as you kind of alluded to, they're sort of low grade, and they're kind of grumbling, and it's not like one day it's markedly different unless you have a complication. So
because the pain, the hip pain that took me to the hospital back in July, I know it's not a typical, but that's where the infection had gathered, pardon me. So I don't know. It's a very hard question to answer.
Great. We actually have two more questions now. Can nurses at TOH refer patients to you, Dr. Lau, or to Ruth, or how is the referral made?
Yeah, good question. I would encourage discussion with the treating team in terms of referral. So like typically we like that the treating team is involved in the discussion on the day of discussion, so that they kind of can provide the context as well as take away the information to use. So, and typically it's the MD or one of the residents that attend. So if you're worried, I would maybe just remind the treating team, like, is this patient appropriate for endocarditis rounds? And commonly they're on board.
Just a quick question for the mobile screening program. Is it limited to patients in Ontario?
So your question, yes, generally speaking, we are targeting Ontario participants, but we don't advertise, but we could take Quebec patients if needed.
We need to establish more partnership with RAMQ and Quebec. For now, the program is just funded by research. One of the issues we have also is if you detect something, who is taking care of the patient in Quebec? Is it to do referral here? If you have to refer to a cardiologist in Quebec, it's much more complex to organize, but something that we have in mind.
Just a follow-up question to that. Do you have a current geographic limitation to how far your mobile clinics can be set up?
It's Sandra answer.
Generally speaking, we've gone out as far as 2.5 hours away from Ottawa. And I think that's our current focus right now. So Ottawa and surrounding areas, exactly for the reasons Dr. Messika-Zeitoun had just mentioned there, just so that there's easy referral back to the Heart Institute and make sure those referral pathways are there when there is valvular heart disease detected. But we hope to expand and we hope to reach other geographic areas. That's the whole point of our mobile screening program, is to really reach out to areas and demographics where there might be a lack of access there.
So Sandra is not aware, but we are sending her to Nunavut next week.
So we have time for one more question online. And we're just wondering if there's an anticoagulant that can be used for valves other than Coumadin, which don't require as much frequent blood work.
So for the with the patients that have the mechanical valve that are on the Coumadin, there is no substitute. That's the only medication that is suitable. We've had a couple of patients that came back that were switched to another oral anticoagulant, and they developed thrombus on their, embolus on their valve. So that's the answer is no.
No, I fully agree. I would again one step further. It's a contraindication. It's a malpractice to give DOAC to someone with a mechanical valve.
I have one question for the mobile screening program. So why age of 65 have been considered for the by screening? So not less than that, let's say 55 or 60, considering the age goes up, the risk of surgery would be higher.
Yeah, thanks for that question. So 65 years of age, we landed on that target age group because we know that it's more prevalent as people age. So we want to detect it early, and typically that's sort of 65 and above. If we do it too early, we probably won't see anything, or it hasn't developed potentially.
No, I agree. It's also a balance between cost and efficacy. If you lower the threshold, you detect much lower rate of patient with abnormality, so you spend a lot of money for limited benefit. Doesn't mean that we don't have to do it, but for now we don't have the capability. And the higher threshold you pick up, the more likely you get to find abnormality, especially valvular heart disease.
Thank you so much. Unfortunately, these are great questions, but I have to put a cap on it. So sorry about that. But if you do have more questions, you can put them in the chat and we will get back to you. Thank you so much to all of our speakers from our first panel. I would like to especially thank Sarah for being here as part of our Q&A. Very appreciated. Yeah. So thank you very much, everyone. We're going to take an energy break. There are snacks over on this side of the room. Please help yourself. And please, we have Derek from Novartis over in the corner. Please feel free to pop by. Novartis has kindly sponsored this event and the food, as well as information on the mobile screening program as well. Sandra will be there. Friendly reminder that washrooms are out the door and to the left, and we will reconvene at 10:35. Okay. I know that not everybody has grabbed food. That's okay. We'll continue to do that, but I will sort of get the ball rolling again. Hopefully the coffee is settling in. I do just want to put a little announcement out for those who have time to fill out our surveys throughout the day. Your feedback is super important to us, and it's sort of how we shape these days. So if you take a moment to fill that out, that would be very appreciated, and you will be entered for a chance to win a prize. So carrying on with the next portion of our day, we're going to be hearing about atrial fibrillation. For the next presentations, we're going to ask that you hold your questions similar to before. And then at the end, we're going to have another question and answer period where our speakers will come up to the front. So first up, we have Dr. Alzahrani, an EP fellow who I personally have had the pleasure of working with in the electrophysiology lab before I came into this position. And we're so excited for him to be here to speak to us about atrial fibrillation.
Hello, morning everyone. My name is Alzahrani. I'm one of the adult cardiac electrophysiology fellows, and I'll be presenting the about atrial fibrillation. So basically, I'm gonna go over these objectives. So I'll go over the definition of the atrial fibrillation. We'll talk a little bit about the statistics, and then we'll go over the pathophysiology, risk factors, complications, presentations, and then how we diagnose atrial fibrillation. And then eventually we'll have a bit of overview about the atrial fibrillation management. Sorry if if there's anything that's too complicated or too simple, I tried to make sure things are clear for you, but feel free whenever you have a question at the end, then I'll take all the questions. And again, thanks, Tori, for having me here. So before I move on, I would like to thank all the nurses in our healthcare system. This would never have been done or completed without their efforts. And I think currently with the busy days and the tough schedules and the switch since COVID started, and thank God we're over this. There was maybe no time to say appropriate thank you, so thank you to everyone. So what is atrial fibrillation? It's hard to define atrial fibrillation, and it's at the same time a bit straightforward sometimes. It could be a symptom or it could be a disease. Sometimes it's like there are some doctors who would say it's probably like a fever. So is fever a symptom or a disease? Atrial fibrillation is a disease. However, it could be telling us about other conditions, either cardiac conditions or non-cardiac conditions. It's basically a heart disease that is characterized by an abnormal, irregular rhythm, and it is a heart disease for sure. And it's the most common sustained arrhythmia we have that is basically associated with reduced survival, reduced functional capacities, lots of symptoms, and it affects the quality of life in some patients very badly. As you can see here from the picture, with a normal typical sinus beat, there we see a P waves before each QRS, and these P waves are basically because the sinus beat is getting propagated through the appropriate channels to the AV node, so it's one P there. But with the atrial fibrillation, we have mostly left atrial cells that are not designed to do the job of the sinus node, and that are basically the P waves or the fibrillatory waves we see are erratic, bizarre looking waves. And that's why if the sign gets through to the AV node and gets connected to the or transmitted to the ventricles, then that's why we see abnormal, irregular beats. So when it comes to numbers, based on statistics from a few years ago, this is not up to date, to be honest, but there's about at least 700,000 to 800,000 Canadians with atrial fibrillation. In the States, the number is about 8 to 9 million people. In Europe, in combination, is about 10 to 12 million people. And the scary thing is that the atrial fibrillation prevalence is estimated to increase by 70% by 2030. With the other scary stuff too is that the one in every 40 years old person will have AFib during their lifetime. I'm not trying to scare you, but this is the numbers we got. And around the world, it's about 46 to 50 million people with atrial fibrillation. So this is a map that you could see. Apparently, in North America, we do have the highest number of atrial fibrillation patients per 100,000 population. Next comes Western Europe, and then Eastern Europe, and then the rest of the areas of the countries with the atrial fibrillation. Why should we care about atrial fibrillation if it's just we see lots of patients, people outside, they have atrial fibrillation for some time and they're doing fine, and some others come to the hospital once in a while, and there are patients who have very high symptomatic burden. So we typically we have to care, but we should care because it does reduce the survival of patients. We know that either the atrial fibrillation itself or the consequences of atrial fibrillation, it impacts the living of people themselves or their families as well, and it causes disabling strokes. And these strokes, the AFib strokes, are tough on patients with what comes next after the stroke. And about 30% of these patients with stroke will have another stroke after this. So it's devastating for patients, for families, for caregivers. It results in other cardiac diseases, including myocardial infarction, heart attacks, diastolic and systolic dysfunction, and heart failure, and non-cardiac consequences as well. So patients could get dementia, could have cognitive impairment, even those with controlled, semi-controlled disease. And it does have an economic burden. And apparently, based on the statistics, we do spend about $2 billion a year for the atrial fibrillation management. That basically is covering their hospital stays, emergency visits, medications, procedures. So, and it takes space. You see, lots of emergency departments, lots of patients come to the emergency departments either for a brief visit, they get cardioverted, they leave, or they could stay. They come with complicated stuff sometimes, with heart failure, more, and sometimes even elderly or older patients basically will need more stay, because it's not just one, get cardioverted, you go home. It's probably multiple issues. So we do so it does have a burden on the healthcare system. It does have an economic burden, and of course, clinical and on families too. So the pathophysiology of the atrial fibrillation is not very straightforward. We do have different factors that modulate or trigger or help with the presence or with the triggering of the atrial fibrillation. Generally, conditions, cardiac or non-cardiac conditions, non-cardiac including what we call hypertension and obstructive sleep apnea, drugs as well, and alcohol, smoking, obesity, and sedentary lifestyle, or cardiac diseases, including diastolic or systolic LV failure or heart failure in general. People who are elderly, they get stiffer left atrium, and this increases the pressure inside the left atrium, increases the risk of atrial fibrillation. And there are genetic predisposition as well. So we see this in younger patients or patients with very mild heart disease that typically goes masked and recognized until they start to get older. And then we go through the family history and find some genes that are responsible for this and for other cardiac disease as well. So to put everything together, or have a little small map, there are different factors. So electrophysiological factors, shortening of refractory periods, ion channels, and there are hemodynamic factors, including high left atrial pressure, and then some atrial fibrosis, inflammation, in addition to alterations of the autonomic tone. And then we get some triggers, which are basically either atrial or ventricular extrasystole or premature beats. This package or collection will trigger the atrial fibrillation, will keep it going. And the worst part is, as the atrial fibrillation progresses, this gets worse. So it's like a loop. More fibrosis, more AFib leads more fibrosis, more atrial pressure, and the circle just doesn't end. Risk factors, as I mentioned, there's lots of risk factors. We can start with clinical risk factors, cardiac disease in general, hypertension, obstructive sleep apnea, patients with thyroid disease, especially hyperthyroidism, patients on drugs, and patients on alcohol, smokers as well, and patients with obstructive sleep apnea, patients with other diseases as well. So it's basically could be could be many things. So at the same time, there in some patients, about 25 to 30% of patients, we don't know exactly what's the trigger. So it could be idiopathic, or we call lone AFib, and it could be reversible, or could be non or irreversible. Specifically reversible in patients post cardiac surgery. They get some manipulation of the tissue, cutting sutures, scars here and there, so they develop this. And typically in those patients, the atrial fibrillation is reversible. However, their lifetime risk is higher. So when it comes to the atrial fibrillation types, there are the paroxysmal atrial fibrillation. We do have the persistent atrial fibrillation, and then the permanent. And then they divide the persistent atrial fibrillation to early or long-standing. Basically, the paroxysmal is less than 7 symptoms for or atrial fibrillation for less than 7 days. Anything more than 7 days to 3 months is basically early persistent, and anything up to 12 months or more is basically long-standing persistent. And in patients who are chronically in atrial fibrillation, they don't go back to silent, they just have permanent atrial fibrillation. So the natural history of atrial fibrillation, it's a progressive disease. We know this by all the studies and by what we've seen so far. Sorry. And then so as I mentioned, it's an endless loop. So with few factors, patients is mostly in sinus rhythm, rarely or occasionally in paroxysmal atrial fibrillation. And then more episodes of atrial fibrillation leads to more times of left atrium fibrosis, more inflammation. Adding to this, the chronic inflammation that is associated with atrial fibrillation, the cardiac conditions that have been treated or non-treated, non-cardiac disease as well. So it comes to a point that atrial fibrillation during the first I wouldn't say a phase of disease, but early years, it will be easier to cardiovert someone out of atrial fibrillation. So these ECVs are electrical cardioversion, and it's easier to cardiovert them, and then they stay in sinus for a longer time compared to someone who's had progressive disease. That when it comes to more persistence, it's hard to cardiovert them, get them out of the atrial fibrillation, and it's also hard to keep them in sinus rhythm or normal sinus rhythm. To the point, everything just gets worse and worse till they get permanent atrial fibrillation if they go untreated and unrecognized, because there's lots of patients out there with paroxysmal atrial fibrillation that we just don't know about, and we I've seen this, and all I've seen this is in some patients, just like, oh, I feel just a pinch here and there. I feel tired. I don't think, well, I don't know what's happening. Maybe the age, I'm not exercising as much. And then things go unrecognized. And then over time, we miss this when patients sometimes present with persistent atrial fibrillation. And you ask them, and they was like, it was fine. I was just doing everything by book. It was, age, and, I just changed this. And our patients, all of us, not our patients, I'm just talking about all of us, we're very smart linking things to food for some reason. When I stopped eating salad, I just felt bad, and it's like, but it was maybe something else. So you have to, think about something else. And we see this all the time. You see it in your practices in clinic or in other ways. And it was like, when I started taking that medications, I think I felt bad, but maybe something else was going on. Then we discovered things. So over the years, the worst patients, there are some risk factors for the progression of the disease, but the paroxysmal with minimal burden of the disease typically progresses unrecognized, and patients just go without being noticed to have atrial fibrillation. So there are risk factors that are associated with progression in atrial fibrillation patients. And first thing is age. So with age, aging process is nothing that we can stop. And I think the science so far couldn't do anything for it. It's just a process that we all have to go through. So there are aging related process changes that probably can't do much about, but then we know there's patients with heart failure who have high risk of progression, patients with larger left atrium, more fibrosed left atrium, that the longer they go, the worse it becomes, and then the hardest to do to stop atrial fibrillation or to treat atrial fibrillation. Alcohol. In clinic, I recommend to patients just to cut it to zero consumption, because there are direct and indirect link between alcohol consumption and atrial fibrillation and cardiac toxicity as well. Even we say, maybe a glass of wine a day, it's with dinner, it's fine. And I've seen it myself practically, although I don't have much experience, but we put patients sometimes on medications, and good medications. They're good. They're in 40s, 50s. They're doing fine otherwise, and they keep having these episodes. And then you ask them, "Are you taking your medications?" "Oh yeah, of course, I take it twice a day. This and this. I have my wife does tell me about this, and everyone reminds me of it and everything." And then when you ask them about alcohol, it's not bad. It's probably a couple of drinks a week, and then when they cut it to zero, their atrial fibrillation burden goes. So it does affect this on the short term and the long term as well. And as I mentioned, asymptomatic, minimal burden, they go unrecognized and noticed, and then this is a risk for progression as well. Complications, lots of complications of atrial fibrillation and bone mortality, either a direct or non-direct, by strokes, heart attacks, or myocardial infarctions, heart failure. Cognitive impairment and vascular dementia is another thing that basically is a major complication of atrial fibrillation, and by itself it increases the risk of mortality. Adding stroke to this makes it even worse. Heart failure and LV dysfunction as well, and obstructive sleep apnea is basically the same with heart failure. AFib increases the risk of heart failure, and heart failure increases the risk of AFib. Obstructive sleep apnea, uncontrolled, not on CPAP or periodically checked, the same. Worse sleep apnea, worse AFib, worse sleep apnea. So who's the higher risk of stroke? There's multiple risk scores. Basically, the most straightforward one basically is the CHAD 65, and this is driven from or derived from information of the from the studies and the data we have. Is patients who are older than 65, they do have high risk of stroke. Patients with hypertension, with myocardial infarction disease, patients with heart failure, and with diabetes. Patients with previous stroke have high risk of stroke as well. And there are also other things, including chronic kidney disease as well. It's also associated with high risk of stroke in patients with atrial fibrillation. So clinical presentation in general is about 20 to 30% of patients who are asymptomatic, and atrial fibrillation gets diagnosed incidentally. These symptoms basically vary between patients. Most of the patients will have palpitations, or they would say funny feelings. I feel like my heart is racing or fluttering. Other patients will have fatigue, dyspnea or shortness of breath, and sometimes patients may feel, I don't feel like myself. Something is unusual, but they feel dizzy as well. They get some chest tightness or pain. That's typically different from the MI or the heart attack pain. However, it could be explained as pretty much the same as pressure, some tightness here. Typically doesn't go to the arms. Or they can present with complications like stroke symptoms or heart failure symptoms, and then we discover that they do have atrial fibrillation. Interestingly, lots of patients come with fatigue, or just fatigue, especially those who are in the middle age and who are actively more active physically, and they're working and they're doing their things and they're enjoying it. They feel like they'll say I used to walk for like 10 miles and now I do like 7, 6. I just feel like it's not myself, and they start linking this to other stuff. But atrial fibrillation could do this as well. How does atrial fibrillation impact patients? I think so far, or this far into presentation, we could all see worse disability, higher number of medications, because lots of patients can be controlled with one pill, but there are other patients who will need more medications. They will be on blood thinners, they will be on rhythm controlling medications, and there are some antiarrhythmic medications that we use. We add rate controlling medications to it as well. So lots of medications, never a pleasant thing to anyone. Great number of symptoms, emergency visits, and hospitalizations, and then complications and conditions, and their survival as well. So it affects them on the daily basis, in the short term and the long term as well. What about families? So it's a huge burden on families as well when it comes to, especially for patients with high symptomatic burden or patients who are visiting the emergency more often, who needs more care as well, even at home. Sometimes families are involved in, especially for elderly patients, involved in checking their medications, reviewing their doses, checking if they have any bleeding side effects from the blood thinners. So it's a huge burden on the families as well. It's not an easy job to do. So how do we diagnose atrial fibrillation? So I'll make sure I'm running on time, Tori. We're doing good? Okay. Atrial fibrillation basically, or typically, is diagnosed on a 12-lead ECG. So once we document this, then this is a confirmatory test that we say, we are confirmed you have atrial fibrillation. But on a device, an implanted a pacemaker or ICD or a loop recorder, or on a cardiac telemetry or Holters. These are the main things. There are other screening methods, and they are good with screening for atrial fibrillation, starting with the pulse check. So irregular pulse could be related to atrial fibrillation. However, it's not the only reason, not the only disease that causes atrial fibrillation, irregular pulse, because we have other patients who have atrial flutter with with variable conduction, or we have patients with PVCs. They get some pause after the PVCs, and then the PVC doesn't get conducted to the pulse. You feel like the pulse will stop for a bit, and then it'll come back and say, oh, maybe it's safe, but it's not always the case. And then there are a few other things like the single lead devices, like the Cardia device. This one over here, the patients use, they can, whenever they have symptoms, they put their fingers on the device. It's a very small one. It's very helpful. And then this is connected to an application on their phone. So we could see the rhythm on their phone when they see their doctor, when they go to the emergency department. And it's a very helpful device. We have diagnosed patients with AFib, sinus pauses with this little thing. I think it costs like $40 from Amazon or something. I'm not trying to sell it, but it works. It works greatly. And then smartwatches, Apple Watch. It could also be a helpful tool to diagnose atrial fibrillation as well. And there's lots of studies that did basically assess the specificity and sensitivity of Apple Watch. Again, this is not, I have zero disclosures. I'm not involved with any of these people, but it does help, and it's popular too. So we could diagnose this atrial fibrillation from this as well. And it does have very high specificity. The sensitivity is not 100%, it's not the best. And then so that's basically the way we diagnose or we screen for atrial fibrillation as well. So when it comes to management, like any disease, basically we go over what are the risk factors, what are the triggers of atrial fibrillation, and then we control these factors first. And at the same time, we go over the disease itself or any complications. And in general, the Canadian cardiovascular guidelines outline the management of the atrial fibrillation in these three. So we assess the stroke risk if they need to be on blood thinner, and then the arrhythmia itself, whether we start rate controlling medications like beta blockers or calcium channel blockers, or we start anti-arrhythmic medications to try to switch them from atrial fibrillation to sinus rhythm. And then every time, every visit, every encounter, we have to look at the risk factors to manage them. And then the catheter ablation basically is not the end of the list. In selected patients, we go right ahead to the catheter ablation. I'll go over this briefly. So for risk factors modification, so basically overweight, obese patients, we should target a weight loss more than 10% of their weight, or a BMI less than 27. But in general, we encourage patients to lose some weight, and that really helps with their disease burden as well. In terms of diabetes, high blood pressure, we ask them to be on appropriate medications to help with their targets. The A1C is about 7, and the blood pressure target for the day hours is about less than 130 over 80, and this is based on the Canadian cardiovascular guidelines. ACE inhibitors are maybe preferred because they do help with the blood pressure, plus the remodeling that comes with atrial fibrillation that leads to heart failure. So it's 2 ways: exercise, exercise, exercise. It's one of the major modifiable risk factors or interventions that we can use in patients with atrial fibrillation. It is being seen that it reduces first of all, it improves their functional capacities, their exercise capacities. It reduces the burden of their symptoms, prolong their survival. It reduces risk of the dementia comes from the atrial fibrillation, risk strokes. And there's lots of research that's going on about the exercise in atrial fibrillation patients, especially those who are with paroxysmal atrial fibrillation. And then alcohol and tobacco smoking. Tobacco, 0, alcohol, 0, but realistically, it's sometimes hard to just ask patients to stop everything just cold turkeys. It's not practical sometimes. In some patients, it has been done before, but some patients could do this. And I think I would say we have to always encourage 0, even to get minimal, but the target should be 0. Although there are some studies that shown maybe a little bit of wine here and there, some chocolate might help the heart function, but we know that the alcohol does have a direct toxicity to the heart cells and to arrhythmias as well. So the management for paroxysmal versus persistent atrial fibrillation is slightly different. In patients with paroxysmal atrial fibrillation, if they do have low to minimal symptomatic burden, we typically either do nothing. We say, if you're feeling okay, everything is fine, there's no issues, you can just watch yourself. If you get more symptoms, then we'll probably give you medication, or sometimes we prescribe the pill in the pocket. It's either a rate controlling medication or a rhythm controlling medication, and they just use it whenever they feel the symptoms, especially if their symptoms last more than 20, 30 minutes or an hour, 2 hours, and it's useful and helpful. Or in other patients with paroxysmal atrial fibrillation, especially those with an early course of the disease, the early rhythm shift or cardioversion to sinus and keeping them in sinus helps with the disease on the long term. And for those patients, we sometimes offer antiarrhythmic medications, or we can just refer them for atrial fibrillation ablation. In persistent atrial fibrillation, specifically older patients, we aim more for rate controlling medications or beta blockers, something to slow their heart rate to make sure they feel fine. Not because anything, but it's just sometimes hard to manage the persistent atrial fibrillation and hard to just get rid of it. But at least to make sure patients is feeling fine and doing well. However, in those patients, there are some patients we basically ask or basically offer antiarrhythmic medications and then select patients depending on multiple clinical and factors and their recurrences. For persistent AFib patients as well, if their symptoms are persistent, the medications are not helpful, we ask them to come for cardioversion, or we either do it either urgently or not urgently, and we also cardiovert patients who are unstable in the clinical practice as well. But long-term goal for them is more of rate control. Some will get rhythm control, although the studies have changed and there is more data coming supporting even targeting rhythm control right away for those patients with persistent atrial fibrillation, because it's now or never. And as the disease progresses, things get worse as well. So in general, for rate controlling medications, we prefer to use beta blockers in patients with an LV ejection fraction less than 40%, and we don't use calcium channel blockers in patients with EF less than 40% because it does have a negative effect on the heart muscle function, and they could somebody could go into cardiogenic shock. But those with ejection fraction more than 40%, it's good. As well, if they don't have adequate rate control, rhythm control, the catheter ablation or AV node ablation, which I'll talk about later, might have a role in those patients, and it could be for the long-term benefit. I'm almost there. Different medications or rhythm controlling medications for different comorbidities as well. And catheter ablation could be first line. It could be the way to go after trying multiple medications in some patients. For stroke prevention and anticoagulation, basically based on the Canadian cardiovascular guidelines, they recommend using the CHAS 65. So any patients who is 65 or above should be anticoagulated with a full therapeutic dose. If they're below 65, either one prior stroke, TIA, hypertension, heart failure, or diabetes, any one of these should be anticoagulated. If they don't have any of these, they do have coronary artery disease or peripheral artery disease, then they do have an indication for aspirin or Plavix. They get them. If they don't have any of these, then we don't anticoagulate those patients. So the last is the catheter ablation. Different modalities. So I'll start from, I'm not sure if you see my mouse. Anyway. So radiofrequency pulmonary vein isolation. So we go endocardially through the groin all the way to the right atrium and then to the left atrium crossing the septum. And then we go around the left-sided and right-sided pulmonary veins, and then we apply ablative lesions around them to block the signal from passing through the pulmonary vein to the left atrium and to the heart. The success rate of this procedure is up to 80%, and about 20% of patients might require another procedure. It takes about 3-4 hours. The other modality here is basically the same concept, but it's more of cryo or more of cryoablation therapy. So we get the balloon all the way to this spot, and then we block the vein, and then the balloon gets inflated and gets frozen to -50 or -60. And that basically blocks the transmitting signals of the tissue and blocks the transfer of the atrial fibrillation signals to the heart. This in a repeat procedure in those patients who had unsuccessful radiofrequency ablation, then we go target other lesions in the heart other than the pulmonary veins. a new technology that is coming and is being gone on in Europe and the States as well. It's coming to, I think it's been also committed in Canada as well. It's coming to the center here is something they call pulse field ablation. So based the same concept, it just gives this pulse cautery. It reduces the time procedure complications of these procedures. And the last option basically is the AV node ablation after implanting a pacemaker. And we target or we go for this procedure in patients who are with persistent refractory symptoms who are unable to manage at home with despite all the medications, or if they develop side effects from the medications as well. So we go ablate the AV node, and they're going to be dependent on the pacemakers for the rest of their lives. It does help with their symptoms, with the heart function, with the long-term functional capacity. There are some benefit of on survival in those patients, but those patients typically are older patients, multiple comorbidities. The procedure could take from 20 minutes to an hour maximum to be done. Okay, thank you so much, and thanks for having me.
Thank you, Dr. Alzahrani. Sorry for the pressure at the end there. It's hard to pack all that into 30 minutes. So, and the good news is that he'll be around at the end for our question period. So next, it's my pleasure to introduce one of our patient partners, Anne-Marie. Anne-Marie is one of our patient partners here at the University of Ottawa Heart Institute who can speak to this topic from a perspective that not many of us can. We're so happy that she can be here with us today, so please join me in welcoming her.
Hi, everyone. Thanks so much for offering me the opportunity to participate in this day and to sort of meet all of you here in the room and the people that are joining us virtually. Let me start my timer so that I stick to my time limit. So yeah, I'm still living with AFib. I'm about 20 years in, and this is why we should care. So we asked the question a little earlier, why care? For people like me who are living with this condition and trying to live full and active lives. It's been almost 20 years that I've had a relationship with the University of Ottawa Heart Institute. I started in around 2006. I started my relationship here as a patient, and since then it's expanded to include a number of different volunteer roles that I like contributing to the Heart Institute. I received really special and excellent care when I was here, and I feel like I need to give back to the institution. I'm also a Women at Heart peer support group leader for women with electrical heart issues. So not only do I have my own experience to draw on, but also the experience of the women who are in those groups who come together to share their experiences and learn and support each other. So let me just start by saying that living with AFib kind of sucks. It's no fun. And yes, we all find ways to manage. It's part of who I am. It's not all of who I am, but it's not a gift. It's not a great thing that has made me change the way I look at life. It's something that I have to manage. And so I think that it's important to sort of keep that in perspective, because sometimes it's easy to slip into the space of, yes, I've made changes in my life. Yes, it's made me aware that I'm very grateful for what I have and who I am and what I can still be with this condition. But at the same time, I wouldn't wish it on anyone. So let's dig in a little bit. So in the before time, I was living my life. I had 2 young kids. I had a busy career. I had a strong social support network. I was active, physically active, and I ate mostly well, maybe had a few too many glasses of wine. And then in around 2006, I happened to be at the doctor's office with my daughter and told my doctor that I was having that funny heart feeling. When I have an AFib episode, it feels like I have, if you picture a fish out of water on a dock flopping around, that's what it feels like inside my chest. And I was trying to describe it once to one of the residents in the emergency room. And I said, usually we don't even think about our heartbeat, right? It's there, it happens, it just keeps going. It doesn't even cross our minds. But when I'm in an AFib episode, that's all I think about. It's all I think about because it's just so present. It's all I can feel it. Every beat I can feel. So so not January, in 2006, I'm diagnosed. I go through a period of short episodes, an hour and a half, 3 hours, that resolve themselves every few months. And of course, as was described, progressively the episodes get longer, they get closer together. And so eventually in January of 2012, about 6 years later, I have January 2012, and every Saturday I'm at the ER at the General Hospital, which is about a 15-minute walk from my house. So I walk over to the ER, get cardioverted, go home, and then next week I'm back because by about Wednesday, Thursday, I'm back in AFib and it's not resolving on its own. So I go for an ablation December 2012. It works. I'm back at work 1 week later. Everything's great until about early 2017. And then I start having episodes again. So I go for a redo. So this is 5 years after. I'm going for a redo, another catheter ablation. This ablation hits me like a Mack truck. I feel like I wake up after the ablation and it feels like, oh my God, I've been like run over by a truck. So it was a completely different experience, which was fascinating to me because it was theoretically the same procedure, but a very different impact. This one didn't work. And after the second ablation, my episodes became harder to live with. I was more exhausted. I was unable to do all the things that I committed to doing. It's really hard to plan your life because you try to plan something and then you just don't have the energy or the interest really to do it. I get really grumpy when I have an AFib episode because I'm kind of annoyed. So for a while, I used a pill in the pocket approach to manage the episodes. And again, the episodes started getting more frequent, closer together, coming more frequently. In April of last year, April 2023, I had a surgical ablation. So 6 years later, surgical ablation, had a really rocky time coming out of that ablation, trying to use meds to stabilize what was happening in there. Finally, we tried the amiodarone and we did it for 3 months, and I haven't had, knock on wood, an AFib episode since then. So part of me goes to, okay, I'm just, coming off the drug still and it's not kicked in yet. And part of me is going, okay, I'm going to take every day I can without these symptoms. So what do I do to try to manage this condition? I try to stay away from my triggers. I've worked out alcohol. In the groups that I lead, I talk about if you can't go from where you are to zero, go from where you are to 1 drink less a week, and then progressively to 2 drinks, like do it gradually. Even if you have to do it gradually, if that's the only way you can do it, it's a way to do it. And I did that with alcohol. I also did it with some of my food choices. So I now eat mostly plants. And that's how we worked out the meat out of our diet. We stopped the red meat, and then we stopped the chickens, and then we stopped the fish. And so we gradually, like over a few years, not over a few weeks, we started to make those lifestyle changes. I make sure that there are lots of opportunities in the day to laugh and to find humor in life, because that's, to me, makes it worth living. I'm still physically active. I bike, I kayak, I run, I walk. Even if I'm in AFib, I try to be active. Sometimes if it's a running day and I'm in AFib, I don't run because that can be disastrous. So what I do is I walk instead, and I eat mostly plants. So yeah, a bit of a roller coaster. When I was diagnosed with AFib, so you're diagnosed, you get the news, this is what you have, and you're a little bit deer in the headlights, right? Like it's like, okay, like everything that was said after that is kind of fuzzy. So for me, one of the important things was being able to find places to find information that I needed to help me manage my condition. I'm a person who likes to try to understand what's going on. Unfortunately, we don't have the information about what causes AFib, which is a little bit annoying, but hopefully with the research that's being done, we're getting there. But we do know a lot about some of the risk factors. I know a lot, I've learned a lot about what some of my triggers are. I manage those, but it was really interesting for me to be able to go online and find resources and find insights into what I might be experiencing and how I might deal with it. There are, of course, the trusted sources online, the Mayo Clinic, the Heart Institute, like other places like that. There's a really good UK cardiologist who does YouTube videos, Sanjay Gupta. He's a UK cardiologist. He's amazing. And I still go back to those videos now and then. There's a lot of wacky stuff online. And so the wacky stuff is kind of funny to read. It goes to that you got to laugh every day thing. But you need to be able to be discriminating, right, in the kind of information. One of the things that I talk about with the groups that I lead is and what try to share is what the curated list of resources for them. I can access research papers online too, and those are a little bit, I know just enough to make it frightening. But one of the things that, so rational me is trying to understand what's going on. Less rational me is kind of going through the emotional me is going through the grief cycle. I've lost the invincible side of me, and I'm trying to manage that grief cycle. And a lot of you are probably familiar with Elizabeth Kubler-Ross's grief cycle. I kind of really liked this image, right? How we want grief to work, kind of straight line, going through those stages, how grief actually works. So every time I'm in an AFib episode, I'm back in the anger denial stage. So this is sort of the three sides of living with AFib for me. If I'm having a bad day, having AFib episodes, I'm miserable, I'm grumpy, I'm frustrated, I'm angry. Mostly though, I'm having good days. I'm that person in the middle on the bottom, holding people up. I'm strong, I'm doing what I can to manage the condition. And trying to find a way with the third image of living peacefully with my heart that has weird things happening. And so, as I said, typically the days are good. The part of who I am, this is part of who I am, but it doesn't define me. What I've learned through the peer support groups is that everybody's experience is different. Some of the women hardly feel the episodes at all, and other women are kind of completely out of commission when they're having an episode. So everyone you're dealing with can have a very different experience of what this is. A lot of the ladies that I work with, and for myself as well, this condition is invisible. It's not obvious to your family, to your friends. And so it's really difficult sometimes for people to understand where you're at and what you need. It becomes really important to be able to talk about those things. So I think I'm past my 10 minutes, so I'm going to stop it there. I just want to say one last thing. From one of my favorite other Women at Heart peer support leaders, Laura, who's actually here in the room, to be curious and not furious about your condition. And so find that place of curiosity where you're discovering and learning and moving forward. Okay, I'm done. Thank you.
Thank you so much, Anne-Marie, for sharing your experience with us. It's very eye-opening to hear your perspective on it. Next up, I'd like to introduce Anne Grenon. She's a registered nurse on the arrhythmia team here at the Heart Institute who specializes in AFib. And today she's going to talk to us about what the AFib clinic is all about.
Hi, everybody. All right, so as she said, I'm the atrial fibrillation nurse here at the Heart Institute. So the AFib clinic is really just a source for patients that are usually newly diagnosed with atrial fibrillation. So lots of my referrals are newly diagnosed, but I do get also the ones that are already on medications. So I'll give you a bit So I'm going to go over education that I give the patients, how the clinic works, so how I triage patients, anticoagulation, why it's important for the clinic, and we do weekly clinics. And then I'm going to talk about a little bit of the AF ablation IVR. So it's kind of like a follow-up for patients after their ablation. So education that I provide is mostly the booklets. So I have a smart phrase that identifies all the links. Sorry, I guess I can't move that. So yeah, it's pretty much all in direct links, and then I call them. So anytime I have a referral, I will call the patient, invite them. I offer a class once a month about atrial fibrillation, sorry, a webinar. So I invite them to my class, discuss with them, especially if they're newly diagnosed. I answer any of their questions that they may have. But every patient that is referred to my clinic does receive a call from me if they want it, of course. And then I talk about their quality of life, and I'll kind of triage in that sense that how they're doing. And then I do a lot of symptom management. So on this, we have a stoplight tool, which is super helpful for patients, and patients love it because it kind of gives them that when they're okay, when they should kind of go and see, kind of like with all the heart failure and ACS stoplight tools. But I normally like to go a little bit deeper and say, like, you need to rest for a bit, because a lot of the patients, if they start to have the AFib, I understand they panic. It's very, very stressful for them. But I always encourage them to rest for a little while, make sure they've taken their medications, and also tell them why they're taking their medications. A lot of patients will tell me, oh, I stopped taking my medication because I don't have AFib anymore. It's like, okay, no, you don't have AFib because you're taking your medications. So I explained to them, you need to keep taking these medications, probably why you're having more episodes. So yeah, I really do like symptom management and when they should be alert or when they should be doing certain things. And then I review a lot of their pill in the pocket. A lot of patients have pill in the pocket option, but don't really know how to use it. So I insert in writing and in my smart phrase written what the CCS guidelines are for the pill in the pocket. So wait 30 minutes, take your pill in the pocket, sit, rest. And I tell these patients, I know it's very time consuming. It's no fun. Like it's a chronic arrhythmia. So it is very time consuming, and but you kind of have to go through the process to kind of help with your symptoms. And then obviously urgent symptoms. So if the patient's having chest pain or passing out or dizzy, they're unable to even walk across a room, even after resting for 2 hours or something, then definitely there's something else, or any stroke-like symptoms, always go. And then another big part is the modifiable risk. Anas already went through all those things, so I might just fly by. But there's a lot of risk factors that are not modifiable. So like if they've known coronary artery disease, or they've had valve disease, or whoops. So there's a lot of things that you cannot modify, but with a chronic illness, obviously there's a lot of lifestyle changes that can be done to help symptoms, to help you manage a little bit better. So I do a lot of that teaching and kind of identifying with the patient what could be changed in their life, and try to give them as much help as possible to try to help that. So for the AFib clinic, so there's kind of two different sides to the AFib clinic. So there's the AFib clinic that I receive referrals, call the patients, make sure they have all the information they need, and also give them a source of somebody they can call. So if they're having an episode, I say, call me. If you have any questions, call me. So I'm kind of like that kind of middle person between the physician's office and the emergency room sometimes, and the nursing coordinators. So trying to kind of do that communication with them. But for my clinic, I also accept patients. So normally I accept the most urgent patients. So the patients with paroxysmal atrial fibrillation that are showing signs of heart failure, or that they're having really long episodes, they're very symptomatic, even on medication, and they really need to be put on the ablation wait list and be seen by a physician as soon as possible. So if there's a cardiologist also that refers them, obviously at that point, you know that they're super symptomatic. So there's kind of a process to that. And also another thing I do is I ensure that they're on the proper anticoagulation. So when I receive a referral, if they have a positive CHAD score, I then communicate with the GP, ensure that the patient's on the proper medications. So we have that kind of, at least if they're not being seen for a few months, well, at least they're on the proper medications, reduce that complication, reduce the risk of stroke. And I do my weekly clinic. So basically I see 5 to 8 patients per week. So I see them in clinic, and then the physicians will see them afterwards. So I really take my time with them, really identify, like, listen to their symptoms, how it's affecting their quality of life, what can we do, what suggestions could we do for like modifiable risk. Then I really go over all the treatment options. If they're already on treatment options, then we just review why you're on this medication. If there's any follow-ups, like a lot like amiodarone, their side effects. So just to make sure that they're aware that they need to have blood work every 6 months, for example, just to make sure. And if they're having symptoms of their thyroid being all out of whack, well, that's maybe your amiodarone, you know, like, so just really take the time with the patient, because I do have the time. So just really take that time, listen to them. And then give them as much resources. So like you mentioned, like for like any of your alcohol stuff or quitting smoking, like, so give them resources. Or like for exercise. So a lot of people, if they're not exercising and they're like, well, now I have this AFib, I want to start to exercise. It's like, okay, but like, then give them resources to make them feel better, like going to a rehab program or whatnot, like trying to give them ideas on how to help with their modifiable risks. And then discuss also with the patient, because it is their choice. Like they could be on medication. Some people don't mind being on medications, but other people don't want to be on medications. They prefer to have a procedure, and vice versa. So you really discuss with the patient, what do you want? Like, are you happy with the management? Are you not? Some people are not. Okay, they would like an ablation. Perfect. And we explain everything about the ablation. We go over like what to expect the day of. And also I really emphasize that it's a treatment option. It's not a cure. So it's not like they'll never have AFib. They'll still be on their anticoagulation. So just to be clear about what the expectations are of the ablation, because you don't want them to kind of be super disappointed at the end, because that happens a lot. And then also I provide suggestions for physicians. So for their anticoagulation, if there's a change that should be made, if the patient's complaining about taking a medication twice a day, but they could be adequately anticoagulated on it once a day, and you're like, oh, I keep missing my second dose. It's like, okay, well then maybe we should try to do something else that's better for you, that's going to help your situation. So just those little things, just to add a little for the patient. So now I have an example. So I have this 50-year-old woman, Jane. So she was diagnosed with paroxysmal atrial fibrillation 1 year ago. She's having weekly symptoms, weekly episodes that are lasting over 40 hours. She was on bisoprolol, but she stopped because of the medication side effects. So on her Holter, she's got a good amount of AFib on her Holter. So for her, she would be a good candidate for my clinic, just because she is having a lot of episodes. She isn't able to take the medication that she is prescribed at the moment. So she's on nothing really for her AFib. And she's very active. Like we go over all the modifiable risk, anything, or like her triggers and stuff like that. So, and I feel like this person should be seen maybe a little bit sooner, put on the wait list, and at least see if there's any other medication or management we could do for her. And then we have a gentleman, Matheus. So he's 65 years old. He was diagnosed with paroxysmal atrial fibrillation 5 years ago. So increase in his symptoms. He's super fatigued. He's having more shortness of breath. He's been in the emergency a few times in the past few months, and he is in rapid AFib. He's on bisoprolol, amiodarone, and of course his DOAC. So he would be the perfect candidate. So paroxysmal atrial fibrillation is it is progressive. So today's paroxysmal atrial fibrillation is tomorrow's persistent. So this man looks like he's kind of going into that persistent, and you kind of want to get the ablation prior to that because it is progressive. So yeah, so he would be an amazing candidate because he's on a rhythm control, on a rate control, and he's still having all these symptoms. So something else needs to be done. So that's the AFib clinic. I think I got everything. Now I'm just going to show you the AFib ablation IVR. So this is kind of an automated questionnaire for the AFib. So they would get a pre-procedure quality of life assessment. So it's really, AFib is really quality of life, how people are affected by it. So they do the pre-procedure, and then we get the data from that, and then they'll be followed up. They'll be followed up 2 days and 30 days after their procedure. So we ask about medications, how their insertion site is doing, if they've gone to the emergency, if they've seen their GP, if they have any questions, and then that gives us kind of a notice, and then we can follow up with them. If they have any questions, I'll give them a call, be like, hey, what's going on? So at least they have that person that is following up with them day 2, day 3, day 30 after their procedure. And then we follow up with them 6 months and 12 months after and see the difference between how their treatment is going. So we started in November 2021. So this is kind of just so we've done over 1,200. So you can see here, like pre-ablation satisfactory, it's pretty much mixed. Like it's not, nobody's feeling awesome about their AFib. And then you see 6 months after, a lot of more people are extremely satisfied from their treatment. So that's really good. Like that's very encouraging on the ablation side of things. And then this is after 12 months. So you see that progressively, because 3 months after the ablation, a lot of people do have more episodes. But so that's why we do this 6 months and 12 months when their heart is really healed and they're feeling a lot better. And that's it. Thank you.
Thank you, Anne. That was super interesting, especially about the IVR portion. I'm sure people are gathering their questions for our Q&A time for that. Next, it's my pleasure to introduce Dr. Rozen Alex. Dr. Alex is a school, clinical, and rehabilitation psychologist with over 20 years of experience, 7 of which have been here at the Ottawa Heart Institute. We're so glad that she can be here today to speak to us about the mental considerations pertaining to patients with AFib. Following Dr. Alex's presentation, we're going to ask our advanced practice nurse, Lindsay MacArthur, to moderate our Q&A panel presentation. So get your questions ready.
So the joy of being last is I have to speed talk, so I apologize for that. My name is Rozen. I'm one of the psychologists here. Before I get started, I do really just want to thank Anne-Marie for going over the human experience of going through it, because it does suck. And sometimes when we are just in our clinical modes, we forget about the fact that having AFib is very uncomfortable, and you have to do a lot of thinking, as Anne-Marie reviewed, about what things am I going to take on, what things am I not going to take on, how much do I want to challenge myself today, how much do I want to give myself a break today. Those things that we don't always do, we just kind of go day to day. You have to make these sort of automatic, much more thought through. And I think that just taking that time to recognize that before we approach our patients and expect them to make all these changes is always very helpful. So really briefly, I'm going to review the relationship between atrial fibrillation and mood, and some strategies for managing distress regarding AFib as well. So as you can probably guess already, there's direct and indirect impact of mood on our cardiac health, especially AFib. There is a complex bidirectional relationship, and they really do impact each other. I keep doing that. So our mood impacts our cardiac health in direct ways, including inflammation. We know, for example, depression is associated with increased levels of systemic inflammation, and we saw in one of the slides earlier today that inflammation is a risk factor for AFib. The autonomic nervous system dysregulation is also impacted. So, for example, again, depression can lead to imbalances in the autonomic nervous system, increasing our sympathetic activity, otherwise known as our fight or flight response system. So that system that gets us ready to tackle a problem, run away from a bear, should a bear run into a room, things like that, that's also impacted. It also reduces our parasympathetic activity. So that's our rest and digest activity. That dysregulation can trigger or worsen AFib symptoms. There's also indirect impacts of our mood on AFib, and that includes behavior and lifestyle factors, which you've already seen a few slides about. There's also medication adherence. So we know chronically undiagnosed depression can often lead to difficulties with medication adherence, following medical advice, getting that initiation going for activities such as exercise, changing day-to-day activities and things like that as well. And there's also those behavioral factors that can be impacted by mood as well, such as dietary changes, smoking, alcohol use, things like that, that can also exacerbate AFib. Furthermore, some studies have suggested that symptoms of chronic emotional distress can increase the initiation, propagation, and reoccurrence AFib. And anger and hostility rates in men over a 10-year period had a predictive relationship with AFib as well. So these are factors that we know we want to work on when we're working with patients that are having high symptom burdens for AFib. AFib can also impact mood in direct and indirect ways. So patients with AFib who have higher symptom burdens, so that they can feel the runs more, they have more frequent runs, note more stress and anxiety, and lower quality of life as well. At the individual level, the patient experience of AFib can vary extremely, as you've heard. Some people can really feel it, other people can't. They say about approximately 61% of AFib patients experience their symptoms, such as palpitations, shortness of breath, or poor exercise tolerance, whereas 39% tend to report no symptoms at all. And again, that can lead to problems as well. So this variance in symptom perception can mark a challenge in patient care because AFib can be debilitating for some, or they can ignore it and not make the lifestyle changes that are required as well. So some specific psychological triggers of distress include fear of further health complications. So we've heard some of the health complications earlier, so I won't go over that. But that chronic symptoms can also lead to constant physical discomfort, can wear down a patient's mental resilience over time, and lead to more fear and uncertainty as well. Quality of life can also be impacted as well because the limitations that are imposed by these symptoms can really reduce the things that give people pleasure that they value in their life. And those things are also risk factors for depression when we can no longer engage in those enjoyable activities that we normally do. Finally, chronic stress and the emotional burden of just the symptoms, right? So if my heart is palpitating quite a bit, guess what? I can start feeling anxious because anxiety also has that feeling as well, right? So we do really want to pay attention to those feelings, but also not just dismiss them as, oh, it's okay, it's just normal, it'll go through, right? So I will show you a very busy slide that I won't get into just for time's sake, but this is just an illustration, again, about the two-way nature of atrial fibrillation and stress, that there is the stress that can create the AFib or impact the AFib, and also the AFib that can circulate back and create more stress over time. An example of management that incorporates psychological perspective and thought about about AFib is this comprehensive management example that was proposed by Sears a couple of years ago, and it includes a medical management, symptom management that you've already heard, behavioral change strategies that Anne-Marie already discussed as well, and managing of the psychological distress. And this includes looking at things like anxiety over time, checking in on it from regular checkups that that patients can go to at PCP meetings or through clinic appointments and things like that, and as well through self-management strategies. So self-guided stress management resources, yoga, relaxation, meditation, that sort of thing as well. The way that I look at this is through a cognitive behavioral therapy perspective. So cognitive behavioral therapy is a well-known theory in psychology, and a lot of people may have heard of it or use some of the strategies of it for other health related management, so such as diabetes and things like that. The way we really look at it is we think of a environment or a situation that occurs, and it triggers this internal process in us. We have thoughts. So our cognitive changes that can occur include our thoughts, our beliefs, our self-talk, the way we approach the situation, our behaviors, so the things that we do and we don't do, our physiological response to the situation, and also our emotions. We know our emotions are sort of the last thing we can change. They're the hardest thing to change. So we look at the way that people are thinking about their AFib, for example, or thinking about the situation that they're in at that moment. We look at the things that they're doing and that they don't do that may be exacerbating the anxiety or the depression in that situation. And we also look at what's going on inside their body. You know, are they taking their medications? Do they maybe need a medication for anxiety or depression? Did they sleep well? Are there other sort of physiological risk factors that are happening there that could be exacerbating the issue? And we work backwards from there and say, what are the easiest places for a patient can work on and change? So again, going back to Anne-Marie's example, is some days she can't run, right? So that internal cue is saying, I can't run. And so she'll say, well, I will try to still do a behavior to help myself, which is walk, but with respect and recognition of what her body's going through at that moment. And that likely improves her mood over time. I'm just guessing. And she's nodding her head and saying yes, so that's good. And then it reinforces a positive cycle. So we're trying to slow down the negative cycle and move towards the positive cycle. So some of the things that we can think about in terms of strategies for psychological management include normalizing or educating with the fact that there is a bidirectional relationship between AFib and our mood. It doesn't mean it's all in a patient's head. In fact, we really want to emphasize that it's not all in their head. It's just that there is this unique bidirectional relationship there. And we don't want to pathologize it or dismiss it, right? The other thing is we want to screen regularly a patient's mood just to make sure that they are paying attention to some things that could be maybe exacerbating their AFib there. And encourage treatment of pre-existing mental health symptoms if they are there, because that is likely impacting their management of AFib. And then finally, also strategize and communicate the needs of the patient with patient and other healthcare professionals as well. That strategizing and communication will also require maybe other professional support, including counseling, psychotherapy, professional, like personal trainers or going to a yoga class or something like that, and also supporting relationships. And you're going to hear about relationship supports later in the day as well. Having supports, asking for help when you need it, giving routines or chores or responsibilities to other people and families or friendship groups could be helpful for patients as well if they're having a high symptom burden. Last but not least, there's just some resources to look for. If patients don't have access to to individual psychotherapy through insurance plans. Access MHA is sort of the one-stop shop in Ontario to look for resources. So people can self-refer, and there's self-guided programs. There's some individual programs available as well as group programs through there. There's also Anxiety Canada. They have the Mastering Anxiety and Phobias self-management course as well, which is free. And they also offer group therapy online for a fee. The prompt clinic is referral only, but if you have a patient who has premorbid psychological distress and may have been on medications or are currently on medications, but it's not quite optimized, you can have a referral to the prompt. You can send a referral to the prompt clinic by a physician referral, and they can reassess sort of the medications and provide suggestions as well. And then finally, I put an example of a app for sleep from the VA actually in the States, but it's CBTI Coach. It's the Insomnia Coach. It's a self-guided program for sleep management because we know sleep is such a big part of management of AFib as well. And finally, if somebody does have access to insurance coverage for psychotherapy, the Ottawa Academy of Psychology here in the Ottawa area has a list of people who are providing psychotherapy in the area, and you can filter it to who deals with health psychology issues and things like that. Same with the College of Psychologists of Ontario. And just again, reinforcing the good information that's out there, not the maybe questionable things, the Heart and Stroke Foundation and our own patient guides as well. And that's it. Sorry, that was fast.
All right, thanks so much. So I'll get all the speakers to come up onto the stage so we can just do the panel. Anne. You too, yes, sorry. Okay, perfect. So does anybody in the room have any questions? All right, perfect.
I have two questions. One is for Anne-Marie. You mentioned that you've identified your triggers, and I was wondering if you could share what those are. And my second question is, in terms of modifying risk factors, it was mentioned alcohol and smoking, and I'm wondering about caffeine intake.
There we go. Sorry. So the triggers that for me, are that I've found are lack of hydration. So if I'm not drinking enough water, caffeine, alcohol, stressful, like high stress moments. Like so a time when it's just like zap, you're in a kind of really stressful situation. Those ones will just I can feel my heart start going weird. So those are the ones that are the ones that I really try to manage carefully. And what's the other question? Was that for me or for?
If caffeine is a trigger.
Oh.
What I tell patients for caffeine, it's like 1 cup a day is okay as long as it's not triggering your AFib. If you see that you can't have a cup a day, then obviously stay away from it, but trying to limit to that 1 cup a day, because yeah, if you have numerous cups, it can trigger for sure.
Yeah, it's actually a very controversial question, so thanks for that. It's so based on the studies, there's no direct link between caffeine intake and atrial fibrillation. However, we've seen in some patients that it does trigger AFib. So we can't say, oh no, there's no science behind this. So there's some, I think a part of this is basically related to the amount of caffeine and coffee intake. And in some studies, as I mentioned, there's 1 or 2 cups of coffee a day actually helps with AFib, helps with stroke prevention and heart or against heart disease. But too much is going to be, even if it's not going to trigger atrial fibrillation or worsen the symptoms, it's not good for the health and basically increase your sympathetic activities and your anxiety in general. Yeah, but yeah.
Yeah, I'll just add to that because I didn't say, and I'm going to throw it in now, because negative emotions can influence the patient's AFib symptom report. So if someone's a little bit more anxious to begin with and then they have caffeine, it's probably not a good combination. So it's actually just knowing yourself and knowing your patients in terms of how you respond to caffeine and where your sort of stress levels are as well.
Thank you, everyone. Quick question. There was a lot of talk about risk factors and doing physical activity, which I think is wonderful. I'm wondering about the other side that I've also heard sometimes is like the elite athletes that then develop AFib. And I just am curious, you know, how common that is and, you know, what is the mechanism there? Like, it just doesn't fully make sense to me.
Yeah, thanks for it's a great question, and we've seen this in some of the athletes in the clinics. We don't know, bottom line, we don't know exactly what's happening, but it's a different mechanism to the one that's linked to exercise. So basically, in general, exercise reduces your inflammation burden in your body, increases your blood circulation and make less fibrosis. However, in some patients who are athletic, and we've seen this in clinics here, there are two things that we know, not for sure, but one is genetic predisposition, and number two is the muscle mass. So increased muscle mass, including cardiac muscle mass, could sometimes be linked to higher intra-left atrial pressure, and this could trigger, but bottom line, we don't know for sure. So, but thanks for the question. It's a great one.
This question's for Anne, so yes, keep the mic. So I'm in PACU corporately, but we do cardioversions every Tuesday morning. Are you following the population that does the cardioversions in PACU?
Only if they're sent to me.
Okay.
So yes, like technically I invite everybody to send me a message if this patient needs education or whatnot, because it's very important. I want to reach as many people as possible. That's the thing, right? If I don't know they're there, then I can't help them. So yeah, for sure. Like if somebody is like, oh, I don't know what I'm doing and I don't know what this is, definitely invite to the class and all that stuff.
Okay, we're just going to do an online question.
Hi, could you comment on the recent BMJ study that concluded that regular fish oil use may pose a risk for AFib?
Yeah. Well, thanks for the question too. I'm not aware about the, about this study or the depth of the study, but from what we've known that in general, omega-3 or fish oil could be helpful in the heart disease, and this could have indirect effect. However, I can't say there is a strong positive link or association between those two, so I'm not sure. I don't want to confuse you two.
We'll do another online one.
Is there any effect of cannabis on AFib?
And that's a wrap.
Again, thank you for the question. I'm not aware of any direct positive effects on or protecting against AFib. So I won't be able to answer this question. Sorry for that.
Okay, so I had you over here.
More just like a quick comment or question. Just the whole stigma surrounded with women and anxiety. Like if a man walked in with the same symptoms, they'd be on every monitor. How do you convince women, or do you coach them to sort of advocate for themselves to get the help they possibly need?
I'm going to get on a soapbox. So hang on a second. You're 100% right. It's hard, and that's why I hope I emphasized enough. Just because there is a bidirectional relationship between mood and our heart health does not mean it's in our head, or that we're being overly anxious or crazy or any of those things, right? So it is really kind of emphasizing. I almost want to take it as a more of an investigative approach to say, these are the symptoms that I've had. This is how long I've had it. I understand that stress. It's almost like beating them to the punch, right? I understand that stress is a part of it, but it is more than just stress. It comes at other times. It is impacting my quality of life. I need a medical management of these symptoms, and just really reinforcing in a very sort of directive way. Yeah, this part is obvious. It's this part that I'm looking for, and being slightly annoying about it. And don't be afraid of being slightly annoying about it. I'm using that judgmental term on purpose, but again, if a man were to say, this is the third time I've come into the office about this, we would say, oh, geez, we really need to take care of that. So it's recognizing it's okay to do that. I don't know if there's anything else to add.
Just advocate for your health. I think that's what I would say. And just push if they're pushing back, just push.
I think it's really interesting in the Women at Heart peer support groups. I hear a lot of stories about the number of times that people have gone to their medical professionals to talk about the same thing before a treatment happens, and that we talk about communication and how to take this space that you need to take to deal with the issues that you have.
Okay, perfect. And that's all the questions we have time for today. So I'll hand it back to Tori.
Thank you so much to our presenters for this panel. That was super interesting and great engagement. We're going to shift gears a little bit now, and we're going to move on to our next sort of all-encompassing topic of cardiac resources. To get the ball rolling on this, I'd like to introduce Matheus Hausen, who is a postdoctoral fellow at the Exercise Physiology and Cardiovascular Health Laboratory. I'll let Matheus tell you about his research specific to physical activity and cardiac rehabilitation.
All right. Okay. So good afternoon, everyone. Thank you very much for your attention. Thank you, the committee, for the invitation. And today I'll talk with you about research updates in physical activity. So the itinerary of our talk, it's hard to actually summarize more than 80 years of research in physical activity, but try to bring the fresh evidence and try to inspire your practice. So first we'll talk about physical activity review. Next, those response between physical activity and cardiovascular health, and physical activity in cardiac rehabilitation perspective. So first, let's just go here. Okay, all right. So first, defining physical activity, which is, sorry again, okay. Any behavior that results in an elevation of energy expenditure above resting levels, and this can play different across domains, different moments of the day, and the room for change is different from occupation, family care, transportation, leisure, and exercise, which is we can improve our terms of prescription, controlling variables, but other phases of the day are definitely harder to change this behavior. And also we have key determinants of active lifestyle, socioeconomic status, cultural background, neighborhood infrastructure, and environment, global warming. So those determinants can also be barriers to adhere into a physical active lifestyle that we need to acknowledge. So this first review illustrates very well in this schematic how physical activity actually, first, is important to be promoted by a safe environment, and physical activity play a vital role in prevention of risk factor and also managing the outcomes of ongoing diseases, and physical activity will vary across lifespan. About the we have more than 80 decades of research in physical activity that started with comparison between job types that require different energy demands, then moving to questionnaire that attempted to estimate the energy expenditure across different modes of activity, then with the objective measurement with pedometers for step counts, accelerometers to determine movement, and currently we are getting into a new phase, which is the wearables and the phones phase that is very promising as well. So those decades produced robust recommendations, guidelines, and currently we have guidelines across different life stages from utero, childhood, adolescence, and adult. But for midlife and older adult, it's not a consensus. Here in Canada, we have a strong guidelines from the Canadian Society of Exercise Physiology that not just covers physical activity in terms of volume. We have 150 minutes of moderate to vigorous physical activity, and also muscle strengthening exercise, physical activities with balanced training as well, and also sleeping and sedentary behavior recommendation, like 7 to 8 hours of good sleep and no more than 3 hours of recreational screen time, and breaking up those periods. But still, it's hard to prescribe or design programs for these age groups, especially because aging and functional capacity doesn't appears in a linear model. So one way to tailor and improve those interventions is assessing frailty. Frailty is decreasing functional capacity following a stressor event, with this capacity remaining at lower levels than baseline after recovery events. As we can see, we have developed a framework depending on the level of recovery. We have several steps such as pre-frailty, and this can be assessed through the frailty phenotype that comprises low grip strength, slow walking speed, exhaustion, low activity level, and weight loss. And also there's a frailty index with more than around 40 domains that also helps to assess frailty levels. And it's important to acknowledge that physical activity is part of the main factors that promotes the inflammatory profile and increase the level of frailty. And frailty, we know that the risk can be increased through several factors such as gender, ethnicity, socioeconomic background, education, habits such as smoking. On the other hand, we have protective factors such as healthy diet like Mediterranean diet, and of course exercise. And it's also important to acknowledge that people with frailty may present significant high rates of cardiovascular disease, and also multimorbidity, polypharmacy, sarcopenia. So highlighting the importance of tailored programs to stimulate active lifestyle according to the level of the functional capacity, which is important to provide safety and effectiveness. Now, jumping to the second part of our presentation, we discuss some dose-response relationships with study that covered populational studies and tried to assess physical activity levels with cardiovascular and overall mortality and disease incidence. So the first study performed a huge meta-analysis with study with more than 10,000 participants in a total of 30 million participants in the meta-analysis. And after the regression, the modeling of the relationship between the physical activity and mortality or incidence of overall cause disease and cardiovascular disease, calculating according to the actual recommendation, also found the proportional of preventable deaths around 60% for all-cause disease and 12% for cardiovascular disease. However, if we observe the half of this dose, this volume, we already can observe some significant protection from overall disease and overall death and cardiovascular death. And of course, if we increase our volume, we have higher protection. Next, the second study observed that in a big cohort with more than 200,000 participants, they observed that several types of activity may actually protect cardiovascular system and reduce the risk of mortality. We have bracket sport and running sport as the highest, with the highest levels here, but the key message of the study is that other types of activity counts as well. So it's important to choose one that's more sustainable, more long-standing to the individual. In this third study, authors compared the difference between female and male protection from physical activity. And they observed that women received a higher protection for the same doses of physical activity, both from aerobic activity and muscle strengthening activities, for both all-cause and cardiovascular mortality, which we conclude that women are more protected for the same doses of physical activity than men. So this information is very important to be used to disseminate and promote the participation of women in physical activity. This other study, a meta-analysis, it gathered several studies that in this time not focused on physical activity, but on sedentary behavior. So sedentary behavior, we can define as activities undertaken at a low energy expenditure, lower or equal to 1.5 metabolic equivalent, like sitting, lying, or reclining. So just for designing programs to reduce those habits, it increased the cardiorespiratory fitness around 5 to 10%, depending on the level of the participants, showing that only attacking the reduction in sedentary behavior has an effect in certain ways similar to training. So it's also important to acknowledge that programs must also focus on the sedentary behavior part, not just the active lifestyle, the physical interventions, the exercises. Now to the last part, let's talk a little bit about physical activity in cardiac rehab. So this first study performed from our group performed a survey with more than 600 patients with atrial fibrillation, and they observed that patients did not meet the actual recommendation around 150 minutes per week of moderate to vigorous physical activity, and also used to have a sit time around 6 hours per day, which is already in the margin of the recommended value. Only 3% was able only to correctly identify the Canadian movement recommendations, the one I told you earlier. And 62% were not confident about performing vigorous intensity physical activity. So those patients who present higher values of moderate to vigorous physical activity volume, it was associated with higher healthcare professional support, higher knowledge of the moderate to vigorous physical activity recommendations, higher knowledge that physical activity may help managing other diseases, and understanding that physical activity is not dangerous for atrial fibrillation. This other study performed by our team started an intervention for both groups, one performing the standard care moderate intensity continuous training. On the other arm, a group performed the high intensity interval training, both in 12 weeks. And authors observed that both increased in the same way functional capacity, also same magnitude for quality of life in physical functioning and mental component domains. And both were successful in promoting the same statistical magnitude, the levels of moderate to vigorous physical activity. So the conclusion is that the HIIT, which lasts a third of a standard care training duration, is effective as well to promote benefit, improvements in mental quality of life, cardiovascular outcomes, but also impacting the active lifestyle of patients. Now moving to technology a little bit, let's talk about the usefulness of an app with patients. This study used an app to not just prescribe training sessions, but also send messages to engage, to motivate participants to continue on cardiac rehab. And what after they performed some interviews with these participants, patients reported that it was beneficial in promoting physical activity, but it lacked personalization according to the goals, fitness level, and they complained about the lack of a real-time environment. So technology plays an important role in connecting patients to healthcare providers, but can't be simply replaced by a chat box or of course, we can use technology to improve education dissemination, diffusion, but won't replace the actual human care, human contact with professionals. And these are the arm from the same big study, actually. They tested the use of wearables. We had Apple Watch and Fitbit Versa during the intake phase, the baseline phase of the cardiac rehab program. And it was successful, it was feasible. So showing that we can apply this technology in terms to expanding the possibilities of care of more patients, especially for those who live far from the cardiac rehab facilities. So I think it's good to understand that we can apply the technology, not just to come closer to the patients, but also expanding the level, the capacity of care. So to summarize, to share with patients, physical activity plays a central role in preventing cardiovascular disease through life scores. Programs must consider patient specificities, including social aspects, infrastructure, availability, and functional capacity. Smaller doses are better than activity, and personal preference may impact patients' adherence to a long-standing active lifestyle. Women have received higher cardiovascular disease protection from physical activity. Exercise intervention may also affect other domains of active lifestyle. Education must be prioritized to improve self-efficacy in engaging in adequate volume intensity of physical activity and reducing sedentary behavior. And finally, technology may assist patients' assessment and engagement. However, personalized interactions with professionals must be prioritized. And that's it. Thank you very much.
Are there any questions?
Hi, I'm wondering what you can say about later intensity, longer duration for people who have comorbidities that might prevent them from engaging in moderate or vigorous activity, as well as kind of those 10-minute bursts of activity and how that contributes.
That's a great question. First, we don't have a single answer for like one fit all, but the key message is tailoring. So it's important to first perform a good assessment in terms of not in terms of functional capacity, metabolic, cardiovascular limits, and we can prescribe within safe zones. And about the bursts, as I said before, guidelines, they lean to promoting as much as possible physical activity with higher bursts. So even small part we call exercise snacks. So if we can engage in more high intensity activities, even in short duration, may also affect and help with cardiovascular protection. Thank you. Thank you.
Thank you very much, Matheus. So it is time for lunch. The food has arrived. We're just going to take a couple seconds. There's a lot of food. Thank you very much to Novartis, our sponsors for the day. We're just going to set a little bit more up at the front, but please start lining up. And another little plug to please fill out the surveys. They really do help us shape these days, and it would be much appreciated. And you can enter for a chance to win a prize. We will reconvene at 12:45. Session, so be sure to fill that out for your chance to win a prize. So carrying on with our cardiac resources portion of the day, I'd now like to introduce two of our virtual care nurses here at the University of Ottawa Heart Institute. Donna Macleod and Jennifer Morand are going to speak to us today about what they do specific to telehome monitoring. Okay.
So, thank you for the introduction. I am Donna Macleod.
And I'm Jennifer Morand.
In this presentation today, we'll focus on technologies that we provide in cardiac virtual care and the programs that we offer. Our staffing model consists of our manager, Amy Charlebois. We have 3 full-time RNs. I myself manage heart failure. Christina Gosselin manages cardiac surgery. Jen Morand, she splits between both heart failure and cardiac surgery. We have 1 part-time nurse, Marianne Yakubchuk, and she does the overflow of heart failure and ACS IVR. We also have 1 casual RN, and we have an additional full-time RN that will be implementing the regional program.
The objectives of our program are to reduce hospital admissions and improve patient outcomes. When compared to standard care, patients being followed in telehome monitoring have a reduction in readmission rates and in general feel more comfortable transitioning from hospital to home. In our program, we mainly follow cardiac surgery and heart failure patients. However, we do provide equipment to the TAVI and hypertension clinic. Patients are provided with a blood pressure cuff, a tablet, and a scale, and some may get an O2 monitor. And patients are required to transmit their vitals daily. This information is then transmitted through the Cloud DX platform, where it's reviewed by our cardiac specialized nurses. So from here, we review all the information, and the nurse can implement individualized care. So this may be medication adjustments, it may be arranging clinic visits, and self-care education. So we do have inclusion and exclusion criteria for our program. For the cardiac surgery following, we try and follow patients who are at high risk for readmissions or complications. So this may be patients who are above their pre-op weight, if they have a new post-op atrial fibrillation or other sinus or other rhythm issues, if they have a reduced ejection fraction, if there's any wound concerns, or if they're at high risk for pleural effusions.
So I'll discuss the heart failure monitoring. We are an acute intervention model, which means patients who are deemed high risk for heart failure exacerbation. Reasons for referrals include fluid optimization, which is basically diuretic adjustment, medication optimization of GDMT, ACE, ARB, ARNI, beta blocker, MRA, and SGLT2. We can also follow patients who are on IV milrinone, allowing assessment of daily weights and vital signs. If not accepted into our telehome monitoring program, and I will go over the inclusion/exclusion criteria. Patients can be referred to the GDMT clinic, which allows for more stable heart failure patients. Patients can also be enrolled in our heart failure IVR program. So inclusion criteria of patients to be followed in cardiac telehealth. Patients must consent and agree to the conditions of the program. MRP, which is the most responsible physician. Ability to use equipment independently and safely or with assistance. Responsible for giving their own medications. We must be able to communicate with our patients who can speak English or French, or there's an interpreter who can. I am currently actually following 2 Spanish-speaking patients who have family members who speak English. Exclusion criteria, non-compliance. We expect daily transmissions, and we need to have the ability to contact patients. Patients who live in long-term care facilities where they don't give their own medications. There's no fixed permanent address. No phone or cellular reception is available. Dialysis patients and palliative care patients. But in saying that, if a patient is referred, we have an APN, Freya Kelly, who has the ability to monitor patients using the Cloud DX equipment.
So how you can refer to our program. So internal referrals, you can call the telehealth office, or you can submit an EPIC order. If consults are put in place over the weekend, we do try and follow up on the Monday or the next business day.
So how to refer externally, you can fax the consult to us, or you can telephone the cardiac telehealth office.
So for equipment setup and returns, we ask either the patient or the caregiver to drop off or pick up at the front lobby. If it's an internal referral, we do try and set them up while they're here with us at the bedside.
So within our platform, we have the ability to add surveys. Examples, we have CHF survey, do you have swelling, shortness of breath, medication changes, appointments with physicians, and Trusto initiation surveys. We also have the ability to ask or put in a satisfaction survey, which we send out prior to conclusion of the program. Our recent data shows 100% of our patients are satisfied, 86% are very satisfied. One of the other programs we will discuss is IVR, interactive voice response.
So interactive voice response provides self-care education and symptom screening with automated triage calling. Automated phone calls are sequenced based on the programs, and a designated IVR nurse will follow up on these calls that are flagged. So this will start as early as day 2 since being discharged home. Other IVR programs that we have here at the Heart Institute include the atrial fibrillation, the TAVI, and the prehab. And we follow we follow more closely the ACS and the heart failure, the ACS and the cardiac surgery. And so just to give you an idea, there's about 300 to 400 referrals monthly. So it just goes to show you an idea of how many patients we can surveillance at one time.
So within these departments, I will mention the length of time patients are followed. Cardiac surgery prehab until surgery date, post-op surgery 52 weeks, TAVI is 52 weeks, ACS is 52 weeks, AFib is 52 weeks post-ablation, and heart failure is 12 weeks. Each program has a different schedule of calls that are made. So we are all aware that technology is the way of the future. We began this program of remote monitoring in 2005, and our mission in cardiac virtual care through UOHI has been and still is to improve areas of specialized cardiac services using our advanced technologies, allowing accessibility for all. I just have to mention, a cardiologist recently asked me, what's the cost of monitoring a patient? My answer at the time, he also agreed, was priceless. This program not only includes the use of advanced equipment for daily monitoring, but is also comes with an expert heart failure and cardiac surgery nurse who take these daily transmissions, make a plan of care to allow the patients the best possible outcomes for their health and for their future.
So, and this is our manager, Amy Charlebois' contact information. If you have any questions about the regional program or any questions or concerns about our telehealth monitoring program. Thank you.
Thank you.
Are there any questions in the audience or online right now for Donna and Jennifer? Thank you. Thanks, guys. Thank you very much, Donna and Jennifer. So now here to provide us all with an update relating to some cardiology changes are Lindsay MacArthur and Nicole Andrews. Lindsay is an advanced practice nurse, co-chair of the Nursing Clinical Practice Committee and manager of the new Act 2 unit. And she's an overall busy bee here at the University of Ottawa Heart Institute. Nicole is a registered nurse in our new acute care transition unit, and we are so pleased that they could be here today to provide a cardiology update.
All right, thanks so much everybody for having me. For those of you who don't know me, my name is Lindsay, and I'm the advanced practice nurse for cardiology.
And I'm Nicole, one of her new employees. I'm one of the registered nurses working in the Act 2.
So for an overview, we're going to be talking about NitroCyst, which is the application we have developed, and I'm actually going to ask for the audience to participate in this, so ooh. And we're also going to go over the heart failure booklet updates. So what I'm going to get everybody to do is actually pull out your phones and scan that QR code there. So this is actually the advertisement that we have provided to patients. And so the point of this app is it's not actually an app you can get off Apple, but it's actually a desktop application. So for instructions on how to upload this onto your phone, you just need to email acsapp@ottawaheart.ca. Additionally, just as a side note, this information can now be added onto the patient's AVS, so their after visit summary when they go home. So please do it. This is for all patients, so not just patients in the Heart Institute. So for English, it's .nitroassist English, and for French, it's .nitroassist French. So one of the questions I often get when I do talk about the app is why don't we automatically have it on the AVS? And this is because nitroglycerin is not appropriate for everybody. So you guys kind of need to only give it to patients who are actually prescribed nitroglycerin, you know, for patients who don't have any other contraindications, such as aortic stenosis. So that is very important, okay? So let's see if I'm tech savvy. And I am. Okay, so this is basically the first screen that you're going to see when you open the application. So I'm kind of going to go into the audience. We'll all kind of work through this application together, and Nicole is going to be the yes or no hitter, okay? Okay, so when it first comes up, basically, you know, you're going to let them know if you're experiencing chest pain now. So who wants to give the first answer? Oh, thank you so much. Yep.
Oh, yeah, I'm sitting already. Yeah. That's good.
Prime the pump before using. Point the spray away from yourself and others. Place the bottle upright. Press the button and continue to do so until you see the medication spray from the bottle around 5 to 10 times. You guys still have chest pain. Yeah, it's bad.
Yeah.
Yeah.
So then you can see there that we have a visual demonstration of kind of how to walk through the nitroglycerin spray. So we recommend obviously that patients stay seated, and then a timer will actually start that will actually count down that 5-minute interval, okay? Obviously, there is the note that if the pain is severe, or if you feel like you're weak and you're going to pass out, then obviously we want to make sure that they call 911 now, okay? So then we're going to skip because we don't need to wait 5 minutes. Okay, so now do you still have chest pain?
Oh yeah, 9 on 10.
All right, so a little bit of a simpler screen. So, you're going to stay seated. You're going to take the one spray, wait 5 minutes. Once again, that reminder that if the pain is severe or if you feel weak or like you're going to pass out, to call 911. You don't need to listen to me ramble for 5 minutes, so we'll skip that. And then lastly, are you still having chest pain?
Down my arm too.
Okay, so pretty serious. So we're going to go with yes, and then it tells you to call 911 and take another spray. So we're going to go back to the start now, though. So just hit that back to start button there, Nicole. Perfect. So just say a patient does open the app and they're actually not really having chest pain, but they actually just want more education resources. So that's also included in the application. So if you just click no. So there's all the links to all the resources. So, there's the patient guide, there's also the stoplight tool, as well as the nursing coordinator line. This will also come up if throughout them working through the application, just say, after one spray, the pain resolves, then they'll still get the links to all the resources as well as when to call the nursing coordinator. So it's kind of a great way for patients to work through how to manage their chest pain at home. Ultimately, it does save you guys, a little bit of the work in terms of, going over and over and over that. I don't know about you guys, but sometimes I've been working a night shift and I've gone into someone's room and they've taken 7 sprays on their own, or, you hear about a patient who comes in and they've taken like 15 and they bottomed out their pressure. So, it is a really key, good teaching point, and also with the timer to really make sure that they are taking that medication appropriately. And that's my Nitro Assist update. So I'm going to hand it over to the wonderful Nicole Andrews, who's going to give the update on heart failure. So just give 1 second.
So who's familiar with these books? Anybody? Oh yeah. All right. So we've had a few updates to these books. The first one is for CRTD devices, or cardiac resynchronization therapy devices. So these are devices used for patients who are still symptomatic with heart failure despite optimal medical management, or they continue to have worsening heart function despite treatment, or they have conduction issues and need a pacemaker. So the difference with these devices are there's actually 3 leads that are implanted. So there's one in the right atrium and one in each ventricle. So it helps the heart kind of pump more synchronized together by giving that extra stimulation. They can also be used for defibrillators as well. So they are plus or minus a defibrillator. So we tried to keep the information as simple as possible in this book because not every patient's actually going to be getting one of these with heart failure. It's just to give some more education and a starting point. So if you do have patients that are having one, you can give them teaching points, and it's page 7 in the booklet now. Oh, I did that too soon. I was going to say, who knows that there's new guidelines? All right, so our sodium restriction has actually gone up. So it's now 2,500 milligrams. And the previous restriction was 2,000 milligrams. So in kind of context, 1 teaspoon has 2,300 milligrams of salt, which doesn't seem like a lot, but the World Health Organization in 2022 said the global mean average intake of adults is 4,310 milligrams in our diets. So yeah, that's quite significant. Did I break it? So it's important to identify common hidden sources of salt. We always say take away the salt shaker initially, but also it's hidden in a lot of foods and people don't necessarily taste them. So one thing to consider is my colleagues taught me the longer that something is going to last on the shelf, the longer the expiry date, the more salt it has in it. And also there can be quite a difference between low sodium labels. So if you look at your stocks, for example, one brand, they're all low sodium because they meet the guidelines. But if you look at one brand versus the next, there can be quite a difference in that. The main thing is for patients to choose something less than 10% of their daily values. And all of this is in the booklet, and then there's some additional resources there, but those are kind of the key points we give. The other thing that has changed is the guidelines for fluid restrictions have gone up. So it used to be 1.5 liters was kind of the gold standard. Now it's 1.5 to 2.5 liters. However, it's whatever the cardiologist says it is. So the important thing is to get the what the cardiologist thinks and teach that to the patient. So yeah, and then also reminding patients that fluids are anything that is liquid at room temperature. So a lot of patients like to chew on ice to kind of get that thirst from the Lasix and that, but that also counts as liquid, and same with soups, like broths and soup as well. Okay, and Telehome was talking about GDMTs. So this was new for me when I started here because it's been quite a while. GDMTs are guideline-directed medical therapy. So it's used for heart failure patients with reduced ejection fractions. It includes 4 key pillar medications. The first is angiotensin-converting enzymes inhibitors or ACE inhibitors, like perindopril or ramipril, or an angiotensin receptor blocker such as candesartan or valsartan, or angiotensin receptor neprilyzine inhibitor, an ARNI known as Enstro. Most of them dilate blood vessels, but the nice thing with ARNIs is they also provide a bit of diuresis as well. The second pillar is a beta blocker, like bisoprolol, Monocor, metoprolol. The third is a mineral corticoid receptor antagonist. So spironolactone is another one. These are nice because they help with diuresis, but spare potassium, which could be an issue. The fourth pillar is the newest one, which is added, is sodium glucose cotransporter 2 inhibitors, SGLT2 inhibitors. Examples of these are dapagliflozin and empagliflozin, so Jardiance and Farxiga. So with these ones, they're used in patients who aren't necessarily diabetic or have high H1Cs. They're used because they've been proven to help with heart failure as well. So despite their normal sugar. So the biggest education point with these is that they increase sugar loss through the urine. So really good pericare is important. So it'll help mitigate some of the side effects like bladder infections, vaginal yeast infections, and for males, rash or redness of the penis or the perineum. But just because there's so much sugar coming out. So it's just something to keep in mind. We're done. Thanks so much.
All right, thank you for that, Lindsay and Nicole. Next, I would like to introduce Tammy Lafreniere, one of our senior physiotherapists in the inpatient and outpatient population here at the Heart Institute. Tammy's going to provide us with an update regarding sternal precautions.
Thank you, Tori. Hello, everyone. So my name is Tammy. I'm the senior physiotherapist here at the Heart Institute, and I'm pleased to present to you today on sternal precautions and our new standardized approach that's throughout TOH. So I'm going to give you a bit of background on sternal precaution. We had originally created those sternal precaution to try to minimize the wound complication. So it was the assumption that by restricting movement, it would help with reducing that sternal instability and try to promote better healing. But in fact, with time, we did realize that strict sternal precaution can potentially lead to deconditioning, loss of mobility, longer return to function in cardiac and thoracic surgery patients. So there are several studies that did some evaluation on the force exerted on the sternum during various tasks. Just to give you an idea, with a cough, that's going to create about 60 pounds of pressure on the sternum, and a sneeze, 90. So of course, that repair can certainly sustain a bit more than we originally thought. So we also seen a randomized trial that was published in the Journal of Physiotherapy in 2018 called the SMART trial. And it shows that standard sternal precautions and modified sternal precaution had a very similar effect on patient post-cardiac surgery in terms of patient recovery, pain, and quality of life. So sternal precaution in our institution are based on individual patient characteristic, risk assessment, and clinical status of recovery is also considered when we prescribe sternal precaution. When I say we, I mean the surgeon. The algorithm here presented is used by the surgeon to categorize patient in terms of risks of complication based on certain criteria. So at the Heart Institute and TOH, we have two streams of sternal precaution that we use. So we have modified sternal precaution for low risk population, and we have standard sternal precaution for high risk patient. So I will review the risk factors with you, and I'm going to explain a bit more the difference between the primary risk factor and the secondary risk factor. So for the primary risk factor, if patient had any of the following, well, of course, they should be categorized as a high risk of complication in that group. So of course, depending on the patient body habitus, if they're obese or large breasted, that could certainly pull more on the incision. If they had sternal rewiring, or just during their hospital course, if they're deemed to not be healing properly, then they should definitely be in the standard sternal precaution group because they're high risk. So the secondary risk factors, it's more of a combination. So if patients have two or more, then obviously it's better to stay conservative. So let's say we have a patient, diabetic, and a smoker. Kind of know that's a recipe for a disaster. So we're going to make sure that, we keep them in that stream. If a patient has cognition impairment, depending on the level, again, with a combination of other criteria. During intra-op, if there were any complications, so lots of blood loss, or if the patient were ventilated for a long time, or just in general, the surgery took a long time, that's something that the surgeon will think about while prescribing the precaution. And depending on the surgical specifics, so if they took the internal mammary artery, well, of course, to do a bypass graft, that could have an impact. If patient have in their history decrease in bone density, that could be due to osteoporosis or maybe a previous cancer treatment. That's also something that the surgeon will look at. So here at the Heart Institute, we have the EPIC system that we use. It's an electronic medical record software. So the surgeon will place their order. We use a cardiac sternal precaution order, and there's
always a description in each option that they choose if ever they need a refresher. Okay. So I'm going to go in details and describe you here a bit the difference between the two stream in this algorithm. So I'm going to start with the standard sternal precaution. So first, we tell patient not to be pushing, pulling, or lifting more than 10 pounds with their arm for 8 weeks after surgery. And this is to help proper healing of the sternum, of course, with those high-risk patients. I have nice pictures to show you. This is Audrey, one of our physiotherapists. So we do allow minimal to no use of the arms for transfer for patient. So these pictures showcase well how to do it, but I'm going to explain it to you. So we encourage patient to use a teddy. So it's our term for that light pillow that they can use to hold on, just as a reminder to keep their arm occupied instead of trying to push or pull. Okay, so on the first picture, of course, we're going to tell the patient to bend their knees up as high as possible and crossing their arms over the pillow, and they can roll onto their side completely, lower their feet at the side of the bed. They're going to need to use a bit of their abdominal muscle in order to be able to get up, but they can push slightly with the elbow because we're using a different muscle rather than the one that could pull the incision apart. Okay, so of course we're going to tell them to continue to hold the pillow so that they don't try to push with their hands. Getting back into bed, it's pretty much the opposite. So we'll tell patient again, keeping their arm crossed over their chest, leaning to the side. They can kind of fall gently. They can use the elbow to help to control that way down and bring the legs up. For some people, it's easier to bring just the one leg at a time, depending on their capacity. So standing up, it's important again for patient to hold their chest. So the technique we're going to tell the patient, depending if they're sitting on a chair or at the edge of the bed, they may need to shift their hips and weight forward to get a little closer to the edge. Okay, so we're going to teach them to look ahead and to try to bring their nose over their toes just to get a better motion. So we tell the patient to use their legs, lift up, their hips off the bed or the chair, and get their knees straight to stand up. So some patients, if they have a bit more weakness in their legs, they may need to rock forward a few times to get a bit momentum, okay? Because if they can't use their arms and they've been using their arms all their life, it's a bit difficult for them to change that habit. So in terms of range of motion, for the standard sternal precaution, patients are able to have full range of motion for the shoulders and shoulder blades, of course, as long as it's pain-free. So in the event that the patient would be, reaching and feeling a clicking where the incision is at the sternum, we would tell the patient, of course, to avoid that motion for a few days, and hopefully that would resolve. So in terms of, healing normally, usually in that population, after 8 weeks, patient should be able to return to their regular activities. But of course, if they're not healing well, it's going to be important for them to, see the surgeon, or at times they're going to have met the nursing coordinator before if there were any issue with the healing of the incision. But they should certainly remain following precaution until they're all clear. Now, the moment that you probably are wondering if you're not too familiar with the modified sternal precaution. So this is for, again, our low risk patient. So we teach them not to push pull more than 20 pounds with their arms. With that being said, they have to make sure that they keep their elbows and hands close to the body. We also use the term move in the tube. So that was based from a study there done in Texas. So I have, again, nice pictures to show you. So in terms of the transfer, so the patient, they could use a teddy if they want, but if they want to use their arms, that's okay, as long as it stays close to the body. So we tell the patient, again, same technique, bending the knees up as high as possible, rolling on the side. So they're going to use their elbow and they can push a little bit with their hands close to the hip. So once they're in a seated position, it's easier that way to get balance. They can put their arms at the side of the body. And we've seen it clinically. Those patients are actually moving a lot better too after surgery. It's easier for them to move around, and it's not as big as a burden on the nursing staff as well. So the technique to lay down would be the same thing, but opposite. So standing up from a chair or a bed, patient would be thought to either keep their hands close to the body, so on their thighs, as in this picture, or just beside it, and they can push a little bit. Trust me, I usually slip my hand the first few times to see how much weight they're going to put, but it's never close to 10 pounds. So for sure, we're safe in that matter. In terms of range of motion for that population, we still allow them to have full range of motion for shoulders and shoulder blades. Again, if it's not comfortable, there's a click or there's pain, they have to let us know, and they shouldn't be doing that motion, of course. So with that group, they need to follow those precautions for 6 weeks, which is a bit different than the other group, because we know they're going to heal a bit faster. So if everything goes well, then they can just return to their normal activity. But of course, if there's any issues with the healing, they may have to keep those modified sternal precaution, or if it's a major issue, then they could be changed into the strict group as well, if need be. What I want to cover as well too, for both groups, we ask for female patient to wear a bra if they have like a C cup or higher, which will help to the healing of the incision after surgery. And patient are not to be driving until they see their surgeon afterwards. And in terms of coughing or sneezing, well, for both group, doesn't matter. Using the teddy to support the cough is really indicated here and encouraged. So they have to put quite a bit of pressure on it. That way it's not as painful. And they're often able to have a stronger cough as well. So in terms of patient education, well, of course, throughout their stay with us, physiotherapy and the nursing staff are involved right after surgery. So we teach them all the steps. We make sure that they're independent to do it before they go home. At times, I will say, they're struggling perhaps with one of those motions. So we can teach family as well how to help them in a safe manner for them and the patient. But that's rare. Usually when patients are going home, they know how to do it. We will provide them, though, with a sheet with information on how to do it and why. And at the moment, we just slip this page here in their recovery from cardiac surgery booklet, but it's in the works to getting updated since we have those 2 streams now at the Heart Institute. So patients are able to refer to that at home, and also family as well. So by prescribing the adequate sternal precaution, we're hoping to have an impact on patient outcome, of course. So we're hoping to have an impact on decreasing the length of stay of patient. And we did a pilot before putting that in motion, and we did see a difference, which led us to move and adopt those 2 streams of sternal precautions. So we're also hopeful to improve post-op function in those patients and for them to return to function a little quicker. So we're hoping to have an impact on surgical infection or dehiscence. And at times, patients are able to participate in inpatient rehab program because they're following the modified sternal precaution. So overall, we do want patients to be satisfied and have the best experience, but of course, it has to be safe for them. So this is my information. If ever you want to reach out and you want more information on sternal precaution, I'm happy to talk to you in private. But if anybody has question at the moment here, let me know.
Great. Thank you for those updates, Tammy. I was kind of hoping you were going to do a demonstration, but that's okay. Moving along with our cardiac resources portion, I'd now like to ask Julie Sawyer and Amy Charlebois to come up to the podium. Julie is the current care facilitator for the Division of Cardiac Prevention and Rehabilitation, and Amy is our cardiac surgery advanced practice nurse, and they are here today to speak about the ERAS and prehab program.
Hi, everyone. Well, first of all, thank you so much, Tori, for that awesome introduction, and thank you so much for the opportunity to present today. So I'm Amy, and this is Julie. So we're going to go ahead and do a little presentation to you guys about ERAS. I call it ERAS, yeah. But yeah, exactly. Oh, who said that? You must have, you know my presentation? Sorry, you'll see, yeah. So yeah, we're gonna just do a little intro. We're gonna talk about ERAS. We're gonna talk about our surgery outpatient prehab program, and then a new thing that we're gonna be starting for our inpatient program, and then we'll have a little Q&A after. So, ta-da! So ERAS or ERAS, what is it? It's not the Taylor Swift tour, that's for sure. But it actually probably maybe just as popular. So ERAS it is for us, yeah. So ERAS, just so you guys are aware, it originally was developed, their best practice guidelines that were developed more for other types of surgeries like knee or hip surgery. And in 2019, they actually developed guidelines for cardiac surgery, which is very exciting. So these are evidence-based protocols for perioperative care. So it helps to optimize patient outcomes, delivery for healthcare efficiency and cost savings. So they're based on principles of best practice, standardized, consistent healthcare delivery. It allows for team feedback. It's multidisciplinary, which is the key as well. Patient-focused center. And the main goals, of course, is to reduce complication, promote early return to normal activities, and quality of care, of course, for our patients. So there's actually different components of ERAS. So you can see up here just a quick look. So 1, 2, 3. So pre-op, intra-op, post-op. We're really going to kind of be focusing on that pre-op optimization. And Julie's going to kind of go more into that for you guys shortly. But really what that really focuses on is the guidelines kind of list all those important standardized things that we know help our patients do better. So pre-op education, developing a prehabilitation program is in the guidelines, ensuring smoking and alcohol cessation, nutrition optimization. A lot of people don't realize how important nutrition is. It's actually really like a medicine. We talk to our dietitians here at the Heart Institute who are experts in that. So yeah, so that's kind of the key component area that we're going to start talking about shortly. And I'm going to pass it on to Julie.
Thank you, Amy. So yeah, I just wanted to give a brief overview of what we are doing for our outpatients that are listed for elective cardiac surgery, as well as TAVI procedures. So as Amy explained, we take this unique opportunity while patients are waiting at home for their upcoming surgery. And we have this ability to connect with them by providing them education upfront
and also try and decrease their anxiety about this upcoming surgery. So that's why we have this amazing prehab program in place. And the objectives of the program are to essentially help to optimize those things that could cause a patient to be at risk for sternal wound infection, if they have poor glycemic control, malnutrition we screen for. We also want to decrease any of the anxieties they have in relation to coming for the day of surgery. We tell them about what the pre-admission unit appointment entails, who they're going to meet with. We basically take this kind of one-time automated call that we give out to these patients and try and really give as much impact as we can to help decrease that anxiety they may have for this surgery, and then hopefully improve their surgical outcome. So I'll kind of give a brief overview of our actual process. A triage will send out this patient a package in the mail that goes over what prehab is, and that this patient's going to be meeting with their surgeon. They're provided the links to the education at that time during that letter, and then they go from there to meet with the surgeon, accept to have surgery. They then receive a they then have a automatic referral to our program, where our nurses will then onboard patients into what's called a TELASK, which is our database that sends out an automated call. And so this automated call has 35 questions that are asked to this patient. And it was developed by our multidisciplinary team. And they're screening questions that will then be flagged by the automated call and have one of our team members call the patient back and try and optimize wherever they have flagged. So essentially, we screen patients for their HbA1c. Ahead of time, we will place patients in community diabetes programs. We try and optimize with their PCP. We'll let them know that as part of ERAS, we would like to get their sugars in the best range as possible before they come and have their elective surgery. We also will refer them to our dietitian. If ever a patient's kind of telling us, you know, I don't have the best appetite, I haven't really been eating well, we'll send a consult and they'll meet with them. Our clinicians are able to meet with patients who have MyChart set up. They'll do virtual Zoom calls as well as telephone calls. And if ever a surgeon is concerned about one of their patients they've met in clinic, they'll actually send me a message or one of my team members, and we'll organize to have these patients seen in person on site. So we can hopefully orchestrate whether they need to be seen by the dietitian, whether they need to have a social work consult, they have financial concerns, or let's say they don't have anywhere to stay after their surgery. So we really have this amazing program in place to help support these patients and get them in the best shape possible. We also go over tobacco use before surgery, alcohol use before surgery, and as well cannabis. It sometimes is an uncomfortable conversation over the phone, but a lot of times during these calls, patients are just thankful that they're getting the information ahead of time, and we're able to kind of ease their mind about, okay, maybe I should start thinking about easing off how many drinks I have each week, because it's going to impact my healing time, and oh, it could impact how long I end up staying in the hospital. So it's really a great opportunity, and I can say from experience, it's going really well. And all that to say that our referrals are the biggest part too. We're able to collaborate with our multidisciplinary team, and we even have community partners such as the RAM clinic at the Royal. So if ever we identify somebody that has ETOH use that is a bit concerning, we can always refer patients to their program as well ahead of time. So it's really a supportive sense for all of these patients and their family members. So just to give you a little idea, I ran some numbers here, and since last May, this is just to give you an idea of how many patients we've actually onboarded into our program. So the blue bar is how many patients we put in the system every month. Now, keep in mind, we usually have about that same amount that come out because they're having their surgeries completed. But at any given time, currently we're managing about 300 patients every month. And so part of the calls that go out to these patients that we did our initial assessments with is a screening call. So every 2 weeks, these patients receive a phone call asking them if since the last time we spoke with them or the automated system talked to them, have they had a change in their symptoms? Are they experiencing any worsening chest pains, pressures, dizziness, and when to seek medical attention? So based on this, we were actually able to implement a medical directive for nitroglycerin as well. So we've been able to ask patients to present to their nearest pharmacy if they don't have nitroglycerin ordered for our cabbage patients. We also have exclusion criteria as well, but being able to talk to a nurse and being able to do an intervention has been huge. I can speak from experience. 3 weeks ago, my patient was a 70% left main. He had no nitro ordered, and I got him his nitro, and he was so thankful. He called me today to thank me. And he's currently admitted waiting for a surgery now. Because I told him how to get to emerge and when to, look for those symptoms, and they've admitted him now. So yay me. But all to say, our team is amazing. I can speak to another patient who called in to say, because your nurse told me to go to emerge, she went in with some leg swelling and some shortness of breath, and she turned out to have a PE and a DVT. So this program is super valuable, and that speaks to my slide here showing you the escalations we've done after those symptom screening calls. So this is just to capture how many times we've asked patients to actually present to an emergency department, and also the amount of times we've said to our triage office, we're concerned about this person, or even having them follow up with their PCP and go, get Lasix ordered because they've noticed they've gained 3 pounds in the past week. They're becoming more and more short of breath. So all that to say, I'm a little biased. I love the prehab outpatient program. So I know how valuable it is. And just by those, patients calling in and telling us and keeping in contact with us through that whole process before they actually come and have their surgery has just been really eye-opening experience, because I used to work on the wards looking after these patients. So now I get the opportunity to get them in their best shape possible. So that's what makes me very excited to see what Amy has in store for the next part.
Thanks, Julie. I agree. The prehab program is amazing, and they have the best staff. We have the best staff everywhere, but cardiac surgery, so prehab for the inpatient. So this is a really great idea that we had. So we have this amazing prehab program for outpatient, but interestingly, give or take, about 50% of our patients are actually not outpatient elective. They're actually inpatient. They're urgent. Some are emergent, of course. So what we're thinking about is what can we do for the other 50% of our patients to help them and optimize them? Yes, we don't have as much time, maybe, but there's still things that maybe we could do, right? So we're mimicking the great minds of the outpatient prehab program, where we want to screen all our inpatients awaiting for cardiac surgery in hospital using the ERAS guidelines as well. So same thing, we want to screen for malnutrition. When I talked to Joanne, one of our amazing dietitians here, she tells me, the information that even eating, I'll roll back a little bit there. When we look at the ERAS guidelines, they tell us that if you eat a good nutrition, like high protein diet 4 weeks before your surgery and 4 weeks after, it actually helps you do better. So it helps your incision heal, decreases your risk for infection. But even if you start that like 3 days before your surgery, it can help you do better. It can decrease infection. People don't realize that these things are like medicine, and they can help us do better. So that's something we screen for. Diabetes as well. If a patient has an elevated HbA1c or glucose, we can get our diabetes team involved to help decrease that before they go for their surgery. Discharge plan. How many times do you have a patient post-op that's like, oh, I didn't realize that I need someone at home with me to drive me to my appointments or to help out with my groceries, that sort of thing. So making sure that they're aware that they do need that support before they have their heart surgery. So then after we have an idea of a plan in place, which as you can see also would help with anxiety and possibly length of stay as well. Mobility, getting our amazing physio team on board. If a patient can't get up without using their hands, that's kind of a key flag. Dental. So dental is actually not part of ERAS, but one of the things for our valve patients, we like them to have seen a dentist within 6 months of their surgery date. So, if they have this tooth that is a risk for infection, we want to make sure post-op that they don't have any risk for endocarditis or other issues. So we want to try and take care of that before. The smoking and alcohol, same thing. Julie already talked about that. We remind our patients that even if you can't think about quitting forever, that 4-week mark is key. 4 weeks before and 4 weeks after. So this would be like an automatic consult to our smoking cessation program, for example, and they're amazing nurses that will come see the patients to get them set up with nicotine replacement therapy and education. Anxiety and depression. About 1 in 5 people after having a heart event actually can experience anxiety, extreme anxiety and depression symptoms. So it's really, really important to make sure that we remember that and that we provide supports for our patients. So even providing education on what to expect can help with that. We have amazing resources through our cardiac rehab team as well. Cognitive screening, making sure that if we have a patient who might have a pre-op, low MoCA, we're not waiting until the night before they're booked for their surgery to find that out or tell the team, making sure that we are aware if we need geriatrics involved or reassess kind of what the patient plan would look like, including with their family member. Again, confirming education and links to education and resources. So this mimics, again, like I said, the awesome outpatient program. And what we want to do is we want to make a nurse-driven order set. So this would be like an automated kind of flag order set that would come up with a surgery consult. So we have a ton of new nurses as well, right? We have a lot of new staff. We have some of our staff specialize in surgery. Some of our staff kind of specialize more in cardiology. How are you supposed to remember everything, right? How are you supposed to know what all the ERAS guidelines are? So that's why we put it into kind of a checklist, because we know checklists work. And if anybody uses Epic, we know that Epic, there can be like a couple places to do the same thing, if that makes sense. So it helps kind of lean process that. So put everything into one place and just help with that standardization and also help our staff with their workflow too, to make sure that we're all doing the best things that we can do for our patients and their caregivers to recover after their surgery. So again, the key about ERAS and all of this is that it's multidisciplinary, teamwork and collaboration. That's really the only way that it would work. That's how we take care of our patients. So we're just thankful that we have such an awesome team here and they're really positive about the program as well. So these are kind of our prehab program objectives, again, mimicking the outpatient program. But this is what we're hoping to improve, decreasing post-op infection, decreasing length of stay, increasing patient satisfaction, etc. So we have not it's not live yet, but we're in the process of making this checklist. It'll probably be ready in the next couple of months, so stay tuned. But yeah, we just wanted to share that because we're really, really excited about it as well. And that's it.
Are there any questions in the audience? Oh.
Hello, I'm the clinical educator at Riverside Periops, and part of my portfolio is the pre-assessment unit at TOH. So we too have like huge goals in terms of like prehab and stuff. One of our challenges is the lead-in time to surgery. So my first question for you, I have two. My first question is, what is your average time from case request to surgical date to get all those good things in? Because we're struggling.
So that's a good question. So you're talking about the inpatient population or the
Or
outpatient?
Elective, the outpatient.
Elective? So you can answer that.
Yeah, so we typically try and get patients in the sweet spot of 6 to 8 weeks before their surgery. Doesn't always happen that way. Sometimes we get them 6 months before their surgery. It kind of depends on the surgeon, their OR time availability. And then there are the very small amount of times that it ends up happening too quick and we're not able to optimize. But I can say like we're right now getting people at the 4 to 6 week range and it's going really well. So I would say if you can get at least 4 weeks out, I always say the number 4, like in EROS is just your sweet spot.
And that's the majority of the patients would be before the 4-week mark.
Yeah.
My second question, just out of sheer curiosity, is how are you managing your patients on the GLP-1s?
So we're not doing medication optimization just yet. That is something we have identified as a area we would like to focus on, but we do connect with our diabetes team if there are medications we're concerned about. And we, we'll connect with the surgeons too.
And all of our patients do go through PAU and they see their anesthesia. So that's always done in enough time to be able to look at those medications and ensure that they're held at the certain amount of time preoperatively to ensure no like decay. So it's always usually a couple weeks before their surgery date. Sometimes it's a little bit longer, but our awesome triage coordinator really makes it, usually it's at least a couple weeks before their surgery date.
And they're really good at putting notes for us in Epic as well to say, we notify the patient to stop taking.
Yeah, like if PAU, they'll put their note there. So then the nurses know, and you guys put notes as well, like sticky notes as well, just for a communication piece.
Yeah.
Oh, there's a question.
So much. Great presentation, ladies. Amy, I guess then Tori. So once the inpatient program is alive and up and running and you've got some outcome data and stuff, do you think it's something that you would be willing to share and help implement in all of our regional partner hospitals? Because I assume everybody has these patients waiting for surgery.
So we would absolutely 100% love to share that. And just as another like sneak peek, I'm just kind of telling you all these little sneak peeks, but we actually have collaborated with OGH. So they have a cardiology unit at the General Hospital. So a lot of the times we'll have patients waiting for surgery at the General, waiting for transfer over to the Heart Institute. So with the awesome team there, the cardiologist, the educators, the managers, we've actually developed also an Epic order set that kind of mimics our inpatient nurse-driven order set to help start optimizing the patients while they're waiting at the General. So it even has prompts like if you're on anticoagulation, oh, should we look at holding that or bridging? Of course, it's a physician order set over there, but making sure that even that we don't have avoidable OR cancellations or holds before their surgery date. And that type of thing. So that's actually coming like very, very soon. If anybody has Epic, that there's a bit of a wait list for like new orders and such, but it's like really there. It's in the sandbox, they tell me, whatever that is, but it's coming soon. So we're really excited. And that's something we would be able to share with the region as well, especially if you have any patients that you refer to us as inpatient for cardiac surgery. But we would like to share anything if you would like it. Awesome. Thank you.
Awesome. Thanks so much, Amy and Julie. Yes, we like to share here, that's for sure. So last but not least, before we pause for another little energy coffee break, I'm happy to introduce Jennifer Harris. Jennifer is a registered physiotherapist and the manager of the outpatient cardiovascular rehabilitation and the regional outreach programs for the Division of Prevention and Rehabilitation here at the Heart Institute. Amongst other things, she directs HeartWise exercise and facilitates cardiac rehab regional delivery in the Champlain region. We're happy she can be here today to speak to us about an obesity pilot project.
Thanks for the introduction, Tori, and hello, everyone. It's so nice to see some familiar faces and see some familiar names online. I'm really happy to be able to be here today. And as you can see by the name on the slide, I'm a last-minute stand-in for my colleague, Mark. So presenting on behalf really of all of the committee work that we've done, which I'll describe a little bit more. So this was work that we've done as part of a larger initiative that a committee here at the Heart Institute, led by Bonnie Quinlan, launched back in 2022 to really work to integrating the 2020 Canadian obesity guidelines put out by Obesity Canada. So the working group includes a committee of patient partners, cardiac rehab team members, clinicians at Heart Institute outside of cardiac rehab, partner organizations, and others. So it's been a large working group. And we have presented some of that work before here at Linking Heart's Regional Day. But just as a quick recap, we had created and have been working on 5 different quality improvement initiatives that came out of all of that committee work. And they focus on 3 key themes. The first theme is providing a safe and accessible environment for patients. The second is increasing knowledge. And the third is focusing on changing attitudes, beliefs, and practices of healthcare practitioners to support patients with obesity. So today, I'm just going to give an update on one of those projects, which was integrating the 5 A's into the cardiac rehab program here at the Heart Institute. So the 5 A's are really a key pillar of the Canadian Obesity Guideline Working Group and are similar to the 5 A's used in smoking cessation interventions. So the idea is really to ask the patient or client for permission to discuss weight and explore readiness to change, to assess the patient's obesity-related risks and root causes of obesity. 3, to advise on health risks and treatment options. 4, to agree on health outcomes and behavioral goals. And 5, to assist them in accessing appropriate resources and providers. So as we did our work and really explored how we could implement those 5 A's, it did become obvious to us that we wouldn't be able to implement all 5 of them. And the biggest reason is resource. To have that full assessment piece, you really need to have a physician who's able to do a comprehensive metabolic assessment and have access to all of the interventions for weight management. So that's something we don't have within our cardiac rehab program at the Heart Institute, or really at the Heart Institute broadly. And so that's one of the A's we weren't able to implement, which means we couldn't then implement the advise A, which is a direct next step of the assessment. But we did identify that we could focus on 3 of the A's, which were asking every patient a very thoughtful, and you'll see in a minute, there's a lot of work that went into the question, agree on some goals and outcomes with the patient, and assist them by offering them available resources. So up at the top, you have the question that we came up with. And really, this was a long time in the making because, of course, it involved a lot of stakeholder input. So we had our small working group that include clinicians in cardiac rehab, partner organizations, and patients who had volunteered to be on this committee, and then our group as well. So there was a lot of back and forth and really trying to be sensitive on how to word the question in a way that felt comfortable to the patient and to the provider asking the question. So, and to give just a little bit more context of when we're asking this question. So I indicated this pilot was integrating the 5 A's in our cardiac rehab program. So at the start of cardiac rehab, one of our clinicians will assess the patient. We call that our intake. And during that intake, we have a discussion about all of the cardiovascular risk factors that the patient may have. And so we include this question in that discussion. So it's not out of the blue, it's in the list of all of the other risk factors that we're assessing, and it just comes in line. We had always assessed their nutritional status as well as their weight. And so as those are 2 risk factors for cardiovascular disease, so we integrated this question into that discussion. So the question is, weight can affect your cardiovascular health. Do you want to discuss your weight today? If the answer is no, we just move on to the next risk factors. If it's yes, we ask, in what way is weight a concern for you? So the first piece is, we do see a lot of people in cardiac rehab who are malnourished or undernourished, and underweight is a concern for them. So if that's the reason that weight is a concern, then we refer all of those patients to our dietitian. If the answer is yes, it's a concern because they're overweight or they wish to lose weight, then we have a statement. You can see it there on this slide, but the clinician will paraphrase to make it sort of suit the conversation. But essentially, they're indicating that weight is complicated. It's not as simple as eat less and move more. And we're focusing on health behaviors. We've put together some materials to help make sense of this all and point you to some resources available in the community. Would you like a copy of that? So that was it. It's very simple, but it was a lot of, like I said, it was a lot of discussion to come to a process that made sense. The other question you might be asking is, who did we ask this question to? And the answer was everyone, because again, trying to remove the stigma and bias, that we weren't going to start to identify people we might ask and people that we might not. So we simply used 4 clinicians as this pilot, the 4 that had been on our little working group, and they used this question with all of the patients they assessed in a 1-month time period. So to reveal the big results. So we did this over a month. We in that time frame, 42 patients were asked the questions, and of those, 15 of them did say yes to the resource. So, and anecdotally, the clinicians found that patients were surprised by being asked, but appeared to appreciate the opportunity to be asked and then answer the question, as opposed to making assumptions. But that was anecdotal evidence. So our next step is really focusing on doing a survey with the patients who received the resources. Again, our clinicians felt that they weren't sure how the patient might react to the resource that they received once they opened the discussion. They said yes, they would like more information, but the next step is really to assess how they responded to the resource that we sent them. So what is that resource? So this is our new resource that we had created for both patients and healthcare providers at the Heart Institute. And this work actually was one of the other quality initiative work groups that came out of the bigger project. Right at the beginning of all of this work, we did a survey of Heart Institute staff, and we had 255 respondents. And I think we had, I have this number somewhere, 30% felt ill-equipped to deal with the issue of weight management in obese patients, and 95% wish that they had more education. So it was a next step for us, and one of the working groups, as I said, created this pamphlet that really focuses on teaching about best weight, weight bias and stigma, and most importantly, it provides resources on weight management. So this is available on our website, and we will put the link in the chat for this resource and maybe send it as part of an after package. So it's widely available for you to use. Initially, we had done 2 separate pamphlets, thinking we needed a separate one for patients and for healthcare providers. But after our first reveal of the pilots and putting it to use, it made more sense to have just one. And so it's one resource. There are some videos built within the resource. Nowadays, most of our resources we're handing out digitally, so patients can click on the video link and watch the video. So I encourage you to check that resource out, and feel free to use it if you find it helpful. And so this is our next step, and that's where we're at. We're going to survey the patients who received the brochure and who were asked the question, and confirm with them in their perception, did we ask permission to talk about weight? Did we advise you on the concept regarding best weight or the complexity of weight management? Did we assist you with resources on weight management? And do they have any suggestions for us for whether we need to change the question or the process, or just in general, any other suggestions for us? And that's where we're at. Any questions?
Any questions?
Thank you very much, Jennifer. So we're slightly ahead of schedule, but oh, do we have a question in the chat? Sorry. I saw, no, oh, sorry, false alarm, false alarm. We are a little ahead of schedule, but that's okay. There's fresh coffee for a little break. Friendly reminder to please complete the survey. It's my last reminder, and then we'll do a draw at the end of the day. We will reconvene at 2:20. Important. Thank you. All right, now that the online guests can hear me, welcome back. We're kicking off the fourth portion of our day, which is going to be all about stroke. For this portion, similar to the morning, we're going to ask that everybody hold your questions until the end when we're going to have another 10-minute panel when our presenters will be up here at the front. And our moderator for that is going to be our very own Kelly McPhail. So for this next portion, we're very lucky to have our colleagues here from the Ottawa Hospital, as they are the true experts on this topic. And starting us off, I'd like to introduce Alana Niles and Sophia Gokin and Michelle Simpson. Alana and Sophia are nurse specialists at the Ottawa Hospital, and Michelle is a registered social worker. And together, they are going to delve into what caring for stroke patients really looks like.
Well, it's a pleasure to be here today. My name's Sophia. I'm a nurse specialist and I work at the Stroke Prevention Clinic at the Ottawa Hospital. And we're going to be sharing with you the stroke journey today. So we're going to begin with stroke prevention. Then we'll be talking a bit about community reintegration and community resources. And then our medical director, Dylan Blackyard, will also be speaking about acute stroke management. So following this portion of the session today, participants will be able to describe key elements of stroke risk factor education and best practices for secondary stroke prevention. And you'll also be able to identify and access resources to support patient risk factor management. We wanted to add a disclosure that in addition to linking hearts today, we're hoping to link brains, and we really appreciate being here to share in this session. We wanted to put a plug out for our main stroke educational event of the year. You're all welcome to join us at the Ottawa Stroke Summit on September 27th here in Ottawa. If you'd like a link to register, you can go to crsn.ca. Similar to the way that cardiac care is coordinated across the region, stroke care is organized throughout Champlain to provide hyperacute services such as endovascular therapy and thrombolysis, as well as acute stroke services, stroke rehabilitation services, and stroke prevention services. So you can kind of see where we're located across the map here. And to begin, I'd just like to provide a very general overview of the types of stroke we'll be discussing today. Dr. Blackyard will get more into stroke etiology and subtypes, but in general, we're talking about two types of stroke: ischemic stroke, which accounts for 80% of stroke, and occurs when an artery is blocked by clot or plaque. And transient ischemic attack, which comes and goes and doesn't leave a person with deficits, falls underneath this type of stroke. It's a blockage of an artery for a short time, and it's a warning sign for ischemic stroke. And then we have hemorrhagic stroke, which accounts for 20% of strokes, and you would hear of this as ICH or subarachnoid hemorrhage. So let's talk about how our work in heart and stroke intersect, beginning with the heart. People who have heart disease have 2 to 4 times greater risk of stroke than the general population. And after acute coronary syndrome, for example, 2.2% experienced stroke within the first year. Likewise, following ischemic stroke, the risk of cardiac complications is quite a bit higher. In a US study looking at 53 organizations, they looked at patients who had ischemic stroke and no known cardiovascular risk factors and looked at who had cardiovascular complications in the first 4 weeks. And they found quite a high incidence rate. 11% experienced acute coronary syndrome, 9% atrial fibrillation or flutter, 6% heart failure, and then cardiac arrhythmias and Takotsubo syndrome around 1%. Among those with early complications, so ischemic stroke followed by cardiac complications within 4 weeks, looking at those patients compared to those who didn't have cardiac complications, by the 5-year mark, those who did had significantly higher major adverse cardiovascular events, and with those events, 1.5 to 2 times increased mortality, as well as up to 50% higher prevalence of recurrent stroke risk. And so when patients have both heart disease and stroke, the risk of further events is higher. And this elevated risk has also shown itself in an Ontario-based study that looked at the first year after ischemic stroke and found that the risk is especially higher in the first 30 days. And with women, it's 25-fold increased risk, and men, 23-fold increased risk. And so heart disease and stroke share risk factors, and both are highly preventable. Because patient education is key, we're going to be working through a case study shortly so that we can discuss more how this can be achieved and what resources we can use. We know that 90% of Canadians have at least one risk factor for stroke. And through things like eating better, being more active, stopping smoking, getting adequate sleep, managing weight, cholesterol, blood pressure, and diabetes, we can make a difference. Everyone has the power to reduce their risk of stroke. One last thing I'd like to mention before we move into the case study is that when you prevent stroke, you're also preventing dementia. We know that at the time of a first stroke event, 10 people already have dementia as an underlying diagnosis, and 10% more develop dementia. And if a person goes on to have a second stroke, up to 30% and more will develop dementia. And so when you're talking with your patients about protecting their heart through prevention, they're also protecting their brain health and they're protecting their memory. And this is a motivating factor to know that all these things are really cross-sectional and impact their health in many ways. So we're going to move now into a case study, and if you have a phone you can use, we're going to be asking you to log in.
Okay, yeah. If you have a phone, you can scan the QR code. There will be some questions that you can answer from, as well as if you're online, you can go to menti.com and put in this code here, or you can follow along on your phone as well. Okay. Hopefully everyone's signed on. So everyone meet John Smith. He's a 62-year-old male. He has a past history of hypertension, dyslipidemia, type 2 diabetes, coronary artery disease, and he also smokes about 3 to 4 cigarettes per day. He originally presented to the emergency department with chest pain and shortness of breath. After some testing, it was deemed that he needed to have a surgical intervention. So John Smith underwent a CABG. The surgery itself was uneventful, and he was transferred to the cardiac ICU, where he was stable for about a day, and then he was transferred to the step-down unit. On the second day, his nurse came in to check on him, and he noticed that he had left-sided weakness, as well as a facial droop, and he was having difficulty speaking. At that point, the nurse called the cardiology resident as well as the neurovascular resident to come and assess him. They came and assessed him, and his symptoms lasted for about 20 minutes. He went and got a CT-CTA, which ended up being normal, so the most appropriate diagnosis was a TIA. Try to get the mouse all the way over here. Okay, so what were some of the risk factors, John, the vascular risk factors we want to discuss with John before or on discharge? It looked like most of the answers there were correct. So some of the risk factors we'd want to talk to him about are hypertension, dyslipidemia, and his type 2 diabetes. So for blood pressure control, we know that high blood pressure is one of the #1 risks to stroke, and it's important to monitor your blood pressure regularly at home, even if you're not told that you have high blood pressure. Our target in stroke prevention clinic is for the blood pressure to be 135/85 or less. With John specifically, since he has diabetes, we want it to be a little bit less than that. So we would want him to see 130/80. We often use this picture you can see on the right-hand side to start a conversation with our patients around blood pressure if they're taking it at home. So this way we can discuss when they're taking it, what activities they should avoid before taking it, whether they're taking it just once. We often encourage patients to take it at least twice or 3 times with a 1-minute period in between, and then write down the last blood pressure as that's their true blood pressure. We also go over position and kind of environment around them when they're taking their blood pressure. We also will go over if they have a machine at home, making sure that it's actually reading correctly. So they can validate their machine by either going to a pharmacy and checking the machine there and seeing if it's the same reading, or bringing it into their family doctor to also see if they're getting the same numbers. We also go over that they should be using an arm cuff instead of a wrist cuff, and then making sure that their arm cuff is actually the proper size. So often in stroke prevention clinic, we will measure the patient's arm and then tell them kind of if they're a small, medium, or large. With cholesterol management, so cholesterol is the fat that's found in our blood. There is 2 main types, HDL, which is known as the good cholesterol, and the one that helps to remove excess cholesterol in our body, and then LDL, which is named the bad cholesterol, and the ones that can cause plaque to build up in our arteries over time and could cause narrowing and decrease blood flow to both our brain and our heart. So in stroke prevention, our LDL, we would like to see equal or less to 1.8. This can either be achieved by medication or lifestyle changes. So as you can see at the bottom, we often will use medication called statins, or we can talk to patients about diet and exercise as well. The main thing that we suggest patients to avoid in diet is the saturated and trans fats. So this will often be found in overly processed foods, such as fast food, deep fried food, butter, lard, hydrogenated margarine, fully fat milk products, and as well as commercially produced baked goods and packaged crackers and cookies. Another big one we want to make sure patients are managing is their diabetes. So with diabetes, it can increase your risk of high blood pressure, narrowing of your arteries, coronary artery disease, heart disease, and stroke. We often will ask patients how they're currently controlling their diabetes and who they're following in the community for this, whether it's their GP, an endocrinologist, or any other programs within Ottawa. In stroke prevention itself, we look at the target for hemoglobin A1C to be less than 7, or if you're looking at random blood sugar, it should be between 4 and 11. We'll often go over different medication that they're on and diet. We use this one from the Canadian Diabetes website. You can see a little picture of it in the corner there. It's goes over the glycemic index of different food groups. This one specifically is for fruit. And we also have a whole bunch of different programs we can offer them in the community. The main one is the Ottawa Community Diabetes Education Program. So this one we can refer them to, but they also can refer themselves to. It's run by a diabetic nurse and a registered dietitian. I think they offer it online and in person, and there's many different clinics around the city. So they can find one that's closest to them. They also can visit the website Living Healthy Champlain. This one's not geared specifically for diabetes, but it's a self-referred program to help people with chronic health conditions better manage their health. It's a 3-month program. They can decide to either do it online or in person, in a group or one-on-one sessions. And this one's specifically to set goals, problem solve, and take action for their own health. So what are some of the lifestyle changes we'd want to explore with John before discharging him? Good. Saw a lot of good answers there. So some of the main ones we'd want to talk to him about would be smoking cessation, alcohol, healthy diet, and exercise. So we'll first talk about smoking cessation. Quitting smoking is one of the most important things any of our patient or anyone can do for their health. As many of you may know, the Heart Institute has a wonderful program with the Ottawa model for smoking cessation. In the stroke prevention clinic, we're currently doing the opt-out pilot version of this. So all of our smoking patients are referred to the program unless they outwardly refuse. With this program, they often will get a phone call about a week from clinic visit or from discharge, where someone will talk with them, set goals for what they're looking at, if they want to quit in the next 2 weeks, if they want to quit in the next 6 months, and kind of work with them towards that goal. Through this program too, they also can get vouchers for nicotine replacement therapy up to 6 weeks. So they can try and see which ones work for them and then maybe extend from there. We often tell patients that we know quitting smoking is one of the hardest things to do, and there's absolutely no issue with asking for help for it. Another big one is diet. So healthy food has a huge impact on improving patients' cholesterol, blood pressure, diabetes control, as well as weight control. Simple changes kept over time can decrease the risk of stroke, improve your energy and overall health. We will often encourage patients to follow a heart-healthy diet, which includes making sure you get enough fruit and vegetables, specifically from the Canadian Food Guide's about 7 servings. Choosing foods high in fiber. Lowering sodium intake will often teach people about the DASH diet. Choosing healthy fats such as fish, low-fat dairy, or using olive oil to cook, as well as healthier proteins. Again, with fish, chicken, lentils, beans, and chickpeas. Eating less sugar, and eating moderate portion size. So as you can see in the right-hand corner here, this is from the Canadian Food Guide. So this is kind of how they set up a plate. So technically half your plate should be half vegetables or fruit, a quarter of it being healthier proteins, and then a quarter of it being whole grains. So that's where you get your potato, rice, pasta, bread. We'll also give them other resources like the Canadian Food Guide, as well as free dietitian services offered at unlockedfood.ca and Telehealth Ontario 811. Another big thing we want to talk to patients about is exercising regularly. So regular exercise helps lower blood pressure, cholesterol levels, helps reduce weight, as well as overall health. It is recommended to get about 150 minutes of moderate to vigorous exercise per week, or a minimum of 30 minutes per day, and this can be achieved in 10-minute intervals. We will often ask our patient how physically active they are currently, and then we encourage them to start slow and then work their way up. Also talking to them about finding an activity that they actually enjoy, as well as maybe something they can do with friends and family so they'll actually stick to it. We have quite a few resources in the community as well. So there's one specifically geared to post-stroke patients, but then ones that aren't are heartwise.com, and then Better Strength, Better Balance program in Ottawa. And then there's a few other ones that are in the Champlain region, not Ottawa specific. And another big one that's changed recently is about alcohol use. So the new Canadian guidelines for both men and women is that no alcohol is best, but less than 2 standard drinks per week. We all know that drinking less alcohol is better for us, and that even a small amount of alcohol can be damaging to our health. If you look at the chart here, starting at 2 drinks, you usually can stay away from any alcohol-related illnesses. If you drink about 3 to 6 drinks per week, you could have an increased risk of certain cancers, specifically breast and colon cancers. And then if you're greater than 7 drinks per week, you increase your risk of those cancers, but also of heart disease and stroke. Some tips that we can give patients to avoid alcohol is to set a limit for themselves. Drink slowly, drink more water, eat before or during having alcohol, having one alcohol drink and then a non-alcohol drink, or just altogether going for the non-alcohol options or very low alcohol options, as well as making sure that they have alcohol-free weeks or try to find activities that might be alcohol-free. So while in hospital, John was ordered an echo and a Holter. On his Holter, they found that he was in atrial fibrillation. What kind of medication do you think John should be started on before leaving the hospital?
Well, this was a bit of a trick question. The most appropriate one would be an anticoagulant, but he could also be started on a beta blocker depending on heart rate control. You guys did well there. I know there was already an in-surface on AFib, so I'll just touch on this quickly. But atrial fibrillation is a type of irregular heart rate that carries a high risk of stroke when it's untreated or when it's undertreated. The risk of developing AFib increases with age and different medical conditions such as diabetes, high blood pressure, and heart disease. Research has shown that long-term benefits of using an anticoagulant medication for these AFib patients can reduce person's risk of stroke by 68%. Some teaching we like to provide in stroke prevention on anticoagulation is what the medication is and the importance of it, as well as the timing that the patient should be taking the medication around the same time every day, the importance of not missing a dose, what they should do if they do miss a dose, and any of the increased bleed while on this medication. That was it. Thank you guys for participating. For the patient.
Think I got it? No. Yeah, all right. It's that it's not progressing, so. I think there might be 2 copies of it up here, actually. Yeah. So Alana's gone over a lot of the Canadian stroke best practice recommendations for stroke care. And they provided as well kind of core elements, things that we should go over with every person who's experienced stroke or TIA. So making sure they understand their diagnosis, what their personal stroke risk factors are, how to achieve their targets and kind of monitor that they're achieving those things, assessing for any complications after stroke, assessing their knowledge, self-management needs and recommendations for community programs as well. And of interest, the diagram on the right side of the screen here comes from our regional consultations with persons with lived experience of stroke and their family members. And the core themes that they identified here really align with the Canadian stroke best practices. Patients indicated they want more access to information and that peer support is an important thing for them, as we've heard about with other conditions today. Also, they want improved support and access to services during transitions, especially when they're leaving the hospital. That's an important time for them to have added supports. And then more standardization of care and coaching and navigation throughout recovery. To streamline information for our patients, we put a lot of work into augmenting our website, crsn.ca, as kind of an entry point or hub of information for patients. On the website, patients will find videos, health information, programs, services, and educational events. And whether you're pointing a patient here for themselves or for yourself as a healthcare provider, we have both a patient portal and a healthcare provider portal, so you can get information as well. And you'll see there's other topics on here of real importance to patients like driving and sexuality, peer support, and again, the exercise classes that Alana was talking about. Also, links to the patient booklets seen on this slide are available on the CRSN website. So Heart and Stroke Foundation has made a really good comprehensive booklet called Your Stroke Journey that's useful to patients and families. And we've also developed a local resource called Understanding Stroke and TIA that has links to important services for patients. So you can find them on our website. If you're using Epic and you want to add the fast warning signs to the discharge summary, you can use the .stroke nurse ABS. And for anyone who's working as a physician in emergency, there's also discharge instructions that can be provided for patients with TIA in emergency using the discharge phrase for stroke care. So in summary, up to 80% of strokes are preventable, and small changes have a big impact. We know that when we're preventing stroke, we're preventing dementia, and we're protecting the heart. And education and self-management are so important for that. The 3 individuals on this slide here have shared their journey through stroke care on our website as well, if you wanted to check that out. I wanted to point out that the tools and resources discussed today really come together from a broad variety of guidelines. So Diabetes Canada informs the work we do, as well as Hypertension Canada and Thrombosis Canada, etc. So pulling together all those guidelines into the Canadian Stroke Best Practice Guidelines provides the basis for our work. And certainly if at any point in time you're caring for someone with stroke and you want to talk about prevention, resources, or services, Alana and I are happy to collaborate. And it's been a pleasure speaking with you today. Michelle's going to be coming up next to talk to you about community resources.
Hello. It's nice to present in front of people instead of just virtually, but also to the people virtually. Hello to you too. I'm Michelle. I'm the best practice social worker at the Regional Stroke Network and the stroke social worker at the Civic Hospital. And I'm here today to talk about community support that we utilize in stroke care. And of course, it's not an exhausted list, but it's the ones that we use most often. It's not that. It's not showing any of this either. Thank you. Okay. So everything that drives what we do at the Champlain Regional Stroke Network, which I might refer to as the CRSN, just to shorten it down a bit, is based on the Canadian Stroke Best Practice Guidelines, or recommendations, sorry. So in terms of this discussion today, we're talking about transitions and community supports. As per the guidelines, recommendations, patients and families should be provided with information and access to services to optimize return to life roles, activity, and social participation. I thought it would be helpful when we're talking about community resources to bring you through the stroke journey that we follow here at the Ottawa Hospital as well as throughout the region. So on day 1, the patient presents to the emergency department. I'm going to move on quickly to day 2, because that's where we start to get into the community support portion. So on day 2, all of our patients are seen by the allied health team, occupational therapy, physiotherapy, speech language pathology, and social work. And patients and families are provided with the Heart and Stroke, Your Stroke Journey booklet. On day 3, an alpha FIM is completed, and we start talking about inpatient rehabilitation. So the alpha FIM assesses for motor and cognitive function, and the outputs of this create a score that identifies if a patient is requiring inpatient or outpatient rehabilitation. If everything goes as planned and the patient is medically stable and we feel they're ready to move on, we'll start discussing rehab, either waiting for a response from our rehab team or developing a discharge plan. This is an algorithm created by the Champlain Regional Stroke Network that helps our staff determine what patients will need following the acute care stay. So we have one for the Ottawa subregion as well as the East and West subregions. And as you can see at the top, we have the Alpha FIM scores and what those scores mean in terms of services. Now, again, those scores are merely guidelines, and our patients may require inpatient rehab, although they haven't scored in inpatient range, and that's a discussion that we would have with our subacute rehab team. So when we're talking about inpatient rehab, in the Champlain region, our inpatient stroke rehabilitation sites are at Elizabeth Briere, Glengarry Memorial Hospital, and Pembroke Hospital. When discussing outpatient stroke rehabilitation in the Ottawa area, Briere and Home and Community Care Support Services have worked together to create an integrated referral form and triage process to improve the care that stroke patients are getting as outpatients, make things more accessible, make sure resources are being utilized as best as possible. In the other subregions, our outpatient stroke rehabilitation program is provided by Champlain Home and Community Care Support Services. We refer to it as community stroke rehab. For our patients that don't fit into the inpatient or outpatient rehabilitation stream, we have a great program that CRSN and the Ottawa, Cornwall, and Pembroke Paramedic Services have worked together to create. It's similar to the community paramedicine program, but with a stroke-specific focus. Sophia was actually very much involved in ensuring this program came to light and created these amazing guides, one for patients that goes through chronic disease management, stroke prevention, and also an orientation program for the paramedics. We recently added TIA, as well as strokes to this program, and it's going well. It's a great option for patients who don't fit into the rehab stream. When looking at the best practices, community participation following stroke focuses on things like driving, since people who have had a stroke are unable to drive for 30 days and possibly longer if it's determined that it's unsafe for them to drive and there's a report to the ministry as a result. A focus on leisure activities and social participation, which I will be talking about quite a bit today in terms of the resources that I'll be going over. And then also about vocational roles, so that's returning to work or volunteering. And with the increase in younger strokes, this becomes a very important topic because of the impact that it can have on their finances moving forward and being able to support their families. And then lastly, relationships and sexuality. The CRSN embarked on a journey with our partners to determine through a standards of care review what was most important to our partners, as well as where some gaps in care were. So specific to the previous slide, our objectives in our newly released strategic plan, 2 of them will be focusing on developing and disseminating return to work education and resources, as well as developing a framework to assist healthcare providers in delivering education and support regarding the impact of stroke on relationships. These are 2 things we don't have a lot of resources, training, or standardization on as of yet, but in the coming years, we hope to make that a much more robust education and resources for staff. There's it's been mentioned before today, there's the virtual post-stroke exercise program that's hopefully moving to in-person at sometime soon, but will always remain virtual. So the instructors are trained in post-stroke impairments. It's free of charge. The classes are an hour long. It's an open group. It can accommodate various ability levels, and it's offered in both English and French. Now, being able to participate in all of these resources and being able to get back to life roles wouldn't be possible if your mental health is not well. It's important to note that approximately 30% of people who have had a stroke will experience depression, anxiety, and/or apathy. These changes in mood have been shown to result in poor functional recovery, an increased risk for dependence, poor cognitive function, reduction in social participation, and an increased risk of mortality. It is imperative that we focus on mental health so that we can ensure that people are participating in rehab and all of the services that I'll be going over today. Specifically around mental health, I'm happy to announce that a partnership between March of Dimes and the Regional Stroke Network will be launching in September 2004, which is our After Stroke Hospital Peer Connections program. We'll be matching newly diagnosed stroke survivors with a peer volunteer who has firsthand experience. This can be a survivor of stroke or their caregivers. The volunteers will engage with patients and their families to share personal narratives, offer resources, establish connections, and provide messages of hope and encouragement. The goal is to foster a sense of belonging, preparedness, security, empowerment, and involvement, enabling stroke survivors to embark on their post-stroke journey optimally. I can't wait for this to roll out at the Ottawa Hospital, Elizabeth Briere, Glengarry, Pembroke, and Cornwall. Of course, ever so important are our peer support groups. Unfortunately, at the moment, we don't have a robust number of peer support groups, but there are 3. There's one in Cornwall, there's one in Glengarry, or Alexandria, sorry. And then there's one that's outside of region for young stroke survivors, but Champlain residents are more than welcome to attend. It's virtual. The other 2 are in person. These are the mental health resources that we provide to our patients. So first is Access MHA, which is a one-stop shop for mental health resources and addictions resources. Also Counseling Connect, which is free, 1 to 3 sessions of counseling. So not extensive, but better than some of the other options out there that cost a lot of money. There's the walk-in counseling clinic, which is also free, but it's immediate crisis-based counseling services. And then we have the Champlain Community Support Network, which is a search engine to find community supports throughout our region. According to the best practice guidelines, cognitive behavioral therapy is the therapy of choice for post-stroke depression and anxiety. So we do provide patients with information on 2 applications that they can use on their phone. The first one is MindShift, which was created by Anxiety Canada, and it offers self-guided cognitive behavioral therapy. So of course, some deficits post-stroke wouldn't allow for someone to be able to use these tools, but for those who are, we do encourage. There's also Mind Beacon. This does have a cost, but there is some free content, and it's Canadian specific, and it can be face-to-face counseling. It can be like something you do yourself, but you have a counselor that you can connect with, not face-to-face, and different group programs as well. And then for those who can access and pay for private therapy, we do recommend using Psychology Today as a search engine to determine a therapist in your area that can help you with your particular needs. But of course, this can be quite costly, but for some patients covered by their health plans. Specific resources for stroke. A big one that we use is the Aphasia Center of Ottawa, which provides services for long-term speech-language therapy, counseling, advocacy, and empowerment for individuals with aphasia. The other program is the City of Ottawa run Acquired Brain Injury Post-Stroke Program. It's a therapeutic and life skills day program. They have a pool, which is great for people recovering from stroke. We had an opportunity as a team to go and watch this program in action. It's fantastic. And then March of Dimes has an after stroke program where patients and families are connected with a navigator that helps them work through the stroke system and their experience post-stroke. And lastly is vision loss rehabilitation. 1/3 of individuals who have strokes will have some impact to their vision. This is a great service that we use following discharge from hospital. The individuals come and do home visits, help people navigate their vision loss and reintegrate into life with their needs. The Champlain Regional Stroke Network has created some incredible infographics. These ones are for health professionals, and this is just 3 of many. They're easy to print off and to hand out, to use as a reference yourself. They provide some really quick information on what to do in particular situations surrounding stroke. We also have infographics specific to patients and caregivers. And as you can see here, driving's a big one. Post-stroke fatigue, we have ones on mood. These are infographics that you can print off and give to patients so that they have a little bit some information that's simple as well as aphasia friendly that helps them on their post-stroke journey. Now, everything I've talked about today can be found on the crsn.ca website. Please check it out. You can also find contact information for all of the staff there. If there's something that you want to know, questions that you may have, if you want to reach out to me about any questions about resources. And that's it.
Great. Thank you so much, Alana, Sophia, and Michelle. It was super informative. To continue on this topic of stroke, I'm now going to ask Dr. Dylan Blackyer to come up and speak. Dr. Blackyer is a stroke neurologist at the Ottawa Hospital, the medical director of the Champlain Regional Stroke Network, as well as an assistant professor of medicine at the University of Ottawa. We're so glad that he could be here today to share his expertise on this topic.
Thank you very much. It's a pleasure to be invited to come and speak with you today. And thank you once again to my colleagues from the Stroke Network for that amazing presentation just before to talk about the resources that we have available in our community. It's a privilege to work with you every day, and it's a privilege to see how the connections we can build between ourselves and the Heart Institute can also come out with that as well too. In light of that, I'm going to talk a little bit about just the mechanics of stroke specifically and to talk about how we investigate it, what we look for, and also to kind of talk about how it's managed here specifically at the Heart Institute to some degree too. There are many of you that probably have encountered either on the wards or elsewhere specifically what happens or heard overhead the stroke code page. So we're going to talk a little bit about how we approach that, what we're looking for, and what specifically we're hoping will happen during the course of that investigation. So with that in mind, I do have just some disclosures to bring up with that. And the one that's somewhat relevant is that I've been on an advisory board for Roche, who is involved with the use of tenecteplase, but we're going to be talking about everything based upon stroke code best practice guidelines today specifically. So there'll be nothing off-label discussed here today. My goals are to talk about a brief overview of stroke management specifically, and also to talk a little bit about the mechanisms of stroke, but we're also going to talk about stroke codes. What exactly are we doing? What is the purpose of this? How does one operate? And we're going to discuss procedures and operations for that, especially around the inpatient, because that's the one you would be most commonly seeing here. But we'll talk about how that comes from a more general sense as well. And we're going to discuss common problem areas for acute inpatient codes and stroke care and how to potentially avoid them as well too. And once again, everything I talk about here will be on the Stroke Best Practices website. So I would encourage you to look at strokebestpractices.ca. Again, disclosure, I'm on one of the advisory boards for this, so there's a little bit of a plug in terms of the things I do, but it does have a significant amount of information available, both for prevention, for inpatient management, and for the community transitions that we were talking about as well, too. And again, another plug. I feel like I'm more of an advertising huckster here for a second, but just coming up with the Ottawa Stroke Summit on September 27th. That's going to have a lot of information, both related to what we're seeing today, but also common mechanisms and common discussions around things happening through the stroke continuum. So, stroke basics. We've talked a little bit about things like the risk factors, how we approach things from a prevention strategy from that. But when we're talking about a stroke, one of the common things we're trying to sort is what exactly is this? What are we talking about specifically? So if you don't know, what we're talking about is a disturbance in cerebral function that's focal. So it's a specific part of the brain. It's due to a vascular cause. And in most cases, we're talking about an interruption of blood flow due to a blood clot, so ischemia. And it's supported by evidence of acute ischemia or hemorrhage. And what we mean by that is both clinical evidence, so somebody presenting with a recognized stroke syndrome, and radiological evidence from this. So something visible on a CT scan that shows us either that there's a risk of ischemia or the presence of ischemia or the presence of hemorrhage specifically. The pathophysiology of this, and I promise I'm going to try to make this as comprehensive as I can in just a couple of things, knowing that people do fellowships on this sort of thing. But basically what we're talking about is that when somebody has an area of ischemic stroke, and we're going to focus mostly on that, there is a blockage that happens and it leads to an area of tissue that falls below a certain perfusion threshold. So there's not enough blood getting to this area of the brain. There are going to be parts of the brain in which that reaches a critical threshold very, very quickly. So it falls below a specific threshold, and that tissue, regardless if you open the blood vessel or not, is probably not salvageable. So it's gone, it's not coming back. That's what we call the core specifically. But there's an area around that where it's interrupted. There's not enough blood flow getting there. It's not enough to support the functions of the brain, and so it's clinically symptomatic. But it's not yet met the threshold by which it's irreversible. And so what we mean by that is that if we can open up the blood vessel, then we may be able to restore that perfusion and we may be able to restore that function. And that's the penumbra. So you hear us talk about that topic quite a bit. And the whole purpose of what we're trying to do basically is to basically try to salvage that penumbra, because this is not a static thing. That area of penumbra, if you don't open up the blood vessel over time, is going to fall below that critical threshold and it's going to reach to core. So that's why we talk about time as brain, because over time, that area that is salvageable will stop being salvageable. All we're trying to do is to try to prevent as much damage as quickly as possible. We like to throw up slides like this to give numbers in terms of what we're talking about specifically, but this can happen pretty quickly. And so again, when we're talking about the timing for this, they've actually, Dr. Jeff Saver, who's a stroke neurologist in Los Angeles, one of his papers was to go specifically and calculate out how much brain tissue was gone. And he came to just some astonishing numbers from this, that for every 10 minutes, that you'll lose 19 million neurons, that you'll lose 120 kilometers of myelinated brain fibers. The long and the short of it is actually comes out to a significant amount of brain damage over time. And every 10 minutes, it's almost the equivalent of your brain or that structure of your brain getting older by 7 months. So we're talking about fairly rapid changes that can lead to fairly big impacts that come from that. Now, it's a bit more complicated than that because the flow of blood is sometimes a little bit trickier than just one pipe to one part of the brain specifically. And so you hear us talk about collateral flows. So the brain has some redundant pathways to be able to get flow around it. And if a person is lucky enough, there might be some flow around things like what we call leptomeningeal collaterals. So blood vessels that are over the surface of the brain to be able to get past a blockage. There's connections between the external carotid artery system and the internal carotid artery system. There's the circle of Willis to be able to get past things. This is very variable. There are normal anatomic variants that sometimes help and sometimes hinder that. But the idea is that it's not necessarily that you're hoping that basically that flow can get past that occlusion to be able to open things up. And if you're fortunate and you have that presence of collaterals, that's going to help keep that tissue alive longer. So the more the collaterals are present, the more likely it is that you're going to see salvageable penumbra based upon that. And we'll come back to that concept in a second. So the basic stroke principles like we've talked about is that if you have an acute ischemic stroke, it's caused by an interruption of blood flow causing focal neurological deficits. Just to take a step back, you'll see people sometimes present with other symptoms like weakness that's kind of more of a general malaise or things that don't really localize. It really should be mapping to a specific area of the brain for it to count specifically. There's always some variation, but most of the time we're talking about recognized stroke symptoms based on anatomy. So right-sided weakness of the face and arm with aphasia maps to the left MCA territory. That's a focal deficit. If you leave this untreated, then it's going to lead to infarction and permanent damage. And so our first principle is to try to restore that blood flow as quickly as possible. To do this, you have to understand that a stroke is happening. So there has to be that clinical recognition. We were talking earlier about things like recognizing the signs and symptoms of stroke. This is where things like the fast mnemonic come in. Yeah, that's the first critical step, to recognize that this is happening. So everyone should be aware of what the potential signs and symptoms of stroke are. And then the purpose of the stroke code is to collect that data that helps you make this decision and figure out what to do about it, the clinical and the radiological data. It's a whole system set up to be able to make things happen as quickly as possible. Why do strokes happen? So you'll hear us talk about different classification schemes, but in the end, all of our prevention strategies also focus on trying to go on these specific broad categories. So you hear us talk about things like large vessels. This is people who have problems with carotid stenosis or vertebrobasilar stenosis or blockages inside the head, intracranial atherosclerosis, basically large identifiable blood vessels that have some blockage. And sometimes we have things we can do to open those blood vessels up long term. Small vessel disease refers to the very tiny blood vessels that penetrate into the deep white matter. These are very susceptible to things like smoking, like blood pressure, like diabetes, the preventable risk factors that we were talking about in earlier presentations. You're well familiar here with the idea of cardioembolic stroke, but basically a blood clot coming from a central source and traveling to the brain. It doesn't have to be the heart. The aortic arch is also one potential etiology of this as well too, but generally in this case, we're talking about things coming from the heart, and we're typically talking about atrial fibrillation, but that's not the only source. And then there's other, which basically is anything that doesn't neatly fit into those categories. So this is people who have inflammatory conditions, genetic syndromes, etc. Stuff that's a little bit out of those typical cases, and we don't routinely see those, but we think about them. And then cryptogenic are people who have an adequate workup and you don't find an adequate cause. That's up to 15 to 20% of strokes and sometimes a little bit higher. And the good news is they still do respond to the same preventative strategies that we talk about. I'm not going to go too much into this because my colleagues have earlier spoken about the things we do, but these are the things we think about, and these are fairly universal. Looking at things like smoking cessation, blood pressure management, management of diabetes, dyslipidemia, alcohol, exercise, diet, etc. Looking at other causes of stroke based upon clinical presentation. So uncommonly, but from time to time, we will do things like more in-depth thrombophilic screens, vasculitic screens, thinking about other causes of stroke. That's based upon, the specific clinical criteria of how a person would present. The etiology of this is fairly split, but the most common that we would see specifically would be things like large artery and then cardioembolic making up a significant amount. So again, playing to my audience a little bit here, cardioembolic strokes are going to make up to a fifth, and that's probably going to count some of the other people who have no etiology identified, that there's just some source we're not aware of. So cardioembolic strokes are some of the big reasons why we see these from time to time. And strokes that come from the heart tend to be large clots, and they tend to cause large strokes as well too. So that's something else to think of. In terms of what we work up, so we want to have a good sense of a person's blood pressure. We want to have a good sense of their vascular risk factors. But remember earlier I was talking about getting that clinical data, looking for things like collateral flow, looking for things like the presence of a clot. We want to have some findings of the vascular imaging. And so this is why we do things like both CTs, but also CT angiography to get a good look at the blood vessels, to see if there's an occlusion, to see where that occlusion might have come from, and also to get a sense of what the collateral circulation might be. Cardiac monitoring, specifically to look at the presence of some reason why somebody might have a cardioembolic stroke, and then other tests as appropriate based upon their presentation. So if someone has signs or symptoms suggestive of a vasculitis, here's where we would put that workup in. You know the ideas in terms of cardiac investigations well. We will routinely get things in terms of screening investigations such as a transthoracic echocardiogram or a Holter monitor. Just to briefly talk about PFOs, because this will be something that commonly comes up, we will identify these, and it's really only in younger patients who we get to define as patients less than 60 that we think about closure in this circumstance. There is research going on to see, but that's one of the things we can identify. More often, we're looking at things like valvular changes. We're looking for presence of left atrial enlargement or other clues like that, some other potential structural cause where a blood clot would come from. And then Holter monitoring of some description, the longer the better. Generally 14-day is our standard. This can be done as an outpatient routinely, so we oftentimes don't keep people in hospital just for the Holter. It can be done afterward when we follow up with them. Atrial fibrillation makes up a significant amount of the cardioembolic strokes for that reason, but the other causes that we will see are people who have thrombi associated with things like acute MIs, the presence of a ventricular aneurysm. We see this perhaps a little bit less and less in terms of things like prosthetic aortic valves or rheumatic heart disease, but they do still happen from time to time. But atrial fibrillation makes up the large majority of our cardioembolic strokes. And we know that this tends to have a little bit of an age preference. The older you go, the more likely it is that atrial fibrillation is going to be an attributable risk specifically to that. And that fits a long time as we go through with that as we start to get into 70s, 80s, et cetera, we start to be very, very cautious about looking for the presence of atrial fibrillation. If somebody has a Holter monitor that doesn't show it, but there's still a high suspicion, so for example, they have left atrial enlargement, they have a significant burden of PACs, we may do another Holter or longer monitoring just to see if there's something we find. The monitoring for this, even with monitoring of even 21 to 30 days, we're still talking about a subset of people that we might not be able to identify. So there are possibly people out there who have atrial fibrillation that we don't know about it, despite it being present and despite best attempts to look at it. There is lots of research going in to look for other ways to be able to monitor this with implantable monitors, with smartwatches, with AI. So there's lots to come in this space in the future to be able to help to identify this. And then I've talked briefly about some of the other cardioembolic sources that we see. One you may see oftentimes, especially in the surgical areas, is people with endocarditis specifically, who've had something going on with the valve itself, and they have disease either due to some infectious or non-infectious etiology from that. Stroke in the young. So younger people, we tend to see a higher proportion of people who have cardioembolic sources not attributable to atrial fibrillation. These people are going to have a higher subset of strokes attributable to things like valvular disease, structural heart disease, and potentially we would think more about things like vasculopathies and et cetera. So briefly, that's kind of a very of how stroke works and the sort of things we look for that. Now I'm going to talk about codes and inpatient codes specifically. So when somebody presents with a stroke and you have a good understanding of, I'm going to look for this person's penumbra, now this is the actual procedure of how you're going to look for it. So imagine this scenario, you're on the ward on the 3rd floor or the 4th floor or something else like that, and somebody has an acute change and you think that they may have had an acute stroke. What sort of information is actually going to be helpful for us to get the information we decide whether a person is a treatment candidate or not? Well, we need to know when they were last seen well, and this is surprisingly tricky to find, especially in inpatient scenarios where last seen well may have been the last time that they were assessed by our nursing staff or something to that degree. So it might not be exact. And if, for instance, the last time they were assessed was during the night and they were in bed and around and everything seemed fine, but you're not sure, sometimes we have to default to earlier times than that simply because we're not sure. So right away, it's a little bit trickier in the inpatient setting because it is harder to get that time last seen well. We still need that information as best as possible, and we work with what we're given. We also want to have a sense of what the person's functional baseline is. So people who have inpatient stroke codes by definition are sicker than people in whom a stroke tends to come on out of the blue. They have something else going on that's prompted their admission to hospital. They might be post-operative. They might have some other kind of cardiac illness going on or some other medical illness going on that might A, make them more prone to that, or B, make them more prone to have the stroke to begin with. And in addition, if they're older, if they're frail, if they have other medical comorbidities, we need to know this because it does change a little bit in terms of the potential therapies that we can offer. What's their past medical history for that reason? So what medical illnesses have they been treated for? This might have implications for their ability to be treated with things like thrombolysis or EVT. Key to this as well is, are the deficits potentially disabling? So not every stroke is the same. Somebody who presents and you notice, well, their face is a little droopy today, and maybe their speech is a little bit slurred, but things are otherwise the same and they're not noticing any functional deficits. This very well might be a stroke, but it may not be a stroke code because the deficits are not necessarily disabling. This again is a little bit of a funny thing that oftentimes depends a little bit upon a person's own judgment. The classic example I give was as a resident, I treated somebody with non-disabling deficits. They really just had a little bit of difficulty doing math. They couldn't do mental math calculations. And the trouble was this person was a university mathematics professor, so he kind of needed that. So it's very dependent upon a person's situation. Somebody who is frail coming from an assisted living is going to have a different threshold of what's disabling than somebody who lives at home and drives and is independent. So this is a little bit of a moving target to some degree. What medications do they take? It's important for knowing if a person is on anticoagulants, for example. That's going to have implications for the treatments that we provide. What was their reason for their admission? Have they had any inpatient procedures? So did they have to have their anticoagulation held because of a surgery, or did they just have a peri-procedural event, something to that degree? And are there any potential risks for acute stroke therapy if the decision is made to treat them? So right away, you're getting a sense of the sort of things we need to know about. We also want to have a focused exam. We want to know what their blood pressure is, their heart rate, their blood glucose. Low glucose can be a mimic for some of the stroke deficits that we see. And so if somebody presents with focal deficits and their glucose is 2.3, they may actually respond to just a simple administration of glucose. They may not if there's an actual clot, but it's an easy thing to potentially fix. And then are they stable enough to go for rapid imaging? There are tools that you may see us use as well too. This is one example, there are many, to be able to try to do a focused physical examination to see what the likelihood of a large vessel occlusion is. So remember I was saying not every stroke is quite the same. Some are due to small occlusions, some may be due to a very large clot. And so somebody presenting with significant weakness and, for example, aphasia or neglect, that's going to have a higher likelihood of it being due to a large clot. These are people who are statistically more likely to have to go on to get EVT versus a small vessel stroke, which that wouldn't be necessarily appropriate for because the clot is too small. Okay. There are lots of algorithms in place. This is the one from the emergency department, so not directly relevant, but just so you know for review, that if somebody presents to the emergency department and there's a recognition that it may be a stroke, there's a sequence of events that goes into this. But basically, the emergency department team will activate a stroke code, and that stroke code brings the neurology stroke team to be able to come down. It makes porters available, it makes labs available. It basically gets all of those procedures to get that information happening so that it kind of bumps the priority for everything else so we can make a decision about treatment as quickly as possible. In the inpatient role, so this is a bit of an older algorithm, so we're looking at this to see if there's any, but the basic idea is the same. The only difference here is typically in inpatient stroke codes, we ask the team to call the neurologist first. So inpatient stroke codes are not activated by the inpatient team. They're activated by neurology in conjunction with that. And the reason for that is because of those things I was talking about. The situation is more complicated. So there's more factors that go into that decision making. So that's one of the reasons why we do that. But the other basic principles are the same. Once that stroke code is activated, then those same resources become available to us. And everything is kind of geared towards being able to get as much people to that imaging as quickly as possible. So we'll talk about that works in a second. The pitfalls from this, and I've talked a little bit about this before, that time last seen well, I've mentioned that can be very, very tricky and hard to gauge, and that information may change as more information becomes available. Last seen well a couple of hours ago, well, as it turns out, they really weren't talking at that time, but somebody saw them get up and go to the bathroom. If they're coming in with just aphasia, that might not necessarily be the information we need. What's their functional baseline? Ideally, we're trying to get a sense of what they were before they came to the hospital, but the fact of their illness management is going to have a role in that as well too. If possible, a prognosis is helpful. So if they have a palliative illness, for example, to get a sense of what the potential prognosis for that would be. I've talked about the medications they take, and we're specifically talking in this case about things like antiplatelets and anticoagulants and any potential risks. And really what we're trying to get at with this is what were they in hospital to receive, and did they get any treatments that would make things risky? Oftentimes that's surgery. Okay, briefly, acute stroke management, the sort of things we do. So I've talked about trying to get the sense of disabling deficits or not. There are scales that we use. You're never going to be asked yourselves to do this assessment in this situation, but if you see us doing what's called an NIH stroke scale, this is what we're trying to do. It's a very focused neurological examination that comes up with a specific score, and that score will end up showing us, how severe do we think the stroke is. These are just guidelines for communication purposes. It basically just gives us a sense of how severe do we think the stroke is. So we'll do that as part of our focused physical exam, and then we'll go on to try to get some level of neurovascular or vascular imaging. This is an MRI. This would be the absolute gold standard if we could get this. This is not going to be routinely available. Just to show you that there are sequences that can tell you right off, even within minutes, if there's acute ischemia. It would be nice if we could get everyone to get this, but we oftentimes can't. So what we rely on oftentimes is CT. The plain CT itself, the real purposes of a plain CT is basically just to rule a hemorrhage. If you see hemorrhage, that's going to be an entirely different pathway. If you don't see hemorrhage, you're still thinking that if this is an ischemic event, this person may be eligible for thrombolysis, this person may be eligible for EVT. You can use that to tell you if there's the presence of early ischemic deficits or not, but the plain CT is enough to be able to make a thrombolytic decision. Beyond that, we need some level of vascular imaging with this, and this is becoming more and more advanced as time goes on. The CT angiogram is excellent for being able to identify the site of an occlusion. This is a large occlusion in the top two in terms of good collaterals and intermediate collaterals. This is something happening in the left M1 territory. This would be exactly the sort of person that you would want to take to the EVT suite to open that clot up as quickly as possible. The one on the bottom is a right M1 occlusion. They have poor collaterals. Remember how I was telling you every person is a little bit different? This person is probably going to have a large amount of unsalvageable core because they don't have good collaterals out beyond that. Depending on the situation, they may still be a candidate for EVT, but they're not expected to do as well. So this also gives us a sense of prognosis as well. We do have access to other tools as well that can tell us a little bit about that perfusion. If you see us looking at things at Rapid, that's not available at the Heart Institute scanners, but we have it at the Civic to be able to tell us a sense of both the core and the penumbra. And you can use these maps to match this up. These are not perfect. There are things that can give you false core. There are things that can give you false penumbra, but it is a potentially helpful tool that can tell you a little bit about the degree of salvageable tissue that you think. And it actually is now at the point where it pops up on our cell phones, and we're able to use that even as we're coming in to be able to help to determine what the potential therapies for this may be. We have 3 basic therapies that a person might be eligible for. There's best medical therapy. This is based upon their presentation. This is antiplatelets. This is the stroke unit. This is the management of etiologies and things to that degree. And then there's the presence of things like thrombolysis and endovascular therapy. Thrombolysis is typically tenecteplase, TNK, given within 4.5 hours. Endovascular therapy, for those large vessel clots, you can actually take it out. There are time windows for this, and in certain cases, certain carefully selected cases, we can do that out to 24 hours from the presence, but that has to be very carefully selected. The targets for this, according to best practices, we really would like to see things within 30 minutes of last seen well, where possible. So you can get a sense that this can be very, very tricky, even in the outpatient setting, even in the emergency department setting. In the inpatient setting, this can be quite challenging, especially if you're not certain of the time last seen well from this. But that's the best target. The longer beyond that, the less time, the less benefit you're expected to get from this. And if you start to go beyond 4.5 hours, the benefit starts to really become minimal at that point, and your risk of hemorrhage, which is the main complication of this, remains the same, about 3 to 4%. So these targets don't reward ambiguity. After that, I can't overemphasize the importance of the stroke unit team. This is a recognized therapy. So ideally, we would have people admitted to a stroke unit, depending on their comorbidities. For post-cardiac patients, this isn't always possible. So having some expertise in terms of people from our colleagues in physiotherapy, occupational therapy, speech-language pathology, social work, we know that this is associated with better benefits and outcomes and helps to bridge people to rehabilitation afterward. Just to briefly talk about the things we walk for after a stroke. So the presence of DVT. Stroke can make you immobile, so it can make you more prone to having the presence of a DVT. People are also more prone to having MIs after stroke, oftentimes due to the same risk factor and sometimes due to specific things that happen in the brain to affect heart rate. The presence of pneumonia below, especially from aspiration from people who have difficulty swallowing, very common post-stroke complication. And then, as was alluded to earlier in some of the things, even longer term, people can get things like fatigue, people can get things like depression, and then post-stroke epilepsy is something that hasn't really been talked about yet, but people can develop seizures afterward. If you have a scar on the brain from a stroke, that can be a potential seizure focus. So something to think about. There are decision-making tools that we use to determine if a person is a candidate for inpatient stroke rehabilitation. We've talked a little bit about those pathways to go from that, but our stroke team colleagues are the best people to help us sort out. And then during that time, we're working at our best to try to find out why the stroke happened and prevent it from happening again. And just to talk a little bit about how things have gone from the Heart Institute itself, but there's been discussions about how we can improve that process here. And we certainly are happy to talk about this with our colleagues, but this is something we've been trying to engage with for some time to be able to make this process as easy and seamless as possible. One specific point is making that stroke team expertise. If we don't necessarily have people admitted to a stroke unit, to give people a sense of what the stroke pathway after a stroke would be, to make sure that people know who needs to be referred to where, to make sure that people know what specific therapies and interventions that might be able to get from that. And so this is something that we're hoping to continue to work on with our colleagues here as well too, to be able to help bridge that transition. And again, just to give you some numbers in terms of how often this happens, this is not an uncommon thing, but in terms of the number of stroke codes that we see at the Heart Institute over the past few years, these numbers fairly stable, and we have some 2023 numbers in terms of inpatient codes that show that the Heart Institute has about 33 codes. About, 8 of those were actually treated. So 33 codes in total. 1 received thrombolysis, 6 went to EVT, and 1 got a combination of both. The people that got thrombolysis, by the way, had a door-to needle time of 32 minutes. So this is actually possible, that 30 minutes or close to that I've spoken about from that. But this again just gets to that idea that it's not an everyday occurrence that it happens here, but it is good to know what the procedures are and to know what it is that we're trying to do from this, so that when you call to activate the potential stroke code, you know what you're getting into and what it is that we need and how we can best help manage the care of the patient in that moment. So that was a lot of information to throw at people very, very quickly. I think we have some time for questions, but just again, everything I've gone into is available in more detail on the website in terms of the Canadian Stroke Pastors best practice recommendations, And with that, I will stop and happily open up to any questions and discussion. Thank you very much for the invitation.
All right, if our lovely presenters could come up to the table, we're going to open up our Q&A portion. Our very own Kelly McPhail is going to moderate, and we will be taking questions online, so please feel free to type in your questions.
I will start the questions off. We hear all your overhead pages for stroke codes. And is there any correlation with atmospheric pressure changes and stroke codes? Because there tends to be a lot. And we hear a lot of migraine sufferers say, oh, there's a change in the weather, I'm getting a migraine. And of the stroke codes that are called and emerge when we see these weather changes, how many turn out to be actual strokes?
Oh, no trouble. Thank you. So that's, as a migraine sufferer who spent the last week as the thunderstorms of rolling in being a little bit gritting my teeth here and there, I feel that question. I really do. So I'll take a step back and I'll talk a little bit about mimics, because that's kind of what we're coming into. Like, if it's not a stroke, what else could it be? And migraine aura are the most common in terms of mimics that we see from that. Maybe not necessarily for inpatient codes, where oftentimes it's due to some other medical process going on, or a metabolic or an infectious illness, but definitely in the community that's most common. And so that can sometimes be easy to tease out, and sometimes it can be very, very challenging. And so I don't think we have a lot of great information in terms of barometric pressure being specifically in and of itself a risk for strokes. And as such, I don't think we have great information in terms of whether weather systems result in a number of stroke codes from that. What I will say is that definitely people who come in that and we think it's going to be a migraine, that would be one of the things we would potentially think of. And we always like to have an explanation for it. The other thing I'll point out, though, is that maybe in terms of atmospheric changes, one thing that's been actually recently reported on in the data is that temperature extremes, not necessarily barometric pressure, but temperature extremes do seem to be associated with an increased risk in stroke incidence. And this is happening across, and it's not just in high extremes, also in low extremes. So variations in temperature, we don't have a great mechanism for this just yet, but it is a thought and something worthy of study.
I'm the PACU educator, so kind of know your patients, but I'm at the 3 campuses. Yeah. So my question is, you know, everything's concentrated on the civic, but we will get the strokes at the general campus. There is lots of mixed messaging coming from the neurology team when there's a stroke in the OR or in PACU. There's mixed messaging of, is neurology going to come and see the patient or not? And even if anesthesia is like, no, they're having a stroke. But my other thing for my nurses is some neurologists will say, yeah, have the CT done at the general. Others say, don't even do the CT at the general, just get them done at the civic. So what is the best route so I can tell my nurses?
Sure. So that's going to depend a little bit upon the situation. And that's going to kind of come to those factors we were talking about inpatient stroke codes being a little bit tricky and challenging. The question in terms of whether a person is going to come to the civic or not is, are they a candidate for EVT? Or are they a candidate for acute stroke? So if a person, for example, is anticoagulated, has just had a procedure that would make them unsafe for thrombolysis, and if the scan doesn't show a large vessel occlusion, they're not going to be a candidate, so they wouldn't come over to us. So the thinking would be in that case, like if we don't think this person is a large vessel occlusion, then there wouldn't be any purpose in bringing them over, because we would just have to figure out what to do with them afterward without providing any therapies to that degree. The question is a good one, though, because if you're getting different things based upon that, what we're trying to sort out, first of all, is a way to make that a standardized procedure. That's A, going to make sure people get the information they need to make a decision. B, bring over patients who need to be brought over, but also C, not bring over the patients who don't need to be brought over. And that's a little bit of a tenuous and tension-filled thing right now that we're trying to sort out, especially as we're trying to figure out where people would best go to. For now, I would say that the best way to default right now is to figure out, if I think this person is having an acute stroke, I call neurology to help to determine if it's a stroke code. If it's at the civic, just that because that's where we're concentrated, it's a little bit of a different situation. At the general, because it's much less of a neurology presence, that might be why that they might not be able to make it as quickly as possible. And so if they are asking for a CT first, that would be the reason why, to help to determine if this is a reason where somebody would come over with that. We would certainly, and we were just having a discussion about this last night at our divisional meeting about how we're best going to approach this as we look at different structures of providing stroke code guidance. Inpatient stroke codes at the general are always going to be our most challenging, simply because they're the ones that we're least likely to be physically there for it, and we're going to rely on our colleagues to be able to give us that more information. So this is where we get involvement from the race colleagues. This is where we maybe are going to have that different threshold for getting the scan first. But at the same time, calling the code just makes things like this, the scanning and things happen like that, right? So when the code is called, they may call ahead and say, call the code, I'll be there as soon as I can. In the meantime, we will get the scan and we'll have that information by the time I get there. I think that's what they're trying to aim at, if that makes sense. And so the messaging I would give to your colleagues would be, the purpose of the stroke code is to get the information to determine if a person needs to be transferred or not. That might look a little bit different, and we're looking at ways to standardize that. Yeah, absolutely. I have a feeling we'll be emailing each other quite a bit.
I have 2 questions online.
Okay.
Number 1, have you noticed a large increase in strokes in Ontario in the last few years? The person has said, I know that here in Newfoundland in our ICU, we have noticed a large increase in strokes.
So the trends of this over time, so generally the incidence of stroke has been going up. Are those strokes necessarily resulting in stroke codes? That's a bit of an interesting question. And I remember in the earlier phases of the COVID-19 pandemic, we were actually seeing fewer stroke codes for a while. Part of that was because people were anxious about coming in specifically. And so everywhere had this kind of notable dip. So that's been one blip from that. There's been another increased recognition of people having strokes after the fact. So they will have scanning done for a different reason, and a stroke will be found almost incidentally or after the fact. And so that kind of gets counted a little bit in the pure incidence numbers. We're starting to see things revert a little bit more to this idea. So here, year over year, our number of EVT cases is going up, our number of stroke codes is going up. And I think some of that is reflecting both incidence in the community, and also hopefully a better recognition of people having stroke symptoms that are coming in faster and being able to. It's also a recognition that there's the eligibility for these treatments is also increasing. So we're right now trying to undergo a better understanding of that concept of core and penumbra that I talked about. We're undergoing this revision, or we're trying to figure out, are there people with larger core who may still yet benefit? Some of the more recent studies have suggested that people could. And so we're trying to sort out from that. And we expect from that, we're going to see more and more stroke codes because more people could potentially have some benefit, but we're not sure just yet.
Yes, I'd like to ask about the increase of stroke as one ages. Is it an increase of both ischemic and hemorrhagic stroke? Both?
In general, as we get older, we start to see more and more differences in the attributable risk for specific things that would cause stroke. So for ischemic stroke, we'd see more atrial fibrillation. For hemorrhagic stroke, we'd see more things like ruptures from amyloid angiopathy. But the sheer number of strokes tends to go up for both of those. I'm not sure if they both go up at the same rate, but we do know that the older you are, the more likely you are to have both ischemic and hemorrhagic strokes, yes.
Okay. Now then, as a layperson thinking, would then anticoagulant be recommended for high age people to reduce the risk of ischemic stroke?
So that is a great question. And the answer to that is no.
Why not?
The reason for that is because, so we know that anticoagulation really does help with stroke secondary to atrial fibrillation. But they've actually done studies to look at people in whom they don't have atrial fibrillation, but they suspect there's a cardioembolic stroke. And so there was a study called RESPECT ESIS, and there was a study called NAVIGATE ESIS, and they basically did exactly that. We have people with strokes that we think it's due to a cardioembolic source, but we're not sure. Will anticoagulation do better than aspirin? And the answer to that is no, people on aspirin did just as well as anticoagulation. And there was a trend towards higher hemorrhage rates. And so that's the real key to this as well. People who are put on anticoagulation and don't necessarily need to be are going to have a higher risk of hemorrhage. That risk can be managed to some degree, but you're putting a person at a little bit of increased risk, and the trade-off doesn't appear to be worth it for the reduction of ischemic strokes for everybody. Now, atrial fibrillation, absolutely. Those people need to be on anticoagulation or have some other strategy. But as far as we can tell, the simple fact of getting older doesn't change things, and you still will get the risk of hemorrhagic stroke that will come from that. And so putting everyone on anticoagulation seems to just increase the risk for hemorrhage without giving you a significant ischemic benefit.
Thank you.
You're welcome. It's a great question.
Okay, we have another question here.
So when someone is approaching the 24-hour mark, so far as endovascular therapy goes, what deficits would that patient have that would make you decide, yes, we're going to do it, even though it's like 23 hours in, or no, we're not going to do it. It's not worth the risk based on the deficits.
So it's not necessarily a question of the deficits. It's a question of how much tissue do we think is salvageable. And this is where those advanced imaging things come in. So the CT scans, the CT perfusion, all that stuff, what it's trying to tell you is how much of this tissue is salvageable if we open this blood vessel up. And in general, the rule of thumb is the longer time goes from the time of the blood clot, the more core there's going to be relative to the penumbra. This is coming into question a little bit in terms of some recent evidence. So we aren't 100% sure. We aren't as necessarily certain about this as we thought we were, perhaps, but that still does seem to hold true for the most part. So the degree of deficits, it's an important part of the consideration, but somebody who has severe deficits and their scan still looks good at 23 hours, 59 minutes. And what I mean by good is that it looks like there's tissue that you can salvage and there's ways to measure that. That's somebody we're still going to go full steam ahead on per se, versus somebody who, you know, the situation we don't want to be in is somebody who's at 20 hours and it's a young person and they've got lots of deficits and we know we could theoretically do good, but the scan shows that the damage has already been done and there's large core. Then if you try to open it up, the worry is that you're going to put a person at risk of what's called reperfusion injury, of causing hemorrhage within that stroke and making things worse without the benefit because the tissue is unsalvageable at that point. Again, we're not maybe as certain as we thought we were based on recent evidence, but that's the thinking behind that. So the degree of deficits don't make the decision, it's the degree of what we think is salvageable on the scan.
We have another online question. Will Heart Institute nurses eventually have training for the NIH stroke scale?
Do you want it?
So I'll just answer this from a PACU perspective because my nurse have asked the same thing because we have lots of stroke codes. And it's just to have that, you need to be certified. And if you don't see enough stroke codes, you lose your certification. So unless you're always going to get stroke codes every single day, there's no use of having the NIH SS. So like for PACU nurse, we get strokes multiple times a week and we still would not be able to keep our certification. So doing your normal neuro assessment is good enough.
Great, thank you.
About that, I would just say, like, if you're interested in building your neuro knowledge, going and doing the NIH stroke scale training will add to the repertoire of your knowledge. What you're saying is valid in that you wouldn't keep your certification up, but if you want to expand your knowledge, there's lots of websites you can go to follow that certification, and it's great for nurses to have those skills.
We have not been operating on the assumption that we're going to require certification from nurses who would be seeing this as part of their day-to-day skill set.
Hello.
Hello.
I'll try to formulate my question, but coming from two backgrounds, I used to work at Briere at the stroke rehab, and I worked at cardiac surgery ward unit for a year or two. And it's just two observations that I made that kind of cardiac surgery patients are a little bit compromised in terms of stroke rehabilitation and stroke treatment. Like after cardiac surgery, immediately there's a sketchy time where they might not get thrombolytics to actually help them. And then during the recovery after stroke, they're not qualifying for a rehab program soon enough to be optimized, potentially better than, because of the sternal percussion. So it's like a double whammy, like on multiple stages of the recovery after the surgery. So I'm just wondering, is there anything like specific going on between stroke teams and cardiac surgery teams that's like optimizing the stroke patients after the cardiac surgery, or it just happens to be kind of?
So some of that comes to some of the initiatives that we're looking at to be able to get early enlistment so that people have a sense of what the stroke pathways are, so you know who needs to be involved to be able to assess that. The reality of the situation is that inpatient stroke codes, we've known this consistently from the evidence of it, that people tend to have worse outcomes. And some of that comes from those features. Because of their medical illness that has put them in hospital, they don't necessarily have the same eligibility for the stroke treatments. Because of their comorbidities, the pathway to rehabilitation may be more complicated. I can certainly let my colleagues speak to that a little bit as well too.
Yeah, the sternal precautions piece is a challenge, but we have created some algorithms and guidelines around sternal precautions so that patients can still access rehab. And timeliness is important, but of course, even if we have to wait for them to be off sternal precaution, we can still go to rehab after that.
Do you think that will be changing with our modified, so I'm over here, with our modified sternal precautions now?
Oh, I don't know what the modified sternal precautions are. I'm sorry.
That's okay. We can chat later. It's essentially not moving, being able to move your arms a little bit more as to our traditional.
Yeah, it could be. And we also have to look at what the deficits are. And if our movement isn't the issue and it's more legs, brain, and speech, then they should be able to access rehab.
You mentioned after the assessment of the ER, you will try to see if you can salvage the rest of the brain tissue by opening the blood vessel. What is that particular procedure in opening the blood vessel?
So if you hear us talk about EVT, that stands for endovascular therapy. The long and the short of it, basically, it's very similar to somebody having a cardiac angiogram. It's a cerebral angiogram. And so they'll go in through the groin with a catheter, they'll get to the clot, and then we usually have a combination approach. So there's a little stent that they put across the clot, and that stent expands and it gets mixed up with the clot, and you let it sit for a minute, and then you pull the whole thing out, and you're pulling out your stent, but you're hopefully taking the clot with it. During that time, they also have a little vacuum going to be able to help to provide some suction to this as well too. So really, that's the simplest way to put it. They're trying to basically put a stent across and pull the clot back out with a bit of assistance from vacuum from that. And if you can get that open, then hopefully you've been able to restore flow to that penumbral tissue as much as possible. And that's really that approach that they're trying to get to.
Set up to groin?
So it doesn't necessarily have to go through the groin. So if somebody has, for instance, peripheral arterial disease, so a blockage there, they can go in through the radial artery as well too. To get in through the jugular, that would be a different connection. So there are very tense procedures where they'll sometimes do a direct carotid puncture. Yeah, we kind of sit there biting our nails a little bit for those procedures. But if that's the only option you have, it has been done. So, but that would be kind of a last case. This is the only option. A person has no other way to access it. And in a situation that would be, this is our, last best hope for opening this up. It's not something we would routinely do.
Any other questions from our audience?
For the people online. So this is actually to go back to the nurses that were actually, or the ones that were working in emerg. So technically at the general, we are the stroke unit, and we also technically don't have the proper training. Like, we do stroke codes here and there, don't get us wrong, and we get the stroke patients. It's just that we don't have the certification, and all of our new nurses don't either. So we're still kind of following up with all of that. Is there anything that we should be like asking for to actually do it once we get hired? Because all of us, most of us, don't have it.
So we're looking at, so the general is one of the situations where we're trying to figure out what the best approach is. Yeah, so we recently changed some of our algorithm a little bit to be able to bring some patients over to us for stroke unit care. We're also looking at getting our colleagues in hospitalist medicine as well to be able to try to cluster these patients a little bit better. So it might be a little bit easier, especially when it's kind of a more focused cadre of nurses, perhaps, to be able to kind of have that more focused training at that point. But that's still something that's in flux and being developed right now.
So something we created for staff in emergency departments, acute care, as well as in rehab is targeted or stroke orientation modules. So in emergency, they're all up on Elm. There would be some modules that you could go through that would go through some of the essential definitions of stroke, signs and symptoms, and some of the characters you'd have to look for. Otherwise, it's really, I think, deferring to the algorithms that would be posted in the emergency departments. Again, a lot of the assessment that Dr. Black here spoke about today is to kind of be aware of those signs and symptoms and activate a stroke code when appropriate with the neurologist.
Thank you guys so much. That was so informative. I learned a lot, and it was nice to hear what the cascade of events is when we hear that stroke code overhead. So thank you for painting that picture, and we really appreciate you being here today.
Thank you very much for having us.
So we're going to move on now into our final portion of the day, and that's cardiac prevention. And I'd like to introduce Dr. Karen Bouchard and our patient partner, Laura. Dr. Bouchard is an associate scientist and director of the Cardiovascular Health Promotion, Education, and Social Determinants Lab at the Heart Institute. Joining her is our patient partner, Laura, and together they are going to speak to us about navigating heart disease within the family.
Okay, so we're both going to share this podium here. So what better way to end the day before we go home to our families by talking about how heart disease can impact families and vice versa, how families can impact the course of heart disease. So we all know that many adults with life-threatening conditions are also parents, and some of whom have children that live at home. So we know parents face the dual challenge of coping with their diagnosis and their symptoms while also having to parent. So we've heard a lot that parents are often very concerned about the effects of their condition on their children. So today that's what we're going to talk about, and Laura's going to give a little insight from her situation and her family, and I'll talk a little bit about the current evidence in this area and some of the projects that we've been involved in at the Heart Institute to try to help these parents and families. So,
perfect. Thank you, everyone. Can you guys hear me okay? Perfect. Awesome. So my name is Laura. So as everyone mentioned, I'm the patient for today. So just to give a bit of a background on me, I was diagnosed with an idiopathic ventricular arrhythmia at 36. So about almost 2.5 years ago now. I'm 39. And I had a cardiac arrest, and I underwent an ablation, and I now have an ICD inserted. So as part of that, I went through rehab, and I got involved with the Patient Partnership Council, and that's how I've kind of been connected with Karen and other members that are here today. So just to give you a bit of background, or I guess the family impact, as Karen mentioned, there's multiple facets to this. There's really the impact on the parents, and there's the impact on the children. So as the parent who's also a patient, it's very different than how it necessarily impacted my husband, who's the partner, right? So I felt a lot of guilt, like we all talk about mom guilt in our real lives, but I had immense mom guilt after all this, because there was a lot. I couldn't do anything. I'm mom, I'm supposed to do it all, and I really couldn't do any of it. And then my husband, he felt, all kinds of symptoms, like he was sad, he was angry, he was frustrated. You know, we really didn't know what to do and how to handle this. So this picture there, it's not my kids right now, but that's how old they were when this happened. So my daughter was 3 and my son was 20 months at the time. I had a lot of physical limitations. You know, I couldn't lift a lot of things. I couldn't drive. My husband really had to fill in that role for me. But the biggest impact, I think, was on my children. Maybe they didn't, my 20-month-old, he didn't really understand. He just knew mommy wasn't there, and there was really no amount of explaining that was going to explain why I wasn't there to him. He thought it was funny when we got to FaceTime after a few times, so it was all okay there. But my daughter was 3, so she was quite devastated. She didn't, you know, where's mommy? When this happened, it was the height of COVID, so they couldn't come in and visit me. So there was a lot of, you know, a lot of layers to this. After this, my daughter was quite terrified every time I left the house, because when I had my cardiac arrest, I had left to go do errands. So we had to stop saying mommy's going to do errands, and it was just mommy's just going to go out for a minute. And that lasted about 6 months to a year. And it took us a while to click in that that was probably what it was about. You know, mommy couldn't do the normal things. My son was 20 months. I couldn't put him to bed on my own. I couldn't lift him. I mean, I'm short as it is, so it's hard to get him into the crib, but I really couldn't lift him in the crib. So we had to modify that. I missed the first dance class because I couldn't drive. And someone had to be home with my son. And then I chose this picture because it was around the month I came home. It happened in October, and I really didn't know, like, was I going to be okay to go trick-or-treating with my kids? Like, I was still in the Heart Institute till about the 13th, but it all worked out in the end. And the biggest thing was trying to come to terms with my diagnosis as a family, and especially at, you know, 36 as a young mom. It's, you know, when you take those vows, for better, for worse, you really don't think they're kicking in at 36. Like, you kind of think that those are way off from then. But I did learn, you know, we tried to explain to the kids as best we could. I found a random YouTube video that was meant for adults, but it was a cartoon. So my daughter would watch it, and it showed a pacemaker, and it kind of explained to her a little bit of what mommy, the machine that mommy had in her heart. But kids are adaptable and they learn quickly. So my kids learned to just crawl up next to me, so and sit and snuggle and bring me books. So that kind of was like the immediate impacts on my family. Oh. I'm going to talk more.
We can clap throughout. It's great. Okay, so what do we know from the literature? So we know about approximately 10% of Canadian children have a parent who has a chronic physical illness. And that amounts to about 700,000 children across Canada. So we're not dealing with just a small amount of kids, it's a lot. And in comparison to those who don't have a parent with a chronic physical illness, these children tend to report more difficulty concentrating. They have higher levels of hyperactivity. Often they'll have poor school attendance. They have more psychosomatic complaints, so more stomach aches, headaches, and they demonstrate more externalizing problems, so issues with aggression, impulsivity, as well as internalizing symptoms, so things like sadness, feelings of loneliness, anxiety and depression symptoms. They also tend to have a little bit of lower self-esteem. But paradoxically, they also have higher, maybe not paradoxically, but there's also some positive things that can come out of it, right, as well. So these children typically report higher social competence, as well as higher levels of empathy. So there's both good and bad that can come out of this. Most of the literature tends to focus on the bad, but there are some benefits to children in terms of, you know, how they interact with others and the empathy they feel.
So what is the problem? And I think when you look at a problem, you really need to know, like, what's the challenge, right? So how do we understand the impact on family members? So as I mentioned, you know, being a patient, it was, you know, what did I need to move forward? But also I'm a mom, so it's really hard to focus on what I need to move forward, but I also need to focus on my family. You know, and the same with my partner. There's a lot of, you know, what supports are available to him, but really, how do we move forward with this as a family? And, you know, you always talk about, you know, parents really need to put their oxygen masks on first before they put their kids on. And you can probably apply that to lots of, you know, parts of parenting. But it's true for this as well. So we have to do the work for ourselves, but, you know, then try to focus on our children and really how do we support them? So, you know, the big problem being, you know, explaining heart disease to your child and, you know, what is it? How is it going to impact them? But it's not easy at any age. So you have to make that age appropriate for them. And realistically, depending on when this is happening in your life, you have to do it again and again and again because they forget, they understand more. And then you're just waiting for the questions. You're just waiting for that hard question. You know, my daughter's slowly built up to it, but she's never asked. Like when I asked what doctor I'm going to, she was like, which doctor? which doctor are you going to? Is it the family doctor or is it doctor here? Like she's now started to like associate those. And so she hasn't asked, is mommy going to die? Like she doesn't ask those questions and she eventually will though. So it's, is the machine still working? Like that was one that she asked a couple of months ago. So it's the real problem is, not having the tools to, I'm not a psychiatrist or psychologist. I don't know, like, how do I tell my kids that, how do I support them? How do I explain this to them? How do I put their fears to rest in an appropriate way? So I think that's probably the biggest challenge.
Should we clap again? Okay, so the parent's illness context really does matter in this case. There has been a tremendous amount of research that's been done in oncology and substance abuse and HIV. But from our recent scoping review, we found that less than 5% of existing studies that look at psychosocial and behavioral outcomes in children have been done in a cardiac context. So I'll just show you very quickly the two studies. So the first is a quantitative study of about 9,000 children. They compared those who had a parent with a physical illness and those who did not. And what they found was that the odds of children reporting difficulties with emotions and concentration was 2 times that of their peers whose parents did not have cardiovascular disease. And the qualitative study here that you see that was done out of Norway. Oh, and just as an aside, Norway is like really, they're the ones who are advancing the literature in this area. So we must all be like Norway. So it's a qualitative study and identified several important themes relating to living with a parent who has heart disease, including growing up ahead of time, the importance of parents establishing safe spaces where children can maintain some sort of normality. So this was a small study, but it gives some insight into what the experience is for these children. Now, of note, there have been no interventions in a cardiovascular disease context. So if we look outside of cardiovascular disease, there's been a small number of child and family-based interventions that have been evaluated. And the majority of these programs do involve some sort of counseling, family recovery planning, and communication improvement. And they're often facilitated by social work, psychology, and nurses. And I am happy to report that a lot of the meta-analyses that have been done on this have found that there's small to medium effects that have been observed, especially with improving things like children's internalizing symptoms, family conflict, as well as perceived stress in the parent. So there is some weight to these programs, but there could be some utility in a CVD context. We just have not yet studied that. And I think this is really important for many reasons, but also, as we know, there's a rising incidence of premature cardiovascular disease, especially among young women. So this is something that's always been an issue, but it's going to become even more of an issue in the future. So we really need to address this. The problem is that in a CVD context, we really don't know the severity of the problem. Are the kids all right? We ask ourselves. And where, when, or how can we help these children if they are not all right? So I'm just going to give you just a very quick snapshot of one of the projects that we actually started, Heather Tulloch's lab. We were looking at how children of parents who have a parent with cardiovascular disease, how they've been impacted. And we looked at the psychosocial, behavioral, and lifestyle changes that are experienced in the family, their challenges that they've encountered, and the needs of patients, spouses, and children. Now, the first phase was to talk to parents about this. So what we did is we conducted qualitative focus groups with patients and spouses at the Heart Institute, and we just followed a qualitative thematic analysis with deductive inductive coding. So just a little about who we learned from. So we had about 32 participants, 24 patients, 8 spouses. The average age was about 46. And then you can see the breakdown of the conditions that our patients had. Most participants had about 2 children, and the mean age was 12 years, but really we had a broad range. So some participants had, a 2-year-old, and others had up to 24-year-old. And there's about an even distribution of female and male children. Okay, so what did we learn? So we really were interested in the challenges experienced and their needs. So the challenges that these families experienced were disruptions to their family routine, uncertainty about the future, fluctuations in parents' emotional health, And then a lot of parents discussed increased withdrawal or overprotective behaviors in children. So while some children withdrew, others were very overprotective. And they also noted that there was limited developmentally appropriate and cardiac disease specific resources, which noted before. So what do they need? Developmentally appropriate and engaging educational messaging for children. Psychosocial support for the whole family was desired, and the emphasis was on improving communication skills. So really just having that conversation with children and that ongoing conversation as things change. And also access to a healthcare professional for reassurance and to provide support with any of this messaging was what they were asking for.
So what is needed? So really, as Karen mentioned, is support for the families, and it really comes down to information and relevant materials. So something that's built for a growing family, because as you know, it impacts many families. It could start when a child's 6 or 2, and it goes on for their hopefully a very long life. And what you tell a 3-year-old very much differs than what you need to tell that child at 9 or a 9-year-old or a 15-year-old. And as children age, they need to better understand the impacts on them. Like, is this something that they do potentially need to be worried about? So as they enter adulthood, should they start looking at any risk factors or what have you, depending on the condition? For me now, and I think it's important that you do this with your kids anyway, but for me, it's very much informing my child now. How do we call 911? But how do we say if mommy has, if it's related directly to mommy, my mommy has a heart problem, like maybe letting them know that sort of thing, or let them know that I have that emergency information on my iPhone and how to get to it when she's a bit older. So it's really just getting that information, but the lack of having those relevant materials that what to say, those scripts of how to say it, how to make it age appropriate, that is, something that is very much, I would imagine, needed by many parents.
Okay, so that segues really well into what it is that we did and are doing. So the first thing is we developed a guide discussing heart disease with children and youth, a guide for parents and guardians. So this is it'll be a patient education material that will be available soon. Yeah. So this was done in conjunction. So Dr. Heather Tulloch, Bonnie Quinlan, we had a patient partner who was helping us, and Laura, you helped with us this as well. So basically, we just developed this patient guide on how to talk to children about heart disease. So we have we have top 10 tips for how to discuss heart conditions with children. And then what we've done is we've actually broken it down into developmental stages. So we have, 0 to 2-year-olds, what should you do? 3 to 6-year-olds, what should you do? All the way up until late adolescence. So we're hoping that this will be, useful for parents and maybe address some of the needs that Laura spoke about. The next thing we did, which was kind of a fun little activity, is we developed a child-friendly glossary of relevant cardiology terms. So I have to say, this thing started out as 1 page and it is now 6 pages because we keep adding and adding. And again, super awesome team effort. We had so many people from the Heart Institute involved in this glossary. We had Sophie Briere, who's a nurse over at CHIO, who also helped with a lot of this. So it basically will go into different cardiology terms and how the terminology that parents can use with children. Oh, did I not show it? Oh, there we go. So you can just see as an example. So, an arrhythmia is when the heart doesn't beat regularly. It's supposed to speak as regular as it's supposed to. Instead of going thump, 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 it might go thump, 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 or skip a beat. It's like a drum making a rhythm. So we try to use a lot of imagery and terms that kids might understand. So the next phase, as I alluded to before, is we're going to be doing some interviews with children of parents with cardiovascular disease because, of course, hearing from them is super important. So that'll be the next pilot work that we do. Heather and I received some funding from SHRC, the Social Sciences Humanities Research Council, to conduct some of these interviews. So that's exciting. And then that's going to all be fed into a child-targeted resource. We don't really know what it's going to look like yet. We have an idea. It might be some sort of children's book or a series of pamphlets or multimedia resources, but the interviews that we do with the children will really inform this resource. Okay, so key takeaways. I think just overall, the key takeaway is to really just remind ourselves that health is really a family affair. So this is an article that came out in the New England Journal of Medicine, and I often just go back to it and read it because it's very, very helpful just to remind. It's very obvious, but it's something that we forget a lot, is that our cardiovascular conditions are really impacting those who are around us, and they can actually be really helpful for us in our recovery. So I encourage you to take a look at that publication. And this is just something I came up with. I think it's just a helpful way of thinking it. So the first step really as a healthcare provider, I think, is just to consider that a patient's health condition could be impacting their family. So just even having that thought in our mind. And then communicate with the patient to ask, is this something that's happening to you? How are your children doing? Just overall, how are they adjusting? And then if the answer is they're not and they require some help, then we have some resources that are available that you can connect them with. And hopefully our guidebook will be out soon. And then if not, consult for outside help from trained healthcare professionals. So I think it's just important to think about those steps there. And do you have any final comments? Or oh, also just thank you very much for inviting us.
Are there any questions in the audience?
Will these resources be available on the units to give families while they're waiting for procedures or surgery or anything to start the process?
I would think so, eh? Yeah.
Yeah.
Yep.
Just like any of the other patient guides.
There was another question somewhere. Oh, same question. Okay. Any other questions?
And can I just say also, this is sort of a work in progress research program activity. So if you do have any suggestions of things you think would be really interesting to add to this, just let me know. Thanks.
That was awesome. I'm going to have to let our AFib panel know that they did not use the terms wiggle enough based on the kid glossary. That was great. Thank you very much, you guys. So as our day is coming to a close, I'd just like to remind everyone to please complete the surveys. We really appreciate your feedback. For those who already took the time to complete our afternoon survey, thank you. And as a result, your names were entered into a draw, and the winner was Jana Burns, who might be online. Jana, if you're online, we will contact you. And now finally, I would like to ask Bonnie Quinlan to return to the podium to provide our closing remarks. She is our Director of Cardiac Prevention and Rehabilitation here.
Thanks, Tori. Well, first, a huge thank you to all the participants in person and online for attending this event. We'll do the numbers math later, but certainly having almost close to 350 participants register is, I think, a record. So, wow, thank you so much. I want to say a special thank you to our patient partners who kindly participated in this. So Sarah, Anne Marie, and Laura, your input in these kinds of educational days have a huge impact on what we learn and what we do in clinical practice as healthcare providers. We're very, very grateful, and thank you from the bottom of our hearts. Thank you to Novo Nordisk. I think the rep is gone, Derek O'Neill. He kindly supplied all the food and refreshments for today. So a big thank you to them for supporting this event. Special thanks too to all the amazing speakers that we had. Truly remarkable. I learned a lot today as well. Thanks to Phi in IT, who's been back and forth all day, making sure that everything has been working seamlessly again. So thank you, Phi. And our housekeeping, Rob Forget's team as well. A huge thank you to Tori Temple for quarterbacking this event. Thank you, Tori. You did an amazing job. Wow. I think it might have been a bit like herding cats, you know, for a while, but she did a great job. This is really her first regional event that she's done as the regional educator, and she did a fantastic job. And some of her colleagues are sitting in the back, and thank you for greatly supporting this day, making everything look so easy. So thank you. So we will be sending likely out a needs assessment to all of you. It's very to prepare for next year. As we finish this year, we start thinking about next year. So please do fill it out when you get it. We want to make sure that we're meeting your needs, not ours. So we want to present what you want to hear. So please, when Tori sends that out, fill it out. Otherwise, have a great evening and thank you so much, everyone.